Hi everyone, I am Anna Maria Scaccia. I am a kidney cancer and thyroid cancer survivor. I am also a KCA ambassador and member of the Patient and Caregivers Advisory Council. I always get that mixed up. And I'm also the host of Kidney Cancer Unfiltered. If you haven't heard it, check it out. We're premiering season 2. We already premiered it. So welcome to our this is the first time I'm emceeing, so if I'm great, please tell me. If I'm not, you could blame my partner. He is my fall guy, just so you know. But welcome to the KCA Education event in partnership with the Judy Nicholson Foundation. I just want to welcome up our CEO and president of the KCA, Gretchen Vaughn, and I also want to welcome up, sorry, I might cry because I've known Tracy for the last 4 years. She is one of the first people I started talking to when I got my kidney cancer diagnosis at 37 in 2020. And so to be able to actually finally meet her in real life has, I don't know, again, makes me want to cry. But she is the president of the Judy Nicholson Foundation. I just wanted to welcome both of them up here. Sorry, I believe Gretchen is going first, so I will. Do you want me to put the mic back on? Do you want to hold it? How do you want to do this? I'll put it back on.
I'll probably drop it.
That's okay, I'll drop it.
Good job. Hello, everyone. It's so nice to meet you. Today, I'm Gretchen Vaughn, the CEO of the Kidney Cancer Association, and she's very much the whole reason we're here. And being able to, I don't know who all got to participate last night in the dinner, but getting to see people meet each other for the first time, this is kind of what it's about. You know, we're here to embrace and support and lift each other up. And as the KCA and Judy Nicholson Foundation, we're here to support you every step of the way, whether you're a patient or a caregiver. So thank you for your time today and for making the effort to come out. And just a quick a note of thanks to our sponsors, that we would not be able to do this and provide these resources to you without them. ESI, our gold sponsor, I think they are here in the back. So please, if you have any questions for any of them, they would love to take them at the end of the conference. And then Exelixis and Pfizer, also our silver sponsors. And Telix and Merck were our bronze sponsors. So thank them very much. And for any of you that may be on some of their treatments, this would be a really good time to enlist some information from them. So today, we have a wonderful program for you. I'm super grateful because this is the first time that we've gotten a chance to collaborate with one of our affiliates, the Judy Nicholson Foundation. And as serendipitously it would happen. A little bit about me, I was in financial services for 12 long, heinous years. Don't hold that to me. But during that time, I think everything in life, if you think about it, is probably before cancer touched your life and after cancer touched your life changes, and a lot of times for the better. Mine changed in a beautiful way the first time that I encountered cancer in my family. And with that, I started volunteering at MD Anderson Cancer Center and fell in love with the beauty and the blessings that actually come with cancer. Because I got to see and I was honored to be with the patients and caregivers at a time that was the most critical, the most personal, and time in their lives. And there's something really special about that. And to watch that transformation that families go through, it's a lot of hardness and a lot of pain and a lot of suffering, but at the same time, there's a lot of beauty and blessings and love and people coming together and supporting each other, and it's really how I think we should be anyway. Unfortunately, sometimes it takes something like a cancer diagnosis to remind us why we're here. And so during that time, I decided I want to do something here. I don't know what it is. Like I'm a stockbroker, for God's sakes. I don't know what I'm going to do. But I wanted to be a part of it, and 6 months later I got a job at MD Anderson, and I was there for 13 wonderful years. And I actually got to meet Judy and Nick Nicholson during a time around 2008 when she was diagnosed, and Florida was part of my territory. And I don't think I realized that she had kidney cancer at the time, so this is really all coming full circle. But then today leads me to today, where I was super close to one of the top kidney surgeons at MD Anderson, Christopher Wood, for any of you that knew him. And he was the chair of my organization and said, you know, at the time, KCA was one of the only kidney organizations. And what I noticed, and he was always so upset about, was that kidney was really lagging in the cancer world. And like, the research was lagging and the data was lagging and certainly the treatments. And so, and he really wanted to do something about that as his legacy, and asked me if I would consider helping. And people don't actually leave MD Anderson, so I was like, I don't know. But the more I looked at it, the more I researched, the more I realized there's so much that could be done here. And I thought that we could do big things together. And we really believed that coming together as a community, because I think part of the issue was that kidney was such a smaller disease site. And then add on to that, the rarer forms is even more so. So it really takes all of us coming together to really have an impact and move this forward. And he has passed away at this point, but I think he would be very proud of where we are today, and that 10 years ago, we couldn't say, and perhaps some of you wouldn't even be in this room had we not made the progress that we have made in the last 10 years. So we're very grateful for that. I am honored to be a part of this and to get to work with you all and Judy Nicholson Foundation. And we're really just here to connect the patients and caregivers and doctors and researchers with critical resources that are needed to improve your lives while driving innovation. So that's really kind of KCA's mission. And so with that, we have built, if you are unfamiliar with us, please stop by and talk to us. And we really try to vet all the resources out there, knowing that there's a lot that aren't that great. Google is our best friend and our worst enemy. And so we try to navigate that for you and with you. We're one of the few people who have a live human at the end of our 800 number that will hold your hand and your caregivers through the process, through your journey, connect you with resources and other organizations, depending on what your needs are. We've also created a patient assistance fund that hopefully helps with a little bit of the burden, because so much is, I mean, obviously insurance will cover your treatment, but the cost of travel and parking and all the things that you got to go through once you're there. We just want to do anything we can so that you focus more on your health and your healing while you're there. So these are just some of the things. There's virtual support groups and all the things, and you'll hear some wonderful things that Judy Nicholson Foundation also provides you. But please take advantage of the resources. We all really try to come together to provide these and continue to add to them as your needs change. And so we're always looking for feedback as well. So with that being said, I'm gonna hand it over to Tracy, and I hope I get to meet each of you today. Thank you so much.
Hello, everybody. I'm Tracy Poinier, president of the Judy Nicholson Kidney Cancer Foundation. I did write talking points, and I'm really nervous, so forgive me. I am a patient, and my journey started, I wasn't going to tell my story, but I feel like it's really important to tell my story and what led me to today. Back during the pandemic in December 2020, I came down with COVID pneumonia, and I couldn't breathe. So my husband called 911, and an ambulance took me to the hospital that day. Sorry, I'm getting emotional. I feel very blessed to be here today, and I'm honored. And fast forward, so I was hospitalized with COVID pneumonia in 2020, and he was not even able to come into the room with me, so he had no idea what was going on. And I had a CT scan done, and they found a mass, a rather large mass, and didn't tell me. They didn't even tell me. I had no idea what was happening. I was on oxygen at that time. And fast forward a few days, when I started to get a little bit better and I was recovering, a gentleman walked into the room and wrote on my whiteboard, oncologist, with a name. And I said, why did you write an oncologist on the whiteboard? And he said, nobody told you that you have kidney cancer? And that's how I found out that I was diagnosed at that point. And I called my husband and I said, oh my gosh, somebody came in and said that I have kidney cancer. I wasn't even aware of what was happening. And he said, hold on, whoa. Let me try to contact the ER. And so that's how my journey began. And I had no idea, I've never heard of kidney cancer. I thought it was, forgive me, I'm young. I was diagnosed at the age of 47. So I thought kidney cancer was a disease for 70 plus. I'm trying to be respectful and not offend anybody. So I was really shocked to hear that I had kidney cancer. I had my surgery in February 2021, and when the pathology came back, of course I ran and Googled everything. I'm that type of person that when my scan results drop and I'm waiting to speak to my oncologist, I will Dr. Google everything. So I started Googling and reaching out. I found a support group on Facebook, try not to take too much time, which really was the first point of contact, informational-wise. There was virtually no information. And so that's how I found out about Judy Nicholson Foundation, and which led me to today. I'm nervous. I'm so sorry, guys. But I wanted to say that I am grateful and honored to be here today as a patient, but also representing the foundation and meeting Anna Maria. I have been on Kidney Cancer Foundation's Association's podcast, and I have told my story many times, and I'm grateful that they've given me the opportunity today. We are not just gathered here to share information, but we are empowering each other to strengthen our community. Education is a vital tool. When I was first diagnosed, I did not have any of the information available. So I literally had to go to social media to find that. So I really appreciate everybody today coming together so we can enhance our understanding and improve the lives of both patients and caregivers. As a rare kidney cancer survivor, I know firsthand the challenges that come with the diagnosis. So it's critical that we provide the resources and knowledge necessary to navigate this journey. Our mission at JNF is to support and uplift those affected by this disease, and I'm proud to say that we are committed to helping patients and caregivers navigate their journey through providing resources. We have a podcast, Real Talk with Real Talk. We also have a caregiver support group, Pull Up a Chair, and the world famous Joel Stern is our host of Patient Open Forum. And we get anywhere from 40 to 50 patients together, and it feels like family. It feels like we can wear our slippers, we can wear our PJs, and we just talk, and we connect, and we share information. We talk about side effects. It's phenomenal. Our mission at JNF is helping patients and caregivers, as I said. So I am eternally grateful to be a part of the organization. And I want to also thank our partners at KCA for collaborating with us on the event, and to all the speakers and experts who will share their insights today. I also encourage you to engage and ask questions and connect with one another. Together we can create a supportive and knowledgeable community. Also, by fostering these connections, we remind ourselves that we're never alone on this journey. So thank you again, and for being here, and I look forward to a day filled with inspiration and valuable discussions. Thank you.
Our next speaker, Dr. Ro Arcott. Forgive me, my New York accent sometimes makes me sound terrible with pronunciation, so I'm so sorry, is a urologic oncologist at Ochsner Clinic Foundation, where he treats several urologic cancers with a focus on prostate and kidney cancer. As both a surgeon and scientist, he focuses his research efforts on early and advanced prostate cancer, as well as early and advanced kidney cancer. So I will gladly welcome you up. I want to let you work on the slides. Sorry.
All right, excellent. All right, well, thank you. I'm Dr. Ro Arcott. I'm a urologic oncologist at Ochsner, as I was introduced, and thank you for that wonderful introduction. I'd like to obviously thank KCA and JNF for putting this on, and most importantly, the patients and caregivers that are here today. I think it's really important that you guys are here because it makes an inviting welcome to other patients struggling with these issues, or other caregivers who are struggling with taking care of their family members or the difficulties they may have with kidney cancer, to feel like they can come to an event like this and learn and be more educated about their disease process. So certainly want to thank you guys for being here today. We're going to talk about Kidney Cancer 101, the basics, just kind of go over a very high level overview of what kidney cancer is. The menu, even though there's no food on this menu, is we're going to talk about what are kidneys, what is kidney cancer, are all masses, kidney masses, actually cancer or not, and how do we treat kidney cancer in very brief detail. So the kidneys are a set of paired organs. They're located in your back. They're often described as kidney bean shaped because that's where the kidney bean obviously kind of comes from, the acronym, or at least the pseudonym rather. They filter blood to eliminate waste. That's in basic what they do, and this is kind of a cartoon or an anatomical diagram of what the kidneys look like. So blood goes in, blood comes out, a certain amount of urine as waste is excreted into your bladder, and your bladder then excretes it to the outside world. So what is kidney cancer? So kidney cancer is a cancer or a tumor that develops inside the kidney, so in the meat of the kidney. Specifically in where the urine is produced in a series of tubes inside the parenchyma, or the main meat of the organ. As I describe cancer to patients, cancer is anything, at least in this case, that's inside the body that grows faster than it should. That's why it forms a tumor or a ball of cells. In the picture on the right, it has the ability to move around the body, and it's when it moves around the body that it has the potential to take your life. And I think that that's what is really important. And you can kind of see that in the picture on the right, with the cells breaking through this tumor capsule trying to get to other places in the body. Kidney cancer is quite common. There are 80,000 new cases a year. It accounts for about 15% of cancer mortality. So not a lot. We do a pretty good job at obviously curing kidney cancer, and obviously there's a range, right? Some are curable, some are not. Some are something that we treat lifelong. It's the 8th most common cancer. The lifetime risk is quite small. It's about 1 to 2%, and generally affects men more than women. And like we've already stated, as Tracy stated earlier, it affects people as they age. So, the rates of kidney cancer in the United States are quite common, in certain areas more than others. This is kind of a heat map of where kidney cancer lies across the United States, and if you look in particular at Louisiana, we're obviously very affected. So, you want to be, this is a good place to start when you're learning about kidney cancer and maybe your journey. So how do I get kidney cancer? What happens? We talked about there's 80,000 new cases, but it's pretty rare overall. How do I get it? How am I at risk? And there are definitely modifiable risk factors and non-modifiable risk factors. The modifiable risk factors that we know about include smoking, obesity, high blood pressure, and consumption of alcohol. And then there are non-modifiable risk factors. So these are things that we're born with, things we can't change, such as our genetics, our family history. So if our mother, father, brother had kidney cancer. Hereditable syndromes. So these are things where there's a constellation of symptoms that we might have associated with many other disease processes that also increase our risk for kidney cancer. Gender, as we just spoke about, males more than females. Race, certain races are more affected than others. Sickle cell trait disease, and even being on dialysis. So this is just a list of the hereditary syndromes associated with kidney cancer. I'm not going to go through each one of them or the constellation of symptoms associated with these syndromes or manifestations, but I just wanted to put this up here, and if you're one of these people or have been told that you have one of these syndromes, certainly want to talk to your doctor about possible screening and things like that. So what are the symptoms of kidney cancer if I'm going to have it? Well, flank pain is one of them. Blood in the urine. This is probably the most common that we see today. We call it hematuria. It would look a little bit like this, if you were peeing bright red blood. But it doesn't always have to be bright red blood in the toilet. Sometimes it's blood that's seen on a lab test, seen under a microscope. So you might pee in the toilet, it may be yellow, but your doctor says, hey, actually there are red blood cells in there, and maybe you want to get checked out for something like kidney cancer. A palpable mass, and even fever. Now, the vast majority of kidney cancer is not found with any of these symptoms. It's found incidentally on imaging, and it doesn't present with any of the things that we talked about. It could be completely silent. You may be walking around one day and get a scan and go, man, I've got kidney cancer, I didn't even know it. As Tracy pointed out earlier, she came in for a problem of shortness of breath and found that she had kidney cancer, so it doesn't necessarily present with symptoms. And like other cancers, like prostate, colon, breast, there are no screening tests that we routinely use for kidney cancer unless you have one of those hereditable syndromes that we discussed earlier. So this is the doctor's most favorite friendly machine. This is the CT scanner, and this is how we most often diagnose kidney cancer today, because people come in for a cough, cold, nausea, vomiting, chest pain, shortness of breath, and they get a CT scan and they're found to have a mass on their kidney. This is an image on the left of what a kidney mass would look like on a CT scan. This is what your doctor might show you in clinic. I think one of the things that I always wonder is, what's the patient thinking when they see that? They're always kind of wondering, well, what does that look like in my body? And that's the picture on the right. So it's this ugly looking tumor in the kidney on the right. You can see it's ugly enough that we probably want to take that out. And that's sometimes what we do. Now, every time you get a CT scan and there's a report of a mass on a kidney, it's not always kidney cancer. The most common mass that we see on a CT scan when a mass is identified is actually a renal cyst. And this is what a cyst looks like. A lot of my patients are like, what is that? Is that going to go away? Is that going to stay around? And the answer is, we don't always know why these form. The vast majority are benign. They don't carry any malignant potential because they don't have any solid components within them. We often describe them as water balloons, and unfortunately they don't go away. They usually stick around, okay? But usually that's just okay. Now, not all cysts are the same, so while the most of them are benign or not cancer, you should get them checked out by your doctor. So here's a list of benign renal masses. There's a lot. This isn't a comprehensive list. This is just some of the most common ones that we know are benign that are found in the kidney. So not every mass on your kidney is a cancer. Not every one needs to be treated the same, and not everything needs an aggressive treatment. So how do we know if something's cancer or not? Well, there's a couple of imaging characteristics that we use on CT scan to identify something as a cancer, and one of them is whether it's solid or cystic, like we just talked about. Solid being having some solid component and cystic being fluid filled. Enhancement or hypervascularity. This is something your doctor may talk to you about when he looks at your CT scan. The image on the left is without contrast, which is given through the vein, and the one on the right is with contrast, given through the vein. And what we can see is that this tumor with the arrow in it lights up like a light bulb, and that's a definition, or that helps us define hypervascularity within a tumor, suggesting that there's a lot of cells, they want a lot of nutrients, and they want to grow. All kind of signs of cancer are bad things. The other thing is size. So increasing in size is associated with a greater risk of malignancy. So small masses, 1 to 2 centimeters, may not be cancer. They might be benign. Something that's 10 centimeters, probably more likely to be cancer, but not always the case. So what about biopsy? I mean, do we only use imaging characteristics to identify cancer? That would be kind of odd. And the answer is no. Sometimes we use biopsy. We don't always, because in most cases we don't need a biopsy to determine that something needs to come out. And some of the treatment options are very safe and provide low morbidity to patients, so we just go ahead and treat. But I do want to talk about biopsy and let patients and caregivers know that it's safe. It's about 80% accurate. It's got less than a 5% risk of complications. And there's virtually no risk of spreading the tumor as we know it with modern techniques employed today. So, biopsy is a good thing, and you should ask your doctor about it if you feel like it's necessary. This is just a cartoon of somebody in a CT scan getting a biopsy of their kidney tumor. So what about cancer staging? Everybody wants to know about cancer staging. It's important. It's what we know. It's like what we learn about cancer when we're 3 years old. Like stage 1 is good, stage 4 is very bad. This is kind of a very simple diagram of what the stages are for kidney cancer, but stage 1 is generally small and it's confined to the kidney. Okay, stage 2 is larger, still confined to the kidney. Stage 3, we're talking about bad business. It's starting to go through the kidney into the fat, maybe into some of the veins, or even into the big vein that carries blood back to our heart. Okay, and then stage 4 often describes distant spread of the cancer. So we're talking about lymph nodes, other organs, liver, lungs, bones, things like that. Okay, and each one of them is obviously treated very differently. So once I have a diagnosis of kidney cancer, it's very important that you understand what the histology is, and your doctor will talk to you about it, because really there are lots of different versions of kidney cancer, and these are just some of them up here, and there's even more than this per the World Health Organization. They have like 20 different types. But at the end of the day, clear cell renal carcinoma is the most common. Some of these are less common, and they're all treated slightly differently based on their presentation in the metastatic setting or when the cancer's moved outside of the organ itself. So it's important for you to understand this and talk to your doctor about that if that is the case for you. Okay, so I've got kidney cancer. What do I do now? I think the most important thing is obviously to find a urologist. They're the ones that treat kidney cancer and can help you find a medical oncologist, a radiation oncologist, somebody to do a biopsy or whatever it may be. And you really got to find somebody you feel comfortable calling on in times of need. At the end of the day, things don't always go well with cancer, whether that's surgery or medicine. There's side effects, there's complications. And you want somebody who's going to sit there and dig in with you when times are tough, because at the end of the day, it's not always rainbows and butterflies like the Keytruda commercials that we see. You want to talk about the management options. There are many, and we're going to hear some other speakers today talk about active surveillance, which is just watching the mass. Sometimes these masses grow very slow and don't need treatment. Ablation, burning or freezing of the mass. Surgery, taking out just part of the kidney, which is the tumor, or taking out the whole kidney. And even radiation, which is kind of new on the horizon. It was done many years ago and kind of back in favor. And then finally, stage 4 cancer, you're going to need systemic therapy, so we want to treat the whole body. You're going to need infusions and oral medications to treat the whole body, because it's not just the kidney that we're trying to focus on. And that's important to be done in a multidisciplinary fashion between all of the doctors that you can hear from today. Surgeons, oncologists, radiation doctors, etc. And lastly, shared decision making. So there's no one size fits all, okay? I think all the patients in here have the same story in that they had a diagnosis of kidney cancer, but the journey along that time point to where they are now is very different. And so I think it's important that you find somebody who can talk to you about all the options available. And if your tumor's complex, you should find a surgeon with experience treating complex kidney tumors. I don't think it's wrong for patients to ask, how many of these surgeries you've done, how long you've been in practice. I think it can be obviously off-putting to many doctors, but listen, it's your life that you're putting in their hands. It's important for you to know what you're getting yourself into. So in conclusion, kidney cancer is a tumor that starts in the kidney and has the ability to move around the body. That's what defines a tumor versus cancer. It's when it moves around the body that has the potential to take your life. There are no screening tests that are routinely performed unless you have a hereditable syndrome. And kidney cancer is most commonly found incidentally, so it's not found with the signs and symptoms that we talked about. Most kidney cancers these days are curable. I think that's important. Though when they spread outside of the kidney, they can be more challenging to treat, still manageable, but more challenging to treat, and sometimes involve a multidisciplinary approach involving radiation oncologists, medical oncologists, and surgeons. So I hope that helps set the stage for the rest of our talks today. This is my email and my cell phone number if anybody has any questions or would like to reach out to me. But again, thank you to our sponsors, KCA, JNF, and all the people here today. Happy to give this talk.
It's my pleasure to introduce Dr. Mary Beth Westerman. She is an associate professor of urology at LSU Health Science Center, New Orleans. co-director of the urological, that is a hard one, oncology and residency program director. In her current practice, she treats patients with all urologic cancers utilizing both open and minimally invasive approaches. Her practice emphasizes access to and enrollment in clinical trials where appropriate. So Dr. Mary Beth Westerman, if you could come on up, I'll set the timer. And I believe your clicker is right here.
Thank you so much. All right. Thank you so much, and it's a pleasure to be here today. I had the privilege of training with Dr. Chris Wood at MD Anderson. I was one of his last fellows, and I know he'd be so proud of all the work that's carried on and continuing to go forward. So I'm going to talk a little bit about the surgical options for kidney cancer. And Lee, I think there's a couple of things just to keep in mind with this talk. There are very few absolutes with anything in medicine, so some things I'll talk about are the different things we consider and talk about with patients, but for everything I say, there's usually an example or an exception to the rule. Surgeon outcomes vary, and there's rarely one right answer for anything. So we're talking about who should have surgery, the different techniques, methods, approaches, what to expect after surgery, and then which type of surgery is right for me. So like I said, every surgeon is different. As Dr. Arcott had mentioned, different surgeons have different experience, they have different comfort levels and different outcomes, and you should never be afraid to ask your surgeon, those questions. And just like every surgeon is different, every tumor is also different. So these are just an example. These are small tumors, small renal masses. You can see sometimes they're kind of dangling off the meat of the kidney. Sometimes they're real deep inside the kidney. And those things make the difficulty of the surgery very variable. And those are things, again, that your surgeon should talk with you about why they may be recommending a certain treatment approach. And really the goal that I have for every patient that comes to see me is to do the right surgery for the right reason for the right patient. And the reason for that is that we know, my little picture didn't show up, right, the risks, we have to balance the risks of intervention with the risks of disease. Everything we do surgically has a risk. And not all kidney tumors have the same risk of spreading or being cancer. And so those need to be balanced. All right, so when do we consider doing surgery? We talked a little bit about active surveillance, really when tumors are too big to safely continue to watch them, which again depends a little bit on who you ask, how old you are, that's somewhere in a 3 to 4 centimeter range, sometimes smaller. Patients really want to make sure that people are healthy enough for surgery. Surgery is an invasive intervention. The last thing we would want to do is have some sort of a complication from surgery or anesthesia when it wasn't really necessary in the first place. I say no sign of cancer elsewhere. There's a lot of nuance to that. In general, when we see stage 4, we see signs of cancer that have gone to other parts of the body. In the past, we used to just say, oh, everybody still gets surgery, we're going to go to the OR, that's what we do. And really, they've become a lot more nuanced in that, and that's really where I think a multidisciplinary team is really important to decide, should we be sequencing surgery? Should we try systemic therapy first? And then also for symptoms. So sometimes there may be some cancer that's somewhere else, but people are bleeding and can't get out of the hospital or in pain, and at that point, sometimes it's also time to consider surgery. So there's really two main types of surgery that you'll hear people talk about. It's partial nephrectomy or radical nephrectomy. I really think that comes down to how much kidney are we going to preserve? Are we just taking out all of the kidney in a radical nephrectomy, or try to do a partial nephrectomy and preserve some of that healthy kidney tissue? Once you've decided that, how much kidney are we taking? The next question is, how are we going to do it? So it can be done open with a big incision, robotic, or laparoscopically. And then how are we going to get to the kidney? So the kidney actually is in the back on the side. So there's actually multiple ways to get there. You can go through the abdomen where all the intestines and the bowels are, can actually go through the side or through the back and stay out of the abdomen. So there are multiple approaches, and for some patients, one approach is better than, or maybe better than another. So with a partial nephrectomy, that's where the goal is to take out the kidney tumor and a small margin of normal tissue. In some cases, even we can really just shell the tumor itself out with removing very little of that normal kidney. And you can see an illustration here. Once that kidney tumor is taken out, we've got to put the kidney back together. And so that involves putting stitches back into the kidney. And see, when you still have your kidney there and you're reconstructing something, there's actually a higher risk of complications with taking out just part of the kidney than there is with taking out the whole kidney. And so in a radical nephrectomy, we just take out, the whole kidney would come out, with or without the adrenal gland, which lives right above the kidney, and in some cases would take out lymph nodes as well. Because the whole kidney comes out and we're not sewing things back together, there's less of a risk of having complications from that remaining kidney in the postoperative period. The downside is, of course, with taking out the whole kidney, you lose an entire organ, right? And so with just removing a tumor, you're going to preserve a lot more of that kidney function. And there is a risk of local recurrence with partial nephrectomy, right? It may be low, but the kidney's still there. There's a chance of leaving positive margin and of a tumor coming back in that same kidney. With the radical nephrectomy, like we said, it has lower complications in the surgical period, but you're losing an entire organ. And so I think the conversation, again, it's very patient-driven, and what it kind of depends on the patient's different characteristics. But for smaller tumors, really we try to favor partial nephrectomies. And for younger patients and patients with hereditary cancers, because the younger you are, the more likely you may be to develop another tumor in the future, right? Or that you may have one of those hereditary kidney cancer syndromes. And we know that, again, that kidney may be at risk of growing another tumor, your other side may be at risk, and so preserving as much of that normal, healthy kidney as we can is really important. When the tumors are larger and they start to grow into the fat around the kidney, into the veins that come from the kidney, that's really when a radical nephrectomy is favored, because it would be too difficult to actually be able to get the tumor out and preserve much of the kidney that was left. And then the people who have impaired or kind of baseline kidney disease, where the kidneys maybe don't function great to begin with, we tend to favor doing partial nephrectomies in those cases as well. I find these can be some of the most challenging conversations, though, because a lot of times people whose kidneys aren't functioning that great to begin with also have other medical problems that may make surgery a little bit more risky and may put them at a little bit higher risk of having a complication like bleeding or something like that after a partial nephrectomy. And so, how much kidney do we want to remove? And that, again, these are just a few of the things we think about, but is a tumor limited to the kidney? Has it spread? Are there multiple tumors? How much normal kidney would be left behind if we were just to remove the tumor? Are other nearby tissues affected? What is the overall kidney function? And are there other diseases affecting the kidney function present as well? And what I always tell patients is really the recovery time, though, from surgery depends more on how we do the surgery than how much kidney is removed. So once kind of made the decision of are we going to do, how much kidney are we taking out, the next step is how are we going to do it. So open surgery, you can see in the picture here, that's a lot of times that's done, that's a big incision, that's like the railroad track on the belly. And that's for larger tumors where the tumor is starting to grow into that big vein, into the vena cava, or tumors that are really complex. Minimally invasive surgery is great, but sometimes if the tumor is so big, you'd have to make an incision, this long to get it out anyway. A lot of times it may make more sense to just use an open approach. Laparoscopic surgery. So when we use this type of an approach, the surgeon usually will make a few small cuts on the stomach and use a camera and instruments, but stand at the bedside. So the surgeon standing right next to the patient and using those instruments to get the kidney out. This does have smaller cuts and a shorter recovery time. This is typically only used for people who are having their whole kidney out. For a while, people were doing those partial nephrectomies laparoscopically. I would tell you I couldn't do one laparoscopically, and I don't know that there may be a few people out there that can, but it's a very, very challenging thing to do because it's very hard to sew a kidney back together with sticks. Those instruments they don't move like this, like your wrists would. And so really if someone's discussing laparoscopic surgery, it's typically taking out the entire kidney. And then robotic surgery, which I'd say is probably the most common approach that we use now. This is usually done with a Da Vinci robot. It's a picture of the robot here. And it's similar to laparoscopic surgery where you get a couple small incisions on your belly or on your side. But the surgeon isn't standing right next to the bed. They're sitting over at a console. They're sort of sitting over in the corner, and they can use wrists, and so they can drive all those instruments that are inside the belly by using their wrists on the console. And then in studies they have shown this has less blood loss, shorter hospital stays, fewer complications compared to open surgery. And I think really, again, it comes back to what is your surgeon comfortable with and recommending. There are multiple ways to get to the kidney, and I think the people have different experiences and comfort levels doing more or less complex tumors with different approaches. And so I think those are all questions again, to have with your surgeon. In terms of recovery, the other things to ask surgeons: how long is your surgery going to take? How long are you going to be in the hospital? When can I drive? When can I go back to work? What is the most important thing I can do after surgery? And again, this also is variable, but in general, after a kidney surgery, stay in the hospital anywhere from 0 to 5 days, depending on how complex a surgery it is. I actually send most of my patients home the same day now, because I think being at home is better than being in the hospital. But when there's big open, big incisions, sometimes that needs a day or two in the hospital, just for pain control and to make sure things are moving, people are moving around okay. Return to activities, again, may be a variable depending on how big of an incision that you had, how complex the surgery was, but I'll tell people, for my patients, I tell them as soon as you feel ready to go back, I'm good with you going back. If you had a big incision down the belly, sometimes it'll be 6 weeks, not lifting anything real heavy. In a full recovery, anywhere by, say, 2 to 8 weeks, again, there's always people at that far end, right, of the curve where you're in the hospital for a long time. There were complications, and in those cases, of course, it's going to take a little bit longer. This is just I think my patients and all my residents make fun of me a little bit for this. I think the most important thing anybody can do around the time of surgery is walk. So you walk before surgery. I tell them the best thing you can do to get in shape for surgery is walk, and the best thing you can do after surgery is get up and walk. I tell them that when people go home, that the walk to the car is a therapeutic walk to your car. I think the more you move around, that's what the body is meant to do, and it really gets bowels moving again. It helps the pain, soreness, all of those things, and it really helps people get back to feeling normal and like themselves again quickly. In summary, I think we said that I have very few absolutes, right? But in general, we recommend partial nephrectomy over radical nephrectomy for smaller tumors. I think if you're seeing a urologist and they're telling you the whole kidney needs to come out and it's a smaller tumor, that's something where you say maybe, should I get a second opinion? Because maybe I'm seeing someone that doesn't do a lot of these, or they're just not comfortable with it, and we should look at whether it makes sense to try to save some of my kidney. Partial nephrectomy has a higher complication rate. They can all be managed. My patients all have my cell phone number after surgery, and I tell them if you start peeing blood 10 days later, or you start having fevers, you got to call me because something isn't right and we need to do something about it. But it's all very manageable. And then we open surgery typically for very large masses or complex masses when there's a tumor thrombus. And really, once recovered, there's no long-term impacts on your quality of life from having kidney surgery, as long as you've got enough kidney tissue that's left that your kidney is doing what it needs to do, filtering the blood. And then the other thing I say people will ask is, what can I do in the future to prevent kidney cancer or prevent something from coming back? And I say the most important thing you can do after we've treated a kidney cancer is to keep your kidneys healthy. And the way to do that in the long term is to keep blood pressures under control, keep blood sugar under control. So if you've got high blood pressure, take your medication and walk. That's what is best for keeping the kidneys happy and healthy long term. And I think that is the most important. So happy to give you guys a couple minutes back so we could save those for the panel at the end. And thank you again for all being here today.
Thank you for that wonderful. I actually have a lot of questions too. So our next speaker is Dr. Kyle Rose. He is a urologic oncologist at Ochsner MD Anderson Cancer Center. He is a clinically active in all types of urological oncology, and as a surgeon scientist, his research has focused on bladder and kidney cancer. So,
hey, good morning, everybody. Thank you all so much for having me. Give me 1 second. I really want to mirror the things that Dr. Westerman, Dr. Arcott said. I think when I hear their talks, it's like music to my ears. I think we trained in a very similar generation, and we have very similar views on how to take care of patients. I also want to mirror all the great things they said about patients advocacy and your presence here. And one thing that I will add that I say a lot in my clinic is not just the patients with cancer, but the families of those patients. There are times where we have canceled major surgeries because patients didn't have the family support. And when I really look at my patients who have flown through big surgeries or done extremely well, a lot of that is owed to their family support to help get those patients up and moving. And so not only for the patients and survivors here, but for the families, thank y'all very much for your support, because this is a total team effort. I get to talk today on liquid biopsies in RCC. The title of this study, of this presentation, was actually how can we detect kidney cancer, and we'll go through some of the nuances of that. And I hope I portray or get across how excited I am about these. This is like the next frontier for us. I mean, this is so promising, and I would say an absolute goldmine for physicians, researchers, and patients. And so I really hope that comes across, and I will apologize for some of my examples that I use, but I want you to know how I think of these things. My current disclosures, I get research support from WHOOP, nothing that is specific to kidney cancer. So what is a liquid biopsy? I think we're very familiar what a biopsy is. It's a sampling of tissue. Usually that is from a surgical specimen, or a percutaneous biopsy for a kidney that would go in through your back. A liquid biopsy really is what it sounds like. We're taking some sort of fluid from the body and then trying to determine biopsy characteristics like a genomic profile or a tumor of origin. And so this is I would say this is the gold standard for a biopsy, and that's a surgical specimen. A whole kidney, as shown here on the right side, that has been taken out. You can see on the upper pole, or the upper half of this kidney, there's a gnarly tumor. And taking that kidney out is not only therapeutic, but it also provides our pathologists with the most information possible and allows us to do the most genomic profiling on that tumor. So surgical pathology in terms of biopsy is really our gold standard. We can also get biopsies percutaneously through the back, and typically this is done under imaging guidance, usually ultrasound or CT scan. And if you think about how big an apple is, when we take a biopsy of a tumor specimen, we're taking out a very small sample. So there is a item or an issue of sampling error, but we find that with contemporary techniques, biopsy accuracy has been increasing over the last 20 to 30 years. So a liquid biopsy, on the other hand, is non-invasive by definition. It's using fluid that is from somewhere in our body, and then we're able to determine the genomic profiling based on that sample. And so for various different types of tumors, there are different sources. So we can detect these in the urine and blood for kidney or bladder. For pulmonary tumors, they can get secretions from the lungs. And for GI tumors or colon cancer, we can actually get it from the stool. These liquid biopsies, what are we actually detecting? There's several variations on this menu, but the ones we'll really focus on are circulating tumor cells and cell-free nucleic acid, which I think is where the most promise is and where most of my excitement comes from. But I think we have to be really specific and careful with what question we're trying to ask. So the title of this presentation was Detecting Kidney Cancer. We're not necessarily there. We are not to the point where we are checking our blood samples of patients to determine if you have kidney cancer, okay? So it's used in a much more specific way. So what's the question we are asking? We are trying to risk stratify patients using these liquid biopsies. In other words, determine how advanced is the disease that we already know about. How high risk is that patient for recurrence or metastasis? It also allows us to identify patients who have had a complete response to therapy. That can be immunotherapy or systemic therapy or surgical therapy. We can also monitor patients while they're on therapy, identify patients that recur before a CT scan shows us, and to monitor the tumor while you're on therapy, meaning that how is that tumor changing while we're getting treatments, and can that show us a future direction of how we may need to change treatment. I use this example, and this is one of the first examples I will apologize for. I use this example in my clinic all the time. Cancer is like an anthill, okay? So when we do a CT scan and we see a tumor or a lymph node or metastatic disease, in my mind that is an anthill, right? The tumor cells are the ants. It takes millions or hundreds of thousands of ants to form an anthill, and so it takes millions or hundreds of thousands of cells to form a enlarged lymph node, a tumor, or a site of distant spread. And I think about my kids when they leave apple slices on the floor in the house and there's an ant, you know? Just because there's no anthill doesn't mean there aren't ants, okay? And I've never found an anthill in my home, but I see ants all the time thanks to my kids, okay? So this theme comes up a lot in how we manage patients and how we explain to patients. And kidney cancer aside, when we explain we're gonna give bladder cancer patients chemotherapy before surgery, I tell them that the chemotherapy is taking care of the ants, the surgery is going to take care of the anthill, okay? So the most direct example of this is circulating tumor cells. These are actual renal cell carcinoma cells that are detected in the blood. And this is a study that had examined 195 patients who were receiving systemic therapy. And so again, this is whole tumor cells that are detected in the blood. Only 46% of those patients with metastatic RCC had a circulating tumor cell that was found. And then when we break down the patients that had 3 or more circulating tumor cells, those patients had a worse survival. And I think that makes sense, right? If you have more ants getting out of the anthill, that is likely to portend a poor prognosis. And this shows some of the survival of those patients. Now keep in mind, these are all patients with circulating tumor cells that were detected, so 0 to 2 versus 3 or more, and their progression-free survival, the amount of time that they lived without their cancer progressing or getting worse, was worse if they had more circulating tumor cells detected, okay? So circulating tumor cells. What I'm most excited about and what we'll cover about the most are cell-free nucleic acid studies. And it's important to know these are not necessarily all from the tumor. And you'll hear us talk mostly about circulating tumor DNA. Most of our cell-free nucleic acid in our bloodstream is actually derived from our own bodies, and it's from our white blood cells. And we'll see in a couple slides what the fraction that is derived from the actual tumor is. But in order for us to do a liquid biopsy, we also need to have some sort of germline testing or our blood tested to determine, for example, if I had a kidney cancer, what percentage of that DNA in Kyle's bloodstream is just Kyle, or how much of that is from Kyle's kidney cancer or kidney tumor. And this is the second example I'm going to go ahead and apologize for. And this is really how I feel or how I think about ctDNA and how this works, okay? So ctDNA is where we take a person who we know has a tumor of some sort, and we are trying to determine are there mutations peripherally in the bloodstream that we can detect that are not from the patient but from the tumor itself. And I think of this in terms of us trying to identify a song. That is the goal. There are multiple aspects in the anatomy of a song. There's a drum line, there's chords, there's melody, there's lyrics, okay? So if we assume that the primary tumor, like a kidney cancer, is an artist, we are given fragmented lyrics and we're trying to identify the song. So I plug this into ChatGPT, okay? This would be a tumor-naive approach. That means that we don't know what the primary tumor is. We don't know the profile of that tumor. All we know is there's a kidney mass, but there's no biopsy, okay? So if I plug this into ChatGPT and the fragmented lyrics we're given is that we know it's a country song, I lost my girlfriend, lost my truck, lost my job. That can be almost any country song, right? So it's not very specific, but it's very sensitive. It detects a lot of options, but it doesn't really help us to precisely nail down one song or one type of tumor, okay? What if we change again, I'm apologizing. What if we change the genre, okay? What if we say it's a hip hop song now and it's about butts and it's written to the opposite sex, okay? Again, we get a lot of options, less specific but very sensitive, okay? So this is a tumor-naive approach where we don't know what the primary tumor is. What if we told you that the artist was Sir Mix-a-Lot? There's only one song that we all know that could be. So it really helps us to nail that down. It's too early to sing that song. So using a tumor-informed approach is much more specific and helps us to nail down the mutations that are detected in the blood that are derived from the primary tumor. Where this gets a little more tricky is what if we know what the primary tumor is and we identify those mutations. There's still variability depending on the question we're asking. And this is my example I give too, is that what if we knew that the primary artist is Red Hot Chili Peppers and the lyrics contain California? Well, I mean, that could be 12 songs, 5 albums, right? So it really depends on the question that we are asking. So I use this slide to illustrate that the importance of using a tumor-naive approach versus a tumor-specified or tumor-specific approach. So this is circulating tumor DNA. This is where we hold most of our promise, okay? If we do not know the mutational landscape or the genomic profile of that primary tumor, detection rates for ctDNA are very poor, all right, and it's only about 30 to 27%. So it's very important that moving forward, we use a tumor-informed approach or a bespoke assay specific to the primary tumor. This is a study that had analyzed patients with circulating tumor DNA, and I think what we'll see as a general theme for circulating tumor DNA across multiple cancer types is that patients with more advanced disease have higher tumor signal and we're more likely to detect circulating tumor DNA. And this has shown that patients with higher tumor burden, meaning more masses, more lymph nodes, more sites of metastatic disease, were more likely to have detectable ctDNA. So this is showing 8.8 versus 4.5 centimeters when we take the aggregate of all of their masses, lymph nodes, and tumors. Patients who are ctDNA positive had a larger volume of tumor. And what's most important there is that most the patients with larger tumor burden that were ctDNA positive also had a larger number of genomic alterations identified. And that means that we know what the mutations are in that tumor, and that could help to direct therapy down the road. Not all circulating tumor DNA assays are necessarily on patients with metastatic disease. This is a study of 45 patients that had renal cell carcinoma completely excised. So patients at the end of the day after surgery, we think would be surgically cured. And again, back to the ants on an anthill example. We've taken out the ant hill. We don't think there's any ants left, but we're going to watch those patients. And they use a tumor-informed approach for ctDNA. ctDNA was detectable in 18 of those 36 patients, so half. And patients who were ctDNA positive had a higher tumor size and grade. And patients who were ctDNA positive after what we thought was a curative surgery had a poor relapse-free survival if that ctDNA was detected at any point. And there's a sensitivity of that of 84% with a positive predictive value of 90%. So in these patients, in that clinical scenario, we take out their tumor, but they're ctDNA positive at any point. That is 100% positive predictively for a tumor recurrence later. And not necessarily in the renal cell carcinoma data, but in bladder cancer, we've actually found that ctDNA detection after surgery will precede imaging findings by about 3 months. So imagine you get these scans done every 3 months after surgery, and we have a tumor marker now that's just from your bloodstream. And again, this example is in bladder. This hasn't been shown yet in RCC, but we could detect a recurrence of tumor before the CT scan. So that's, in my mind, very cool and can drive us putting patients on adjuvant therapy or salvage therapy quicker. This is an example really just to illustrate what we are finding in these studies or in these assays. We're finding multiple genes present in the primary tumor in the peripheral blood, and the reason this is important is some of these mutations are actionable. That means we have medications that can be directed at these tumors, so we have an idea of a susceptibility profile. Like if you get a urine culture, it grows a bacteria, we know what antibiotics work against it. This could be similar in the future as we develop new targeted drugs. This slide is just showing the patients who are ctDNA positive versus those who are ctDNA negative after their curative intent surgery, showing that the survival outcomes for patients who are ctDNA positive were poorer compared to those that were not. But what I would really illustrate here is that even in patients that were ctDNA negative, some of them can still have progression or a recurrence. So ctDNA is not necessarily perfect, but it's very promising and it's new, extremely exciting, and it has the ability for us to further the patient care in a very precise way. This study had actually analyzed patients based on their ctDNA profile compared to radiographic findings. And although this is a very exciting field, it really hasn't worked its way into standard of care or into national guidelines quite yet. Many of us use these studies in our practice, especially for patients with advanced tumors. But this is showing that patients who are ctDNA positive were more likely to have radiographic signs that correlated with that positivity. And so this study was able to correlate or discriminate patients that were going to have progressive disease, partial response, or complete response based on their ctDNA. And recall that I had mentioned the percentage of our ctDNA or cell-free DNA in our bodies being derived from the tumor versus derived from our own bodies. The difference in someone who is high burden versus low burden, when you consider the total amount of cell-free DNA, it's 0.3% is considered to be high versus 0.03%. So again, really critical that we have a patient's blood sample to know what is Kyle versus what is Kyle's tumor. And this is showing the difference in patients who had progressive disease while being monitored versus those that had a partial response or complete response, showing that they had a lower percentage of cell-free DNA derived from the primary tumor. Again, this is a study on metastatic RCC patients in patients that had gone through treatment, and now we are using ctDNA as a profile to monitor patients and what changes are occurring in their detectable peripheral plasma. So 78% of patients in this 220 subject study had a detectable ctDNA, and this is in the metastatic setting. 64 of those patients had disparities in their genomic alterations after first-line therapy. That means that we have an idea of what they are before treatment or before systemic therapy. We treat them, and now we have a profile afterwards. And so we can see how the tumor is evolving and how the tumor is responding to that drug. And again, that gives us hope that we are selectively eliminating the tumor cells for which the systemic therapy is effective, and can also show us what the tumor will be susceptible to after that treatment. The largest differences in the study were actually seen in patients that got VEGF inhibitors. We still use these drugs, but this is one of the later, I would say one of the earlier studies. We're typically using now more immunotherapy, but still the concept being that we are seeing differences in the tumor and how the tumor reacts while on treatment. Again, using a circulating tumor DNA in metastatic patients. This was a pilot study analyzing 20 patients who had their kidneys removed. 45% of those patients were ctDNA positive, and they studied ctDNA levels before and after immune checkpoint blockade. And the reason why I included this study is that immune checkpoint blockade is really the mainstay of treatment now for RCC patients who have METs. And this really elegantly showed what this kinetic profile will look like, where we have ctDNA that is detectable, we put them on treatment, and that ctDNA decreases with time. That usually correlates with a good response. On the other hand, we have patients that have ctDNA that increases with time. That tells us that they are not responding to immune checkpoint accurately or the way that we would like, and that allows us to pivot and shift our therapy if needed. So, in conclusion, liquid biopsies hold tremendous promise in the diagnosis, prognosis, and response to therapy, and the recurrence of RCC. There are multiple modalities or assays used. I think ctDNA is the one we are the most excited about and has the most ongoing efforts in this space. There has been constant improvement in assay technology and detection over the last 5 to 7 years. I think what is most important to all the people in this room, myself included, and I should have included the slide from the FDA, but that multiple clinical trials are ongoing right now and are including these assays. And that is genuinely a gold mine to our knowledge and ability to understand these tumors. In that all ongoing trials, not all, but I would say most ongoing trials that are evaluating novel agents are using these assays so that we can better define patients that respond or patients that we need to shift treatment in. So with that said, I wanted to thank you all for having me today. I apologize for the examples, but I will answer any questions that you may have, and please don't hesitate to reach out to us. So thank you.
Before I introduce our next guest, I just want to, I don't know if it's a good joke, but I just want to say, what is one way you could spot an elder millennial in the room? They cite Sir Mix-a-Lot and Red Hot Chili Peppers in the same thing, so I get you. So I wholeheartedly apologize for butchering your last name if I do. But yes, I'm going to invite Dr. Sid Padmanabha. Perfect, okay. He is a radiation oncologist affiliated with LCMC Health with over 2 decades of experience in radiation oncology. He has been a vital part of the New Orleans medical community where he has built a reputation for excellence and compassion. And I will welcome Dr. Sid Padmanabha.
Yeah, thank you very much. I appreciate you all. Thank you for being here today on a really nice Saturday. My name is Sid Padmanabha. I'm a radiation oncologist at LCMC. These are this is kind of the historical thing about kidney cancer. Radiation therapy does not work on kidney cancer, or as the doctors say, renal cell carcinoma is radioresistant. I put a picture of the Karate Kid. And I put that picture there because he's from the 80s, and I think a lot of this data that came out was also from the 80s. 80s was a good time. I grew up in the 80s, but the trials were kind of like the Karate Kid before he had trained as a freshman. So radiation oncology, what is it anyway? Radiation oncology is there with surgery, chemotherapy, immunotherapy, targeted therapy, has an option for cancer treatments. Most commonly, the patient goes into a room and the tumor is targeted. A large machine, linear accelerator, sends radiation therapy towards the tumor. This is usually done as an outpatient setting, and it's usually done for both tumors and areas at risk. So I'm going to talk about some of the new and emerging treatment options for kidney cancer. I'm going to talk about 2 things. The first thing is something called SBRT. We'll call it radiosurgery from now on. I'm also going to talk about what's new on the horizon for kidney cancers. Radiosurgery is the way to treat kidney cancer if you're using radiation therapy. What it is, if you look in the NCCN guidelines, they call it as a preferred modality for most instances. This is a highly precise, very specific, high dose of radiation therapy. It's designed to overcome some of the biological resistance and treat the tumor very effectively. So the old way radiation therapy was done would be to define a geography and treat everything in the field. On the right-hand side, you see kind of older style radiotherapy. The tumor's there, but there's also some normal tissue in the field. And that would be done slowly. It'd be done slowly because you want the normal tissues to be able to regenerate. Nowadays, using radiosurgery, radiation therapy is done in a very precise way using very limited treatments. The treatment on the left there is done in basically 2 treatments. It's done very effectively because it has the tumor volume at risk. The normal tissues are out of the field for the most part. So I'm going to talk about using radiosurgery for early kidney cancer. This is a relatively new treatment that's very exciting to us. There have been about 9 or 10 clinical trials, high-quality trials that show this approach to be effective. This is a trial that came out very recently in Lancet Oncology. And I like this trial because they looked at the whole patient. They looked at disease progression. They looked at kidney function. They also looked at kidney function per kidney. And they checked all this data in a very thorough way. If you look at kidney function, as you can expect, in older patients with renal cell carcinoma wasn't the best, but it fared pretty well over the years. Kidney function held up after treatment with radiosurgery. We also saw that when you treated one kidney, because it had tumor, the other kidney compensated, and overall, this helped preserve kidney function. If you look at side effects with radiotherapy, they were very manageable. Patients who had radiation therapy for their kidney cancer got a little tired, but that recovered. A lot of patients kind of felt something was happening in the flank. So did it work? In this clinical trial, it worked pretty well. The average size of a kidney tumor was between 4 to 5 centimeters, and these were significant kidney cancers. In about 70% of cases, these were kidney cancers that were watched and they had grown. So I think this trial wouldn't be meaningful if these were insignificant, very small kidney cancers. These look like these were significant cancers that had increased in size. And this was the results. It looks like control for kidney cancers was very good. Patients were followed on average between 3 and 4 years, and local control was very good. Local control doesn't mean much if the patient's not cured. The majority of the patients had local control and had no spread of the kidney cancer. So this looked like a very good method of treating a localized kidney cancer. I'm really happy that research like this is being done in a very thorough and prospective manner. The mainstay of treatment for this would be surgical resection, the methods that I think Dr. Westerman had talked about, but this may be an option in select patients. It's important, I think, going forward to compare this against different modalities and see what's the best. Even compare this against active surveillance and see the actual impact of using this method on the whole patient. So this is an example. This is a renal papillary carcinoma. It was 4 cm in size. This patient did not have great kidney function. The patient was recommended to have surgery, but this patient did not want to have surgery, and SBRT was used instead. So basically, the doctor looks at the tumor on CT, on MRI, looks at tumor motion, and drops a piece of radiation therapy in a single dose right to that tumor. This tumor was pretty treatable. I think it depends on the location, size, anatomy, and what's nearby. Looking at 6 years later, the solid kidney mass is replaced with a cystic-looking hypodense mass. Kidney function is pretty good. So that's an example. Looking at the NCCN guidelines, these are guidelines that doctors use. They're vetted by national experts. For a small for cancer below 4 cm, ablative techniques are in there. So basically, this would be an option for small kidney cancers. Like I said, surgery is still the mainstay of therapy. Active surveillance is used very often, but this would be one approach. For larger kidney cancers that are early stage, ablative techniques could be used in select patients. The guidelines also talk about radiotherapy. They recommend that it be considered for tumors less than 7 centimeters, and they give specific dose guidelines. Moving on, I'm going to talk about using neoadjuvant radiation therapy for advanced disease. This is kind of a work in progress, but if we have an advanced kidney cancer, if Dr. Arcana's team's seen advanced kidney cancer, sometimes the kidney cancer is so advanced, the cancer leaves the kidney, goes into the renal vein and into the IVC. This can be dangerous. It can even go into the heart. The patient may need bypass to take it out. It can go and block off the liver. So there's some data done at UT Southwestern about using radiation therapy to help stabilize the clot before surgery. So this is being evaluated very carefully. It may be something that's used in the future. A lot of patients have kidney disease that has left the kidney, that's stage 4 disease. And there's interest in using radiotherapy to treat the primary tumor. This trial is ongoing to use radiation therapy. The trial is ongoing for surgery as well. The advantage of this approach is we can start the systemic therapy, continue the systemic therapy, not interrupt the immune therapy. There may be less risk associated with using radiotherapy as opposed to surgery, and it also allows for sparing of the kidney function. This is a trial that we had open where patients get immunotherapy and they're randomized to adding in radiosurgery to the kidney tumor to look at the effect of that. Radiation therapy is used to help with symptoms. This has been used for quite some time, and it can be helpful in specific kidney cancer problems. Brain metastasis. Once in a while, the kidney cancer travels to the brain. This can be pretty scary for the patient, for the family. Patients often end up in the ER, they end up in the hospital, they get a CT, they get an MRI. Outcomes can be poor, and patients can get in trouble with brain metastases. This slide's a little bit busy, bear with me. This is a little tool doctors use when you have a kidney cancer patient. And And I think the goal here is not to give up hope. In kidney cancer, it's unusual in that you can control the primary tumor pretty easily, pretty durably. So patients who have brain metastases, who have a good performance status, can live a long time, even with brain metastasis. And if survival is good, it makes sense to go ahead and be aggressive, to be appropriately aggressive and go ahead and try and prolong survival. This data does not include some of the newer methods, so I'm hoping survival will be even better in the future. This is a little spot in the brain that shouldn't be there. It's surrounded by edema. The brain that has edema is not really working very well. We can treat that with radiosurgery in a non-invasive fashion. We put a piece of radiation therapy on that tumor, and a year later, et cetera, the tumor is controlled. Spine metastases. Spine metastases can be very painful. They can be difficult to treat surgically. They can expand the bone. They can break the bone, and they can be very vascular. So this is a piece of tumor in the lumbar spine. It is causing sciatica. Radiosurgery can be used to control the tumor, help with those symptoms. In other cases, when the tumor is advanced, the patient may need surgery. However, radiation therapy can be used to help control the remaining tumor there. So what's new on the horizon? I'm going to talk about two types of PET scans. One PET scan is a PSMA PET scan. It has PSA in the name. It's used for prostate cancer. However, the endothelium of renal cell tumors expresses PSA, and this can be used in renal cell carcinoma as well. It's not ready for prime time yet, but there's data that there's good sensitivity and specificity in this case. If a patient has kidney cancer, there is a marker called CA9 that's expressed in the kidney cancer. So this can be used to create a PET scan to detect kidney cancer as well. Now we have a lot of good studies, so why would a PET scan be that important? And I think the cool thing about this is you can find it, you can treat it. So there's a new class of drugs called a radioligand, and that has a marker that shakes hands with the tumor, and it also has a piece of radiation therapy, and it brings the two together. And I think this is really the future of radiation therapy because it's very specific. Instead of going through the body, the radiation therapy goes from the outside in. It treats the tumor very effectively. This is data from a drug from prostate cancer, but there's a drug called Pluvicto that's used to treat very specifically to the tumors. And about 2/3 of patients who have this tumor see their PSA drop very dramatically. And if that happens, patients live longer. So it's been a very successful treatment. This can be applied to a lot of other diseases, lymphoma, for lymphoma, neuroendocrine cancer, even kidney cancer. So there's now under development radionuclides for kidney cancer that take a marker for kidney cancer and a piece of radiation therapy, and they bring them together. So I think in the future, so we talked about stereotactic body radiosurgery. It's used for all different types of kidney cancer. It can be used for a very specific cancer problem. We also talked about what's new on the horizon, new types of PET scans, as well as radioligand therapy, where the radiation therapy can be directed very precisely to the tumor. So thank you very much, and we'll take questions at the end.
I would like to welcome Dr. Julie Cronin to the stage. Dr. Julie Cronin is an interventional radiologist at Ochsner Health. Her academic interests include interventional oncology, women's health, and medical education. And I will give it to you.
Good morning, everyone. Thank you so much for having me today. I'm really excited to talk to y'all about freezing and burning kidney cancer. So just to kind of go over what I'm planning to talk about today, I'm going to introduce interventional radiology. Most kidney cancer patients have met a surgeon, and most kidney cancer patients have met a medical oncologist. But not every kidney cancer patient is going to meet an interventional radiologist. So I just kind of want to tell y'all kind of who I am, what I do. We'll discuss briefly the staging of kidney cancers, go over the types of ablation and the pros and cons of each one, talk about if you would get an ablation, what that IR clinic visit looks like, what the procedure date looks like, how we follow up those patients, and then some case examples. Okay, so an interventional radiologist uses imaging guidance to perform procedures. We use all kinds of imaging guidance. We use ultrasound, we use CT, we use X-ray. We do a lot of image-guided biopsies, including kidney cancers. We also place ports, do venous access for patients that need chemotherapy. We do angiography. What angiography is we go into a blood vessel, we take pictures with contrast in real time under X-ray. And we can use that to guide us. We can stop bleeding that way. We can also treat cancers that way. But what I'm going to talk to you about today is ablation. So similar to most physicians, I went to 4 years of undergraduate, 4 years of medical school, and I did a 1-year internship. What made me an interventional radiologist is I did a 5-year residency of diagnostic and interventional radiology, where I learned how to look at images, but also do image-guided procedures, and then a 1-year fellowship that focused specifically on those image-guided procedures. So I know we went over kidney cancer staging already with Dr. Arcott. I'm going to focus in on these T1A lesions. And so those are lesions that are confined to the kidney and are less than 4 centimeters. This is the vast majority of patients that are treated with ablation. Every once in a while, we will also treat a T1B lesion, which is also confined to the kidney, but a little bit larger than 4 centimeters. But the majority of our data is treating these T1A lesions. So who should consider renal mass ablation? Small renal masses, right, T1A lesions, patients that may not be the best surgical candidate. This is less invasive than surgery, and so if there are a lot of other comorbidities, that kind of may push a patient towards considering ablation. Patients that don't have good renal function at baseline, we can also help to minimize the loss of normal kidney tissue to help try to preserve that kidney function. And then some patients just don't want surgery. And if they're candidates, they can come to us and we can help treat those cancers. This is kind of just, I'm not going to go through all of it, but some of the society recommendations on who should be considered for renal mass ablation. So what is ablation? We're destroying cancer cells. We're denaturing the proteins, which means we're breaking up the proteins, and then we're causing necrosis within the tumor. I'm going to focus on 2 types of ablation, which is what I use in my practice the most. Historically, radiofrequency ablation, we have some older data for that, but the newer data kind of tends to show a benefit, more of a benefit from microwave ablation and cryoablation. So those are the 2 that I'll be talking about today. So cryoablation uses pressurized argon gas to decrease the temperature of these probes that we put into the renal cancer. We can get them as cold as 160 degrees Celsius, but really we only need to get to about -20 to -40 degrees Celsius to kill the cancer cells. What it does is it causes ice crystals to form both inside and outside of those cancer cells. And we do something where we freeze it, so we drop the temperature down for 10 minutes, typically. Then we let it thaw, so we turn off the ice. And actually the thawing is what kills the cancer cells. And we usually do 2 rounds of each, so it's 10 minutes of freezing, 8 minutes of thawing, 10 minutes of freezing, 8 minutes of thawing. And what that does, it causes cellular dehydration. It causes the blood vessels going there to thrombose or shut down. And it causes the membrane of those cells to rupture, and it kills the cells. The nice thing, one of the main pros of cryoablation, they freeze in a very easy to predict fashion, and you can see the ice ball that's formed on imaging. So we do CT scans during the procedure to make sure that our ice ball is the size that we want and that it's not going anywhere we don't want it to go. There is a slightly higher risk of bleeding with cryoablation compared to microwave ablation. That is one of the cons of this. Also, they don't treat as large of an area as the microwave probes do, so sometimes we do need to use multiple probes, and if you think about it, if we're sticking more needles in, we can cause more bleeding that way as well. Very good recurrent-free survival, 87 to 98%, 5 to 10 years after these treatments. And this picture here just shows all the different types of probes that we can use. And then the bottom right just shows what that ice ball kind of looks like if you were to freeze it, kind of holding it in the air. Microwave ablation, this is the same technology that you use in your house with your microwave. So what it does is there's this antenna, this probe, sends out electromagnetic waves. It causes the molecules in the cell to kind of move and vibrate, and then they heat up. And so they can get as high as 100 Celsius degrees. It causes protein denaturation again, and that's what leads to cell death. It's less affected by heat sink than radiofrequency ablation. And heat sink, think about it as if you've got a match right next to the Mississippi River. So if there's a big blood vessel that's flowing really, really fast right next to what we're trying to heat up, it takes away that heat. And that affects how well you ablate that area. And so microwave, like I said, less affected by that than radiofrequency, which is why we have moved towards microwave compared to radiofrequency ablation. The procedure times are a lot faster. We don't have to thaw it, right? There's no ice ball. So those procedures usually go quicker. They also have excellent disease-free survival. Complications. I think this is the most important thing to know. I try to spend the most time talking to patients about all the things that can go wrong. Hopefully, we don't ever have to worry about it, but I want my patients to be well informed about what could happen that we don't want to happen. So complications rates of 3 to 15%, I just pulled a couple review articles to get these numbers. It's pretty similar for cryoablation and microwave ablation. Bleeding is the most common complication. I am putting a giant needle through your back into the kidney. The kidney's got a lot of blood vessels. Most of the time, it's just a little bit of oozing at the site and we don't have to do anything. Sometimes it is serious bleeding that requires blood transfusions, additional procedures, overnight admission. The other thing I like to talk to patients about, there is a risk of damaging structures that are next to the kidney that we're trying. So if it's up at the top of the kidney, we can damage the lung, cause a collapsed lung. The bowel often will sit right next to the kidney. The ureter, which is the part that drains the urine from the kidney into the bladder. And then we also want to make sure that we're not causing any damage to the skin itself. So before an ablation, every patient that comes to us has an IR clinic visit where they meet either our nurse practitioner or physician assistant. They go over medical history, including your medical problems, the anticoagulation medicines that the patient is receiving. We go over the imaging, we talk about the procedure, all the risks, all the benefits, what follow-up looks like, and then we schedule the procedure. When patients come in for procedure day, they check in, they get an IV, we go over labs, we make sure their vitals look okay, they meet the anesthesia team, and they sign all the consents. We do all of these procedures with general anesthesia, so tube down the throat. Most patients are laying on their belly for the procedure, because as you remember, the kidneys are in the back, that's how we're gonna get there. Hydrodissection we'll put a tiny needle between where we're gonna burn or freeze and something we don't wanna burn or freeze, most commonly the bowel. And we can just inject some saline and kind of push it away. That decreases the risk of damaging structures next to where we're going. We can perform a biopsy at the same time. Pathology comes down and takes a look at our samples to make sure that we've got enough tissue if we are gonna do the biopsy. We do our freezing or burning, we take the probe out, we scan the patient, make sure everything looks okay, and then they go to the recovery area for 4 hours. The vast majority of patients go home after that 4-hour period. If there are any complications, it may require an overnight stay. Follow-up, like I said, most patients go home with antibiotics, pain medicine, and nausea medicine. We often get either an MRI or a CT 4 to 6 weeks after, bring you back to clinic, take a look at everything. Most of the time, that's it. We just get you scheduled for follow-up. Sometimes if there's a little bit of that mass that's left, we'll schedule for a repeat ablation just to touch up any areas that were missed. Usually we do repeat imaging every 3 to 6 months to that 1-year mark, and then those patients usually follow up with just urology after that. Local recurrence rates, which means when the cancer comes back in the area that we treated, they've decreased over the years as our technical expertise has improved with these procedures. And recent studies have shown no significant statistical difference between local recurrence rates between partial nephrectomy and ablation. So as a radiologist, I would be remiss not to show you some pictures, right? So this is a CT. You can see right and left, so this patient's on his back right now. There's our mass. Now for the procedure itself, we lay him on his belly, so it's flip-flopped. This is my cryoablation probe, which is skewering the mass like a shish kebab. And then we got a nice ice ball there, as you can see. And so this is his follow-up, so he's back on his back. And as you can see, what we were talking, I think Dr. Arcott was talking about earlier, we're looking for enhancement. There's no enhancement in that mass, so this is a great result. This is an MRI. This is just a normal section of the kidneys, just so you can see what they look like normally. And then here's that mass we don't like. Here's a coronal image, so it's almost like you're looking at the patient face on. And we chose to do microwave ablation here. Like I said, cryoablation, the risk of bleeding is a little bit higher. This patient couldn't come off all of their anticoagulation medicine due to some of their heart problems. So the risk of bleeding was going to be a little bit higher for this patient. That's why I chose to do microwave ablation in this case. You can see my probe again, skewering the mass like a shish kebab. And then during the procedure, as we're burning, gas molecules form. I don't know how well it projects, which is why I kind of drew all around, but you can really see during the procedure, where you're burning, but the gas can also go a little bit past that, and it doesn't mean you're burning in that area. So this kind of just shows that the ice ball is a lot easier to see on imaging, and so that's why the cryoablation, sometimes it's easier, but you still get a good idea with microwave ablation where you're burning. This is right after we took the probe out. No evidence of bleeding. You can see there's a little bit of hyperdensity, which means it's kind of brighter white in the mass itself. There may be a little bleeding in the mass. That is okay. We don't want bleeding outside of the kidney. And then there's a little bit of gas left over. Totally fine. And then we got an MRI afterward, and as you can see, there's no enhancement on that mass. So that is exactly what we like to see. That's all I got. Thank y'all so much.
In fairness to everybody, interventional radiology, I've had it all. I had the radiofrequency ablation. I've had cement poured into my pelvis, but I also have oligoexpression. So I have often on CT scans lytic lesions on my bones that are showing up. And the question I have is, I have been offered at times radiation, and other times I've been offered ablations to handle those. And I'm just curious what the protocol is to help me make the right decisions, and I'm assuming that may be relevant for others in the audience.
I think that's a great question, and I will definitely would love our radiation oncologist to speak to that as well. I am not 100% sure off the top of my head the data behind, if one is better than the other. I think a lot of times it's a very personal decision of if you'd like to undergo, a procedure versus doing radiation alone. I think that there is some benefit to being able to stabilize if you're having a lot of pain from those lytic lesions causing fracture. But the most important thing is, doing one doesn't preclude the other necessarily, but if you are going to do both, I think it's better to do the intervention before the radiation. Do you agree with that?
Yeah, I think it's a very personalized decision, and it depends upon the anatomy involved, depends upon the normal structures. I think the best way would be sit down with a team, surgeon, IR physician, and kind of look. Usually we look for radiation therapy. We look at the volume at risk. We look at if there's normal structure nearby, like bowel. That may be very difficult for radiation therapy, but easier for other modalities. So I think we don't quite know we haven't done a direct comparison.
I don't see a long line behind me, so I will ask a couple other questions. One of the questions I get asked a lot, and I started a Facebook community of all stage 4 renal cell carcinoma patients, and this gets asked a lot. For those of us with one kidney, we've been told by many that looking at scans without contrast is like trying to read a book without glasses when you're farsighted. And we've also been told that with the current innovations in contrast and how they do it, it's okay to have contrast for most people with decent creatinine and eGFR scores. But I'm curious in your opinion on this issue of contrast versus no contrast for scans with one kidney.
Yeah, I think I think sometimes the MRI is very helpful, and that's a scan that can be used without contrast. PET scans are useful as well. Any comments?
Yeah, I'll say I pretty much contrast for everybody is how I generally will go. Sometimes, depending on the facility, there are some phone calls that get made, and we're not going to give them contrast. But even with a GFR, less than 30, a lot of times it's okay. And a lot of the data that comes from the contrast-induced kidney injury in the more like acute settings is we don't even really know that that's really related to the contrast. I think it sort of got blamed, but probably is not the cause. And so I think when you need it, it's safe to do so.
I think speaking about the institutional policies, Ochsner and some of the other hospital systems within Louisiana are different and have different policies as to what GFR is appropriate for certain contrast material. We think MRI contrast is probably safe under a GFR of 30, but of course every institution is different. At Ochsner, and I'm sure at other places, we also employ contrasted ultrasound as a technique in certain scenarios. So I think the adage contrast for everybody is good, and I think there's different imaging modalities that can be used at different times. So certainly reading, certainly your analogy is quite correct. At least that's the way we feel. So.
Thank you. I'm just going to say that's a great question, and I think it's funny that Julie's going to answer last because I think she's by far the expert to answer that question. I think it depends who you hear that statement from. So I trained somewhere where we did a lot of kidney donors, and if you go to a nephrologist after kidney donation, they'll tell you never take ibuprofen. We know that's very safe to do. It's more of a generalized kidney health statement. So if your GFR is in a safe zone and you're able to get contrast, the contrast is very helpful to us. It's not necessarily like reading a book versus reading Braille, non-con and with contrast. But it is very helpful for us, and I think it depends on the patient and their GFR and the question we are asking. But Julie is going to be the expert on this.
So I love to talk about this, but I will kind of reiterate what everybody said. So contrast-induced nephropathy, which is the iodinated contrast associated with CT, some of my attendings when I was in training said it's fake. It doesn't exist. Other people do feel like it does exist, but most often when a patient has an acute kidney injury, less so with chronic. And that's basically, reiterating what Dr. Westerman said. We do have a policy here at Ochsner of a GFR less than 30. There has to be some sort of discussion either with the radiologist or the referring provider. But I will almost always say thumbs up, you can do it. Unless there is a concern for an acute part on top of the chronic low GFR. Other things, sometimes we do angiography where we're injecting intravascular contrast on patients that have chronic kidney issues. And, we talked about this a lot in our group, but you can get prehydrated, get some fluids beforehand, we'll keep them a couple extra hours, make sure they're getting good fluids afterward. If there's no heart failure or contraindication of getting fluids, that just helps to flush that contrast through. I don't think there's true data about it, but it'll make you feel better that, we kind of flush that contrast through. And then as far as MRI, there's basically no risk to getting the modern day gadolinium-based contrasts and causing issues. There's an older entity that you'll hear about called NSF, or nephrogenic systemic fibrosis, for patients that have dialysis, but all of that data comes from contrast agents that are like 20, 30 years old. And so the risk of that currently is exceedingly low.
The reason it's so important is because I think we in the patient caregiver community have to tell our doctors we want contrast and we want to be informed of the risks and the pros and cons, but way too many times we're not getting the contrast, and I don't think we're getting the best visualization. On the MRI issue, we'd all love MRIs, but we have something called insurance companies, which will often fight the MRI versus the CT scan. So what you said, I think, is really important for all of us to take back to our doctors, because we do play a role in what we want, and we have a right to advocate for ourselves as well.
Yeah, and I think it depends a lot on who orders the scans. So what I'll see is, depending on where my patients come from, sometimes, I may have ordered a CT with contrast, but they're 4 or 5 hours away, and their local doctor then orders, and then they end up with a non-contrast CT. And I think that is a patient, I try to educate them, but patients have to advocate sometimes and say, hey, call my urologist, make sure it's okay.
And not to belabor the point, but my mom is actually a CT tech, so we talk about this a lot, and there's a lot of policies that the CT techs are not allowed to give contrast. And so if you're running into problems, it really is important to have your referring provider being very clear in the order itself. It's okay to give contrast, because they'll hit a hard stop when they see that GFR. They are not allowed until they get a thumbs up from a physician. So I know it's frustrating, but we've talked about this. She's like, I'm sorry, I can't do it. Like, I could get in trouble. And I'm like, I understand. So it really is really important to have that discussion before you go, which can be challenging.
My last question, unless there are others, well, not really my last question, I have two more, but I'm only going to ask one more question. I am fascinated with liquid biopsy. And every time I get a panel, I ask the same question, and I get the same answer, but with different nuances. I've had the Signatera blood test every month since I've had cancer. My insurance company approves it. I see very little downside to it. I will never make a decision based on it. I look at it as a tool in my tool chest. It has tracked my progression 3 times perfectly. However, in the medical community, there's some amazing doctors who still are very strongly cynical about it, to be nice, and don't believe it, and I'm very interested in your opinion.
You want to start?
Yeah, sure. I think what you said about it being a tool in the tool chest hits the hammer on the nail, not to keep that analogy going, but it's supposed to be and should be used as an adjunct test in addition to the scans that you're having, as an extra piece of information. There are scenarios in which those liquid biopsies or that panel can precede the findings on CT scan, and so could raise our awareness if you're getting non-con scans and you get a change on your liquid biopsy panel, and there's a signal there that maybe we need to scan elsewhere, maybe we need to do that contrast enhanced scan. I understand the cynicism because it has not necessarily worked its way in the guidelines, and this is relatively novel data, but in my opinion, there's absolutely a role in it, and our medical oncology colleagues do use this very frequently at Ochsner. So.
Yeah, I'll just add, it's a very expensive test, and that's been one of the holdups regarding its use. I mean, quite frankly, obviously, before some of the research in the last couple of years, we didn't really know what its role would be, and we didn't have a good way to implement the test result in making clinical decisions. But insurance coverage has been an issue, and I think that's been an important part of the piece of the puzzle here. That being said, I think Signatera, which is the main company that runs this test, is very interested in helping patients, especially in the renal cell space, because quite frankly, we don't have enough data to make decisions, and they're interested in seeing what their test can do. So I think it's worth having a discussion with your doctor. Certain doctors may not use it as much as others, but my understanding currently is that Signatera is willing to help patients out, willing to make sure that they get the test if they're an appropriate candidate for getting such a test. And there is a policy within the drug therapy space with immunotherapy monitoring. So in stage 4 patients who are on immunotherapy, the insurance companies not have to, but are inclined to pay for repeat testing moving forward to monitor response to immunotherapy if you're on it. So another thing to talk to your clinicians about, if you're on immunotherapy and they're like, oh, well, that test is really expensive, I don't know if they're going to cover it. You might want to inform them that there is some insurance loopholes that can be worked out. And as Dr. Rose said, I mean, it's certainly something that's on the horizon, and we're trying to use it more and more at Ochsner, and hope it's going to be a game changer.
I use it for everybody with bladder cancer. So that's like, to me, sort of standard of care. And I find it very helpful in making treatment decisions, especially regarding surgery and whether or not going ahead with surgery is the right thing to do in patients with advanced disease. The medical oncologists that I work with are not always as sure about what to do with the information, especially in the post-cystectomy setting and some of these real low-level positive numbers and things like that. But I do think that there's a really big space for it in the sort of deciding what treatment to go ahead with, especially something like a cystectomy. I don't use it right now in kidney cancer, just because my patient population, the payment and coverage is an issue. And so I haven't used it, but I do hope that we have the data that comes out from it, that we can use it similarly how we're using it with bladder.
Yeah, I think there's such an explosion of new data that I think everybody is kind of finding their footing and trying to see the most appropriate use.
I don't know, we don't do that part.
Are there any? I will run the mic in the audience while also being out of the way.
Thank you. There was a lot of information to absorb, and perhaps I've misunderstood and maybe misstate my thoughts here, but Dr. Rose and Dr. Arcott especially, I had understood someone to say that there's no screening devices, and it's often asymptomatic patients. My two boys are approaching the age that I was when I got my kidney cancer, and that's a concern for me. And I'm wondering if you did mention, Dr. Arcott, that there are no screening devices except for genetic predispositions, which suggests that there are screening devices, and I'd like to know a little bit more about that. And also, Dr. Rose, the liquid biopsy, is it possible that one day that could be a pre-surgical technique and not a post-surgical technique? Thank you.
Okay, great. Well, thanks for putting us on the spot. This is good. These are tough questions, which is important because I think it spurs more discussion and education for our patients. So let me rephrase. So there are no routine screening programs for kidney cancer. So if you have colon, when you hit the age of 45, and I'm going to butcher this because I don't know the exact colon cancer screening guidelines, but if you hit a certain age, you're supposed to get a colonoscopy, and that's to screen for colon cancer. If you get to a certain age, then you're supposed to get a PSA to screen for prostate cancer. There's not a particular age where you're supposed to say, okay, I need to get a urine test to screen for kidney cancer or get a CT scan to look for a renal mass that might be present without symptoms. So that's the problem with kidney cancer, is it's mostly incidentally found. Now the rates are increasing generally in the United States because we get CT scans for just about everything, whether it be the common cold or something really bad like nausea and vomiting and can't have a bowel movement. So there's not a screening program. Now, if you have a genetic predisposition or a strong family history, talking to your primary care doctor about what that means and seeing a urologist and having a further discussion about screening for kidney cancer may be appropriate. But generally speaking, unless you had a hereditary syndrome, we do not advocate necessarily for yearly urine tests or yearly renal ultrasounds or things like that. Now, the hereditary syndromes that I did put up on the screen, for those, yes, the National Comprehensive Cancer Network, which we had a slide on by Dr. Padmanathan, does have guidelines for screening those individuals. So if you had von Hippel-Lindau syndrome, we might get a CT scan or an MRI every 2 years, starting at the age of, I think it's like 8. It's like very early, but so on and so forth. So that's the only thing. It's a little bit of a challenge. You have sons, and you've had kidney cancer. So the question is, well, what do we do really with your sons if you didn't have a genetic test saying, you're at increased risk for kidney cancer and they are too. So it's a bit of a challenge.
Thank you. I'll preface my answer by quoting something Dr. Arcott and I say to the surgeons that we're training: do as I say, not as I do. Because if my father, who is 63, was diagnosed with a kidney cancer, and I'm 35 right now, when I turn 40, there's no screening available that my insurance would approve for kidney cancer screening. There's no national guideline for screening. I would personally want an ultrasound myself. If that answers your question. And again, it's what would I do versus what are the guidelines? Maybe I'd tell my PCP that I think I got a kidney stone, I'm getting some flank pain, then I get an ultrasound. This isn't being on tape, is it? We can cut that part out. But the question about liquid biopsies, at Ochsner we're still doing the Pathfinder study. And so we talked a lot about, or I mentioned a lot about a tumor-naive approach and how circulating tumor DNA is not as accurate or detectable in those clinical settings. Dr. Matrana is speaking later today. He's the PI for this Pathfinder study, and we should ask him about that. But that is a non-diagnostic screening blood test for various types of cancers in patients that have no known cancers. And to even illustrate that point further, I got both of my parents on that study through Mark because it's a blood screening test trying to detect various types of cancers. I don't believe, and we can ask him when he gets here, I don't think we've had signal yet in the GU cancer realm. But those studies are ongoing. Those things are coming, and that day is coming where we can start screening for various cancers using a peripheral blood test.
Getting my steps in.
Hi. When I was diagnosed with stage 4, grade 4 sarcomatoid, clear cell kidney cancer, and I've had a deep response to the treatment that I've had, and just had my anthill removed. And the pathology report from the tumor came back as grade 3. And so I guess my question is, so for the circulating cells you were talking about, are they still fire ants, or has the deep response lowered kind of the angry cells activity?
You sure? I mean,
I think it depends, and I don't necessarily want to pry too much about the stage or the presence of lymph nodes or distant disease, but it really depends on what the stage was. Thank you. What the stage was before surgery and after surgery. I do think that using a ctDNA-based test after surgery would be helpful in that scenario, particularly if there's no other known sites of disease. And I thought the direction that the question was going to go is if you have a stage 4 cancer, you receive systemic therapy, how could ctDNA guide us in the decision to remove a kidney in somebody with mets, which I think all three of us are nodding is a very controversial area, and we all have our own opinions on. But
yeah, we, ctDNA, we're still learning about it. We're using it. I think the way that I use it, and I'll just so I can speak personally, because like Dr. Rose said, we all have different opinions about it. In the setting of stage 4 cancer, we know that systemic therapy is the standard of care approach because we're trying to treat the whole body, and we're trying to treat all these fire ants that have found new homes or made anthills in other organs. And we can't take out multiple different organs. I mean, quite frankly, it's just not appropriate. Now, if the systemic therapy is able to take care of some of the fire ants and the anthills in other areas, we believe that potentially taking out the source, being the kidney, could be beneficial. And that is still controversial. We're still learning about it. We're hoping some new studies will read out data on whether ctDNA can inform whether taking out the kidney is the next best step. With ctDNA, I think that what we're trying to do is find a trend, quite frankly. So I don't think we have a good cutoff for whether, a ctDNA number of like 1, 5, 10, 20, or 40 is going to give us an answer as to whether or not you're cured or you're going to progress, but maybe some sort of continuous repeat testing would lead to a trend that would would inform whether or not you're going to progress. I think your question too also stems to the fact is, well, are the fire ants that are still around potentially in my body just as aggressive as my original tumor? And I think that's something that we quite frankly do not understand. I think that that's an extremely high level question about what's the biology of the disease that's in the kidney and how is it different from a metastasis in my lung. And that's something that if we had the answer to, I think we'd be much better cancer doctors. And I think we are all working really hard to figure that out. And there are multiple different people across the country at different institutions measuring the tumor biology in metastatic sites and within the kidney and trying to say, well, are they the same? Are they different? And if they're different, should they be treated differently? You know, and hopefully we'll get to the answer to that soon.
Any other?
Thank you, and thank you all for being here. I'm going to give a little bit of my background as the basis for this question, but I think maybe it's just a more general question. Stage 4 papillary, all the metastases are in my lungs, and all of them are very small. I've been on Lenvima, thank you, for about 3 years, and everything has been stable. And my dosage is to the point that I feel pretty darn good. That being said, my oncologist at MD Anderson in Houston has mentioned at some point we could look at cryoablation, something like that. What I'm wondering is, I'm stable, I feel good, I'm living with this very well every day, but at what point should somebody consider radiotherapy, ablation, and what are the benefits, what are the risks? Obviously, at some point, I'd love to be cured. I'd love to be NED, but I'm maintaining well for now. So can you speak to when maybe that step should be taken? What are the risks, and what would the effectiveness be?
Who wants to start with that?
So I can sort of answer the flip side of it a little bit, which is when do I consider removing a kidney in somebody who's had metastatic disease that's been stable on systemic therapy? And to me, it's can I make you radiographically NED? You've been stable and had a good systemic response. All we see is the primary. If we can make you radiographically NED, I think that to me makes sense. And so I would say that may be the same consideration from a distant disease standpoint, and if there would be benefit to stopping therapy, if you're going to treat it, can you come off of therapy?
I think another big consideration too is, how many Mets are there when we're talking about putting probes in, and similarly, I would want to treat every single one. I don't think there would be any benefit to treating half of them. So it would be important to review the imaging and make sure that they're all, you can actually get to them to treat them appropriately. But I would not want to leave any untreated. And, we talked about the risks of damage to adjacent structures, specifically with the kidney. The lung is similar. The lung's a little bit more sensitive, especially for pneumothorax. The lung's a balloon, and I'm going to stick a needle in it. So, it is an important thing to have a very thorough discussion with your doctors, but it's not off the table by any means.
All right, I have 2 tumors in my remaining kidney, and is it possible, do you work on 2 at the same time, or do you do them separately, or do you, how does that work, either microwave or cryo, and what happens to the necrotic tissue? Does it regenerate, or does it just, become, what happens to the tissue after it's...
So I like to stage them if we're going to treat more than one. Some of my colleagues may try to treat them all in one session. I think it's better. There are risks with undergoing anesthesia for sure, but I'd rather focus all my attention on one at a time when it comes to the kidney. But like I said, some of my colleagues are a little bit more aggressive. They may try to do both at the same time. And as far as what happens to that tissue afterward, your body resorbs a portion of it, but there will still be findings of the lesion as we look at our follow-up. It's really just the enhancement characteristics that we're focusing on to make sure that there's no residual solid enhancing tumor in that ablation bed.
And now I would like to welcome to the stage Dr. Mark Mantrana. Serves as Senior Medical Oncologist at Ochsner's Gail and Tom Benson Cancer Center. He also serves as the Associate Director of Clinical Cancer Research at the Ochsner Cancer Institute and as Associate Professor of Medicine at the University of Queensland School of Medicine in Australia. Welcome to the stage, Dr. Mantrana.
All right, well, thank you very much, and thank you all for coming today. I really appreciate this. So today I'm going to focus on the medications that we use to treat kidney cancer and a little bit about clinical trials, because every medication that is on the market today, from the over-the-counter stuff to anything we can prescribe, is there because patients like you guys participated in clinical trials. So these are my disclosures and a little outline of what we'll discuss today. So probably preaching to the choir, you may have heard it already, but as you know, renal cell carcinoma originates in the outer layer of the kidney. There are about 82,000 new cases in the US each year and 14,000 deaths, unfortunately, attributed to this disease. It represents about 2 to 3% of all cancers, so certainly not the most common, but by far not the rarest either. And by far the most common type of renal cell carcinoma is clear cell disease. Now, this is showing my age a little bit, but when I began my training, we had 2 options to treat kidney cancer, advanced kidney cancer: high-dose IL-2 and interferon alpha. And both of these drugs were extremely toxic. In fact, about 10% of patients who received these drugs died from side effects of the treatment. The treatments, unfortunately, only helped about 10% of the patients as well, and all of the patients had very, very, very severe side effects. Today, we're in a much better situation, thankfully. Things have evolved rapidly over the last 15 years or so as we have a better idea of what drives kidney cancer, what causes kidney cancer, and we've designed drugs that actually get right to the source, right to the target. So since December of 2005, really, is when we started seeing these new agents hit the market. And it has been a flood of new drugs, new classes of drugs, and new combinations since that time. There are really 2 main types of medications which we use to treat kidney cancer. And often my patients, when they're first diagnosed, are surprised to hear that chemotherapy is never used to treat renal cell carcinoma, which is wonderful, which is really wonderful. So the 2 main type of medications we use are targeted therapies. Now these are smart bombs. They're pills that target the cancer cells. And what they do is they disrupt lines of cellular communication. And for the most part, they stop the formation of new blood vessels. So in order to grow, cancer has to have a blood supply. And if it doesn't have a blood supply, it makes its own. It's a process called angiogenesis. And the majority of these targeted therapies work by stopping that process of angiogenesis. The other type of therapies that are widely available now for kidney cancer are immunotherapies. These boost the body's immune system to fight cancer by uncovering cancer cells that are hiding from the immune system. I trained at MD Anderson, and when I was there as a fellow, every Tuesday we had lectures. They were called academic Tuesday lectures in a lecture hall very similar to this. And there was always a guy who sat in the back named Jim, who was a little bit disheveled, a little bit long hair, a little bit avant-garde. And he would always rave that the key to cancer was in the immune system. And we were learning about targeted therapies and chemotherapies, and we just thought Jim was a little bit off. He worked in the lab, and maybe. Yeah, that was Jim Allison, who's won every single major prize in science today, including the Nobel Prize for his development of immunotherapy. There's a PBS documentary called "This Is What a Hero Looks Like." If you want to hear more about his life, but his mother died of cancer when he was very, very young, and at that time he made a decision to devote his life to trying to find a cure for cancer, and he developed immunotherapy. And arguably, his work has led to the biggest breakthroughs in cancer of history, really. And so, this is where the immunotherapies come from. And the way they work is pretty interesting. So, under normal circumstances, we probably develop cancer multiple times throughout our lifetime. And our immune system is surveilling for abnormal cancer cells, just like it surveils for viruses or bacteria or other germs that aren't supposed to be there. And most of these cancers are picked up by the immune system, killed, and we never know they were ever there. Never form tumors, they never really cause any problems whatsoever. But what Jim Allison and others found is that in advanced cancers, many of these tumors find a way to get around the immune system. And so under normal circumstances, white cells, T cells, that attack tumor cells have a little on-off switch that works very similarly to the light switch on the side of the wall there. And this is important because when these cells go to attack a healthy tissue, like our liver or our lungs, our liver and our lungs can just hit the switch, turn the cell off and say, I'm a good cell, don't worry about me, go find somebody else to attack. Tumor cells develop little fingers called PD-L1 and PD-L2 ligands that can interact with the light switch and turn the T cell off too. That's a bad thing. That's a bad thing. You don't want that to happen. You don't want the tumor cell to be able to turn off the immune system's ability to kill it. And so what these amazingly smart folks decided to do is they were going to develop antibodies that either bound to the light switch called the PD-1 receptor, or the little finger on the tumor cell called PD-L1 or PD-L2 ligands, and essentially stop that interaction between the tumor cell and the T cell. It's analogous to putting a big piece of duct tape over the light switch so your kid doesn't turn it on and off all the time. But it works. It works for a lot of patients. Not everybody, but it works for a lot of patients. It also can cause some side effects because when we rev up the immune system to fight cancer, sometimes we rev up the immune system so much that it starts attacking a tissue. And this is called an immune-mediated side effect. It can very much mimic an autoimmune disease. And patients will often say, okay, well, what does the side effect look like? Well, my answer to that is anything that you can dream of that ends in itis, these drugs can cause. And it's true. It's true. Because these drugs can inflame any tissue. And if it inflames lung tissue, that's called pneumonitis. It might look like a pneumonia. If it inflames liver tissue, that's hepatitis, autoimmune hepatitis. It can inflame the eyes, the brain, the heart. These are rare side effects, but they do occur. The good news is that for 99% of these side effects, we can reverse them with a high dose of steroids. And often we can go right back to the immunotherapies that led to the side effect in the first place, and they don't necessarily cause the same thing again. What is challenging about these side effects is they can occur at any time after a dose of immunotherapy. They can occur a week after a dose of immunotherapy. They can occur months after your final dose of immunotherapy. So what makes it challenging is if a patient walks into the urgent care center and says, I'm having a cough and shortness of breath, the doctor there, rightfully so, is going to think, well, gosh, maybe this patient has a COPD exacerbation or a pneumonia or COVID or, asthma or who knows. And 99% of the time they're going to be right, but they're definitely not going to think, could a drug the patient took months ago cause a side effect that's now affecting them today? This side effect is treated very differently than we would treat those other things. So I always tell my patients on immunotherapy, if you have any new symptoms, call us right away. And I've picked up the phone, called many ER docs and primary care docs and say, I did just this past week, and say, hey, this could be a side effect of immunotherapy they took months ago. So in terms of, when we use these medications to treat kidney cancer, it is still a truism that if you can resect a kidney cancer, if you can surgically remove it, surgically remove it. That is the most important aspect of this. Dr. Arcott right here and I work very closely together. I haven't been in an OR in well over a decade, so I'm the medication guy. I'm always thrilled when I can send a patient to Dr. Arcott to have their cancer surgically removed, because when we do that, we're often doing it with an intent to cure. But we can use these medications after they're done with surgery. And one way that we use them is what we call adjuvant therapy. Adjuvant means after surgery. And so especially in patients that have a high risk of recurrence, maybe they had a very aggressive cancer, maybe lymph nodes were involved, their cancer may look very aggressive under the microscope, we can give immunotherapy to try and prevent their cancer from coming back. There are really two drugs approved in this setting. One is an old targeted therapy called sunitinib. It never really worked well in this setting, and it's pretty toxic. But we also have a drug called pembrolizumab, or Keytruda, which is approved in this setting, and it improves survival. So in the studies, after patients underwent surgery, we looked at 2 years following surgery, and the patients who received pembrolizumab, 77.3% of them were alive without disease, compared to 68% of them after surgery who did not receive a year of immunotherapy. And so, we often offer this to patients, and it's an individual choice if they want to take the therapy or not. So, approximately 25% of the patients who who present with the disease have metastases at the time of their initial diagnosis. So, these patients are not curable. And about a third of the patients who undergo surgery to remove cancer will develop metastases at some point after surgery. So these are the patients who come to me who really don't have a curative option, whose surgery is not possible. And so what do we do? Well, as I told you, when I first began my career, we did high-dose IL-2 or interferon alpha. Today, we've got a lot more options. And primarily, we have combinations of either immunotherapies and immunotherapies, or immunotherapies and targeted therapies. And so these are 5 different combinations that we have available. And patients often ask, well, which is the best? Well, the best one is the one that works for you. And we don't know that until we give it a try. We've actually done some research in trying to figure out ahead of time which one works for each patient, but it's never really panned out. We really just have to try and see how it goes. The nice thing about these combinations is that they work well. So, for example, in the Keynote 581 study, it's the CLEAR study, this actually included a lot of my patients. I was the principal investigator here in New Orleans for this study. We gave patients a combination of lenvatinib, which is a targeted therapy, with pembrolizumab, which is an immunotherapy, and we saw a really nice response rate. 71% of the patients had at least 30% tumor shrinkage on this combination. But more importantly, in my mind, is that we achieved what's called a disease control rate of 95%. So 95% of patients had at least stabilization of their disease, which we consider a win, or some type of tumor shrinkage. Only 5% of the patients treated with this combination had tumor growth. And so, as an oncologist, when I started my career telling people, hey, I've got a therapy that might work for you 10% of the time, versus now sitting in front of a patient that's newly diagnosed and being able to say, I've got a therapy that has a 95% chance of working for you and keeping your disease at bay, it's a very different feeling. It's a very different feeling. And I'm very pleased to be able to offer this therapy to our patients. So a little bit about clinical trials, because as I mentioned to you, every drug that's available today is there because we did a clinical trial on that drug, and often we did many clinical trials on that drug. On average, patients on trials tend to do a little bit better than patients who are not on trials, and that's for a couple of reasons. One is because when you're on a trial, the FDA requires that you be monitored much more carefully. You're assigned a clinical trials research nurse who's checking in with you very frequently, and often you may be getting something that is going to be the new breakthrough a year or two or maybe more later. So I often like to tell my patients on trials, you are receiving the medicine of tomorrow today. You're kind of getting a little sneak peek, if you will. And the NCCN guidelines, which are what we practice by in this country and really around the world, except in Europe that have their own set, strongly recommends clinical trial participation when feasible. Now, not every patient qualifies for trials. The trials have very strict criteria of who can enroll and so on and so forth. But we're always thinking in our mind, is this patient a potential clinical trial candidate? Now, there are a lot of myths about clinical trials that are out there. One is patients are going to be treated as guinea pigs. And the reason I do clinical trials is not primarily to advance science, although that is an important piece of it. It is to bring my patients the best therapies we have available. And so we're not treating them like guinea pigs. We're just trying to find the best treatment we possibly can for them. And when surveyed, patients who have participated in clinical trials often say it was a very positive experience. They don't feel like guinea pigs. Clinical trials are for patients who have run out of options. Well, we do use clinical trials in that setting, but we actually use clinical trials in every setting in patients who have curable disease or others as well. Patients may receive a placebo and not treatment. It would be unethical for us to withhold treatment for a cancer patient. And so we may use a placebo, but never to withhold treatment. And so what I mean by that is if the standard of care is drug X, we may design a trial in which half the patients receive a new combination, drug X plus Y, like so a new combination, and the other half receive drug X plus placebo. And so they're still getting the standard care that they would normally, but we would never just not treat a patient and give a placebo. That would be totally unethical and would not fly with any institutional review board that approves these studies. Clinical trials are more expensive for the patient. Actually, the opposite is true. In the state of Louisiana, we have Louisiana Revised Statute 22-1044, a law which I personally helped amend, and that states if you are a cancer patient on a clinical trial, your insurance company has to cover all costs related to your cancer care with the exception of the experimental drug. And that's a fairly unique law here in Louisiana, but it's actually financially better for many patients to be on trials because their insurance companies don't get to decide what care they're going to receive anymore. And participation in clinical trials is not important. Well, boy, if you just look at those drugs approved in the last 15 years, I think we can say that that's not the case at all. So a little bit about how clinical trials work. So drugs are first tested in a lab, usually in plates of cells. Tens, thousands, hundreds of thousands of new compounds come out every year, and only a small portion of those actually make it through the first set of testing in the labs. And those that do are then tested in animal studies, usually small animals first, like mice, and then larger animals to help us better define the toxicities and the dose. And the first time drugs are given in humans, those are called first-in-human trials, and those are phase 1 studies, And phase 1 studies really asking what's the best dose, what are the toxicities of the drug, what are the side effects, and I actually founded the only dedicated cancer phase 1 program between Houston and Birmingham, and we've done hundreds of phase 1 trials through that program. These are highly sophisticated trials which are monitored like you wouldn't believe by the FDA and the sponsors of the trials. And often these trials are enrolling 3 patients worldwide at a single dose level, and then we move on to other dose levels. Phase 2 studies enroll a few more participants that by this time we know what dose of the drug is appropriate, and we're really asking the question there, how well does this work? The phase 3 studies ask the question, does this work better than the best thing we have today, and the best drug we have today, and we compare the two. And then in phase 4 trials are after the drug is approved, and that asks the question, how does this work in patients who might not have been able to get on the trial? Maybe they were too weak to be on the trial, they were considered too old to get on the trial, for whatever reason. How does it work in the real world, so to speak? So this is an example of a currently open trial. We have an Ochsner. This is called the Pedigree Study. And so what this does is it takes patients who are newly diagnosed with inoperable, advanced metastatic clear cell renal cell carcinoma, and everybody who enrolls in the trial gets 4 doses of a combination immunotherapy. This is standard of care. And then we look at how the patient did after that. We do a set of scans. And if the patient cancer completely went away after those scans, then they continue to receive a maintenance immunotherapy. That's considered standard of care. If they didn't respond and their cancer grew, we switch them to a completely different type of therapy, a targeted therapy, and that is also considered a standard process as well. But for the majority of patients whose cancer didn't go away completely, but didn't grow, so it either stayed stable or shrank a little bit, we randomize them. And so that's really picking out of a hat, not a literal hat, it's a computer that assigns this randomization. But half the patients receive immunotherapy maintenance alone, which is the standard thing to do, while the other half receive a combination of immunotherapy and targeted therapy. And that's a little bit different. We don't usually use 2 drugs in combination for maintenance therapy. So that's the experimental part here. So our hope and what we expect to happen is that patients who are receiving the combination in the maintenance phase will do better than those who are receiving the standard 1 drug in maintenance. And so it'll be a few years before we know the results of the study, but we've enrolled probably about 12 patients to this study, and they're all receiving therapy per the protocol. So here are my final thoughts. So these new combinations of targeted therapies and immunotherapies are giving our patients longer lives, far longer lives, with fewer side effects than the more traditional therapies we had before. We still can't cure a lot of these patients, but we can give them many years of a productive life. But we still don't know exactly how to sequence these drugs. Which should we use first? Which would use second? And that's why we're doing studies just like this one. And we also are not very good about knowing which combination or which drug is going to work for which patient. I told you we tried to do some things in research to pair up patients with drugs. It's a little bit of trial and error, even if you're not on a clinical trial. You give a patient a drug and see if it works, and then adjust accordingly if not. So what we really need is what's called a biomarker. Some cancers have a biomarker where we can take a blood test, for example, and it can guide us. Lung cancer, for example, has lots of biomarkers where we can do a blood test and it can guide us to this is the right drug for this patient, while this is the right drug for this patient. I often like to say that that's the holy grail of renal cell carcinoma, a good biomarker. We don't have it yet. People have been looking for it for as long as I can remember. They're still looking for it, and it's out there. We're going to find it, but not yet. We haven't found it yet. So more research is needed, but the good news is that new drugs are coming out every year or so, giving patients new options, more hope, and better quality of life. That's all I have for you today. Will we take questions now, or will we wait till the panel? Wait till the panel. Yeah. Absolutely. Well, thank you for your attention.
Now, I'm going to let you in on a secret. I said yes to the MC thing just so I can do what I'm about to do. This next speaker is the most amazing woman you will ever meet. She is smart, she is talented, she is averagely beautiful, and not that way. So I am the next speaker, if you haven't gathered that by my terrible, terrible joking. I will be talking to you today about movement and exercise during and after kidney cancer. But before we get into that, I would like us all to take a minute for movement. If you can stand up, great. If you cannot, you can do this in the chair. It's just going to be a simple breathing exercise. So you just breathe in, just breathe in, bring your arms up, and if you could bend over, make a big sweep and just bend down, hold your arms, swing a little bit, and then come back up, big sweep up, breathe in, do that one more time, breathe in, sweep down, grab your arms, swing a little bit, shake it out, sweep back up, and there you go. Now my hair's a mess, but and sit back down. So I'm gonna grab this, and where is my limit in terms of walking around? So here are some of the things that we will cover. I have a lot of slides, so I might speed through this. The key message is moving your body is a great way to feel better and manage symptoms and bounce back during and after kidney cancer treatment. I should probably give you some of my background so you can understand why I'm actually speaking on this topic, since I didn't give a proper introduction. So I am a certified fitness and nutrition coach. I got into fitness before my kidney cancer diagnosis, but after I was diagnosed with chromosomal renal cell carcinoma, I decided to dedicate most of my career on the side to helping other people with one kidney build their dream physique, right? I call myself the one kidney bodybuilder. That is who I am online, because exercise has been a big, important part of my mental health, and it's not something I wanted to lose. And there's a lot of misconceptions on what you can do as a fitness enthusiast, as a gym rat, as I like to say, when you have one kidney. And we need more research there, but I won't step on that soapbox. So, what kidney cancer treatment does to your body. Now, for me, I only had surgery, so I can speak to that very deeply, but I also know what it can do when you're on systemic treatment. Fatigue and low energy, muscle loss and weakness, you have pain around the incisions, which is very, very annoying. Changes in kidney function, especially after surgery, higher chances of heart problems. One thing we don't often talk about in survivorship and in cancer treatment is the emotional side effects, right? We always so focus on physical, but emotional, stress, anxiety. I know that's gonna be the next one after me. Fear of the unknown. I know we all deal with that. Feeling down about diagnosis and treatment. So this is why movement matters for the body. So during treatment, it strengthens your muscles, reduces cancer-related fatigue, helps ease nausea, improves mood, boosts your immune system. After treatment, supports recovery and kidney function, reduces the long-term side effects. The healthier you keep your body, the more muscle you build, the more you're able to just have a sustainable, healthy life, lowers risk of recurrence, and improves overall wellness. Why movement matters for the mind. Again, I said I have a lot of slides, so I apologize for that. But it's less stress and anxiety. You have a community connection, you get better sleep, and you feel more confident. Same reason people exercise just for regular daily life. It's the same for people who have had or have cancer. And so there are different types of exercise that you can do. It's not just one way. You can do cardio, which strengthens your heart and lungs and increases energy, again, fights fatigue. You have strength training that builds muscle, improves brain and muscle health, strengthens bones, boosts self-confidence, reduces stress, fights fatigue. And then you also have flexibility and mindfulness. We did a little bit of that when we started this, and that really helps. It, not just mobility and stiffness improves that, but it helps calm the mind, ease tension, improve focus. I will be honest, that is the one that I'm not very good at. I love cardio, I love strength training, not really good in the mindfulness. So again, do as I say, not as I do kind of situation, as we've established with other people. I put this down for whatever reason. And this is why movement matters. People who are physically active had a 12% lower risk of renal cancer than those who are least active. Studies also found there's a 23% reduced risk of kidney cancer when there was leisure time physical activity. And another study in the European Journal of Preventative Cardiology just generally found that being physically active reduces cancer incidence by 48% and cancer mortality by 27%. So how to get started with exercise, now that I took you through that. The one thing that people come to me all the time on social, whatever, is understanding how to actually get back into exercise after treatment and even during treatment. Because it's hard to know what to do when you don't know and can't trust your body. And if you are experiencing things like fatigue or you're experiencing pain, you just kind of want to be like, I can't do it, right? I can't do it, I'm not going to do it. But you can, right? You can, if you take these 4 steps to get started. Start small. Don't overwhelm yourself. I am the type of person when after I had my surgery, I wanted to get right back into working out. I was doing cardio kickboxing before that, wasn't lifting as much. I did bodybuilding afterwards. I wanted to get right back into working out. I walked every day, kept walking, and I got tired super quickly, and I got mad at myself because I wasn't at the same physical peak I was before surgery. And same thing when I got diagnosed with thyroid cancer last year. I went through the same kind of thing because I'm just that type of person. Don't be that type of person. Start small, like 5 minutes of walking a day. Stretching is fine. You don't have to stand up. You could do it in your chair. You could do it while you're doing dishes. I don't know why you'll be doing dishes. That's why we have dishwashers. But, wherever you are, set goals. Pick something that's realistic, right? Goals are really important, but it doesn't have to be outrageous. It could just be, I want to walk 10 minutes every day. That's all I want to do. And just try to stick to that goal. And if you can't, that's okay too. That is okay. It is okay. It's consistency over intensity over perfection. Get support. One thing I did before I even had my surgery is I came up with a post-surgery checklist of everything I needed after my surgery to stick and track. One of those was finding my community and people to hold me accountable. One of those people is sitting. He's sitting right there, and he held me accountable a lot, mostly telling me to stop pushing myself too much, but I don't listen to him, so it's fine. And then choose consistency over intensity. It's not about how hard you can go. It's not about how quickly you could get back into it. It's about what is right for your body. And what's right for your body is going to be consistency. So exercise during treatment. I actually broke it up into 2 parts, exercise during treatment and exercise after, because they do look different, right? So what kind of exercises should you do? Again, we have, depending on your fitness level, right? If you are already advanced, then it might take you shorter to get here, or you might be able to do more of this. But if you're a beginner, focus on walking, chair-based exercises, light stretching, right? And as you just develop your skill you develop your fitness skill, you go more to immediate low-impact aerobics, so it's like walking on a treadmill, doing indoor cycling, body weight exercises. You could do wall push-ups, glute bridges, squats if you want. And then you go into resistant bands and light weights for just gentle strength training. It doesn't have to be that intense. But if you're more advanced, running and jogging, doing kettlebell swings with a moderate weight, high intensity interval training, if cleared by the doctor. If cleared by your doctor. Next one. So managing movement by energy levels. I think that's the thing that's really, really important when it's during treatment, is really understanding your energy levels. So if it's low, just do some indoor walking. It could be just walking around your house, outdoor walking around the outside of your house. Dynamic stretching. So the thing about dynamic stretching, it's just you're moving through your stretch. So it could be if you're doing a hip flexor stretch, which I feel like I should demonstrate some of these things. So if you're doing a hip flexor stretch, and forgive me if anything is showing, here this would just be the static stretch. So a dynamic hip flexor stretch is more like you would move back and forth. So you kind of do like You move forward to kind of do your hip flexor, then you come back to kind of get your calf, and so that's like a dynamic stretch. Or you can do, not that, because I realize these are kind of short shorts. You know, it could be, you could do like butt kicker kind of stretches, right? Where you're like stretching your calf. So things like that, dynamic stretching. That's not so much a dynamic stretch, but you can get away with it if you are on stage in short shorts and you need to do something. And this is cardio, right? So if your energy is moderate, you could do light jogging, light rowing, indoor cycling, swimming at a low intensity. Those get your heart pumping, but it's still respecting how your body is feeling. And then when your energy is high, take advantage of that. Go running if you like running, try outdoor biking. You can even do indoor cycling at a HIIT version of it on your Peloton. Anyone have a Peloton? I do too. Let's become friends. You could do contact sports. You have to maybe be careful of the type of contact sport you're doing. Again, clear it with your doctor. Team sports and high intensity aerobics. And I do break it down for strength training as well. So if your energy is low, just focus on body weight movements. So I'm assuming we all know what a squat and a lunge is, right? Okay. You could do the wall sit. You could do a glute bridge. If you do not know what a glute bridge is, please look it up. I am not demonstrating that. And you can use stability balls, right? If you have a stability ball, those are really good also for flexibility, just by doing like crunches on it or taking care of yourself. When your energy is moderate, bring in resistant bands. That could give you some strength training in there, obviously. Or light weights, right? And I put down the weight sizes because people may not know what we mean by light weights. And then when your energy is high, kind of go push it yourself a little bit, see what you can do, increase the weight a bit. You could go for heavy weights, maybe pick up a barbell. Again, really listen to your body. And then with flexibility and mindfulness, that is something that you can do really throughout all of your energy levels, but despite it saying flexibility and mindfulness, it actually can get intense depending on what your type of workout that you are doing. So if your energy is low, static and passive stretching, breathing exercises, meditation, foam rolling, I should have brought a foam roller, restorative yoga, walking meditation, tai chi, and active stretching are good if you have a little bit more energy and you want to push your body a little bit more. And if you have high energy, try Pilates, power yoga, and PNF stretching. And so how often should you exercise? And I actually have like 7 minutes left. Like I said, I have a lot of slides, so I might just swing through it. So here's quickly how often you should exercise. For cardio, aim 5 days a week of easy walking. Like that's cardio. Walking is like one of the best cardio that you can do for your heart, for your body, for your mind. And then try maybe 2 to 3 days of additional cardio for 15 to 30 minutes. It could be light jogging, whatever you want it to be. Strength training, 2 to 3 days a week is really all you need for that. Even if you're like an intense bodybuilder, like you don't need to actually do more. And then flexibility, mindfulness, 4 to 5 days of stretching to keep yourself mobile, and maybe aim for daily mindfulness. That could be, 2 minutes of breathing exercises or meditation if you like it. And so exercise after treatment, this is what I was talking about, the post-surgery checklist. So build a circle of support, find an accountability partner, identify and address potential pain points. So for me, that was making sure my nutrition was on point. And so I figured out a plan of how can I make sure I'm getting my nutritional needs met while also being conscious of what I need to do to rest. And then create a sustainable fitness and nutrition game plan to ease back into working out. And let's see, this is the timeline. It's a very simple timeline. So for the first 2 to 4 weeks after surgery, after treatment, focus on walking, static stretching, breathing exercises, and meditation, again, if you like it. And then at the 4-week mark, you can start bringing in resistant bands. Kind of push your body a little bit more. indoor cycling. These are examples, by the way, just to give you an idea of what type of movements and exercises to go for. At the 8 to 12 week mark, you should be more recovered, that you could push it a little bit more, try a bit more weights, see what you can do, and then 12 plus weeks, you could hopefully be at a point where you could get kind of back into your routine and do what you used to do. And same thing, it's honestly during and after exercise is the same thing in terms of really how often you should exercise. I think the difference is during treatment, you're having this constant wave of kind of what you're feeling and the symptoms versus after treatment, if you're not on a targeted therapy, you're more just focused on recovery. And so this is just a way to ease back in. And strategies for optimizing movement. I'm just looking at the time. So these are really important points to keep in mind for staying safe during and after treatment. Check with your doctor first, right? I might be a certified coach, but I am not a doctor, and your doctor will know better about what you need. Protect your immune system. So opt for home workouts or workouts basically just to avoid high exposure to germs if you're still on treatment. Even if you're just recovering from surgery, you should just protect your immune system. Start slow. I'm gonna keep repeating that. Just start slow, don't overdo it, which is the next one. Listen to your body. If you're feeling dizzy, short of breath, in pain, pay attention to how your body responds and scale back when you feel discomfort. You might want to push it. You might want to see if you can, but listen to your body. Watch your energy levels. We all know cancer fatigue is real. We all know it is a thing. So if you are tired, if you're feeling fatigue, you don't have to say no that day, but you also don't have to go hard. You just do light little movements. And then stay hydrated. We all need water. Just keep drinking. And these are some red flags to watch out for. I'm not going to go through the whole list just to save time because I figured I would be the one to back us up, so I apologize for that. But yes, these are all symptoms that you need, they're red flags that you need to watch out for. So beyond dizziness and lightheadedness, things like nausea and vomiting, shortness of breath, excessive fatigue, swelling or discomfort, unusual heart palpitations, stop, seek attention, figure out what's wrong, do not keep going. Okay. So this, I know we have a nutrition session, but I did want to actually bring this up because this is, again, something that I am often asked about because I am a bodybuilder with one kidney, of what to do about your protein. And so if you are actually on a restricted protein intake, just focus more on optimizing that protein intake. It's important if before a workout to at least have 18 grams of protein and 20 grams after a workout. Research has shown having at least this minimal amount has helped maintain and improve muscle synthesis. I might be saying that wrong. Spread protein intake evenly throughout the day and go for easy on kidney options, egg whites, chicken, Greek yogurt, plant-based foods like tofu. And of course, check in with a renal dietitian about balancing exercise with kidney health because there's but so much I could actually advise you on. And then again, stay hydrated, but don't overdo it. It's actually not good to drink too much water. And my closing thoughts. Listen to your body, stay consistent, progress takes time, and empower yourself. And then, yeah, thank you, stay strong, and connect with me if you want. So this is the awkward part, so I don't know if I should just get off stage or just introduce the next person. So, thank you, that was too much. I should have timed it right. So, so now I am going to introduce Dr. Tracy Murray. She specializes in psychology at Ochsner Health. She conducts adult psychological evaluations and evidence-based therapy with individuals contemplating or undergoing cancer treatments, cancer survivors, and family members of cancer patients. Welcome, Dr. Murray. Make sure.
Good afternoon. How's everybody doing? Good, good. So I'm Dr. Murray. I'm one of the psychologists at the Cancer Center. Work closely with Mark Matrana. So today we're going to be talking about anxiety, which I could talk about all day. But for the purposes of this, it's how anxiety can change depending on what sort of spectrum you're on in your cancer diagnosis, treatment, or thereafter. Okay? I don't have any disclosure, so today we'll define what anxiety is, how it can look at different phases, what it feels like in the mind, body, and through your behaviors, and pinpoint very specific strategies to help manage these type of anxiety. So first of all, there is no such thing as no anxiety, right? It is bad, bad, bad to not have anxiety. If you can see this graph here, level of anxiety with level of performance, we can call that adherence, we can call that just getting up and going and doing what you got to do. If there is low anxiety, you will not be compelled to do much, right? But if there's too much, look at that graph, it's the same. You're not compelled to do much. What this can look like is that fight, flight, or freeze. When the anxiety is so overwhelming, you will fight or push back, you will fly or avoid, or you will freeze and be stuck and debilitated. So we don't want you with too much anxiety or awareness or too little anxiety or awareness. We want you what we call at the optimal stage of utilizing anxiety, meaning it's on your mind and you can use it to do what you need to do and get what you need to get done. In the context of cancer, no anxiety, oh, I'm not worried about that cancer, right? Too much anxiety, I can't make a decision. I'm debilitated, I don't know what to choose. Should I do treatment, should I not do treatment? Should I follow up with my doctor? I'm not even gonna go. Optimal meaning you're using information you have to make appropriate decisions about your cancer care, okay? So when we say, oh, I wanna get rid of that anxiety, no, you don't. We don't want you to. So just some of the physical symptoms about what anxiety looks like. Wide variety here. You might not have all of them, and it ranges in degree. What the most common ones I see are those GI symptoms. Boy, they're one-to-one, right? Headaches, muscle tension, GI symptoms meaning your stomach just is not quite right. I don't know if that's because we're Americans and the food is really bad or if it's because we have higher anxiety. But it's most closely related to those GI symptoms, the muscle tension, and that pounding heart, right? So you're like, oh my God, am I having a panic attack or a heart attack? Get it checked first to make sure it's not a heart attack, and then come to us and we can manage that, okay? Emotional symptoms, so these are the things that kind of are inside and not expressed outward. So that can be feelings of helplessness, hopelessness, doom. Impending doom can be one too, or feeling like you're in danger. Or that fun one at the bottom was called dissociation. That means you don't quite feel like you're inside of yourself, like you're looking at things as an aerial view, things don't seem quite real. That one tends to happen in more of a panic situation than of a low-level anxiety situation. Depending on what type of anxiety you have, you may have what we call flashbacks if it's more of a trauma-related anxiety. Then we have the thoughts and what you do. So think of the thoughts as your internal conversation with yourself. It could be your own voice or let me be clear, the voice of something else, but not an actual voice. It's more like your conscience, like that devil angel type of thing. It can be difficulty concentrating. So if you're finding you're watching TV, and you're like, what is going on with this TV show? I can't even, my mind, because it's elsewhere. That can be a sign that your anxiety is going up into that unhelpful, debilitating place. Just the blankness of the mind, like when you're making a decision about how you're stuck. You can't, you're frozen. You can't, I don't know what's going on, right? That can be a symptom of anxiety as well. Quite commonly feeling like you're going bananas, right? Like you're going crazy can feel like it. So there's so much going on in the mind that you can't even grab one thing to make sense of it. So when it's that way, we have to work to turn it down so the stream of thoughts, the stream of worrisomeness just slows down so you can capture it with greater ease. Now the behavioral part too, withdrawal, isolation, agoraphobia means you just have a fear of being out in public spaces. You'd rather be safe at home. Irritability is probably the most common one, short-fused, right? When you're not feeling well under a cancer diagnosis, that's the one that comes up quite often. If you're fatigued, if you're not getting good food, if you're just overall just feeling really poorly, your fuse for nonsense, for stress, is just very much shorter. So we work at lengthening that out, okay? Some people try to use other things outside themselves, like drugs or alcohol, to help reduce these symptoms. It just doesn't work for very long or very well. So we have very much so other strategies that we can use, okay? So, anxiety works on a spectrum, okay? That spectrum and the severity of these symptoms can vary. You have anxiety, which is kind of the lower end of the spectrum, general irritability, then you have distress. Distress feels differently in the body. It really goes into that place where we talk about being debilitated. So it may be that you can't leave the house. Like the stream of thoughts is going particularly fast where you can't catch it. Chest pains, so it's really up to the ante in terms of distress. This typically happens at diagnosis or when you're going into a transition phase of treatment. Pending surgery, you're starting your adjuvant chemo, or you've had surgery, now you're in a different phase of transition. Distress can be very high. Then we have panic. Panic attack, or some people call it an anxiety attack, but it's a panic attack, is a short period of time, about 3 to 5 minutes, maximum 7. You don't experience a panic attack for 2 hours. That's distress. Some people say, oh, I was in that panic attack for 2 hours. That's distress. Your body cannot sustain a panic attack that long. But a panic attack does feel like you're going to die. That is the most severe when we think about that anxiety spectrum, and how you treat each phases of that spectrum varies. Meditation, deep breathing won't work as well in a panic situation as it would in a lower level anxiety situation. You really have to change your body's chemistry, which we'll talk about, okay? You have to do something to change from one side of that nervous system to the other before any of these low level anxiety symptoms can work, and that includes medications, okay? Not only medications, but you can use other stuff too. Okay. So what causes anxiety? Natural biology. Some people, it is a combination of nature and nurture, but greater likelihood if someone in your parents, i.e. your parents, have had some history of anxiety. Your brain's chemistry. If we are intentionally doing things to you to attack cancer, it can change your brain's chemistry and how you respond to stress, okay? If you are dehydrated, if you are hungry, if you're not sleeping well, what's going on in here changes, and that changes and flexes how you take in stressors in the world, okay? So sometimes it's not about managing the anxiety itself, it's managing what is causing this, right? What is leading up to this. Hormones, if you have a cancer that is specifically susceptible to hormones, and we're taking away your estrogen or your testosterone, something's gonna change, right? There's not much we can do about that, but we can treat that. Inherited traits and the environment. External substances like coffee, I'm so sorry. Coffee makes anxiety worse, right? It's just any stimulant, caffeine just presses the gas on coffee. So if you have a worrisome thought and it's going 3 brain miles an hour, caffeine will make it go 30 brain miles an hour, okay? Just know that if you have that happen, just slow down. Don't pound the coffee, maybe not 10 cups a day. If you're a veteran, I used to work with the vets too, they'd be on 2 pots, right? So not the 2 pots, or maybe doing decaf coffee. Now remember, decaf still has caffeine in it. It's just decaffeinated. It has about 8 milligrams per cup. Tricky, I know. External substances like alcohol too. Alcohol is a tricky one when we're dealing with increased stress. In the beginning, when you're drinking alcohol, and I'm gonna run out of time, when you're drinking alcohol, it gives you a buzz, but once it's metabolized out of your system, your mood symptoms are worse than where you started before, okay? So when it's in there, it's fine, but once it's burnt out, it impacts sleep, pop up, your body's chemistry, you may sweat, and that's not in excess. That's just because you're having more stress, that brain is working differently, it responds to external substances differently. Outside of cancer stress, you might be just fine, but with the stress of this, your body and brain interacts quite differently. Okay, how does it look at different phases? So I'll just give a caveat about well-being. It is about balance. There's no such thing as no stress, but if we have stress, we have an option here. Solve the problem or manage the stress. Cancer treatment is not necessarily a problem that can be solved, but we can manage it until it's done, right? We're in a perpetual state of financial disarray, right? Can't be solved, but we can manage the stress, thereby creating balance, and your body will fall in line. Okay, so anxiety at diagnosis. That is, you just got the diagnosis, just got the call back. You're having physical symptoms, something's going on that they haven't figured out. You're awaiting the doctor's appointment. You're not yet staged. That is an anxiety-provoking thing for a lot of people. They really hold on to this staging, 1, 0 as opposed to 4, when in that conversation it might not necessarily change a treatment plan, but it's anxiety nevertheless. You're not unsure of the treatment plan. You just don't quite understand. The doctor's talking to you, you're listening, but you're not listening. You're not hearing them. So that can cause a lot of anxiety too. Symptoms of the disease that are not managed. If you have a great tumor burden and it's causing a lot of pain, that is going to make anxiety and mood symptoms much worse. So here is what we do at this specific stage. Remember, this is a stage of transition. It feels quite differently. Distress and panic are high. This is not low-level anxiety. Remember when I talked about that spectrum? So we do something called accepts. So that is distracting the mind. There is nothing you need to do to talk about anything at all right now at the stage. If you've got your treatment plan and you're waiting on chemo or immunotherapy or anything to begin, you're waiting for the prescription, what is the reason to continue to talk about it? There is none, right? Not at this stage. Once you're getting information and you're developing a treatment plan, cool, talk to your family, plan, get things done. But once it's done, you're belaboring it now and you're just feeding into the anxiety and making it worse. So have 1, 2 rounds of conversation, making your plan, but not exceeding that to get into excessive conversations about it. Anxiety is going to want you to do that. It's going to say, you know you want to talk about this again. You know you want to look that up again. Oh, what's that little word in the pathology report, right? But it's not necessary at this point. It's actually causing harm to you. Okay, so we use distracting things, activities, things to do. Some people, when they have stress, they need to actually do things with their hands. They need to learn something new. They need to get completely outside of where they are. How am I on time? I don't have my watch. Okay, get outside of where they are. Push things away and changing the physical in the body, massages and things of that nature. And you can self-soothe. I know some people struggle with the mindfulness, but most people cannot clear their mind. Only monks can really do that because they do it 24/7. So you need assisted mindfulness. You actually need to hear someone telling you what to do to cause interference with your thoughts, if that makes sense. If your thoughts are running and thoughts are strong and you're in distress or panic, mindfulness in its original state won't necessarily be effective. So it's not you, oh my God, I can't do this. It's just not appropriate for that phase of anxiety, okay? Lean on others and limit information overload. If you have a question, ask your team. Dr. Google is not your team, right? Because they're not taking into consideration other parts of you. Your doctor is. How strong you are, right? Whether or not you are adhering to what the doctor is saying. Are you doing other components? Mentally where you are. Your doctor can take that into consideration when talking about plan, prognosis, and how well you do. Dr. Google can't, okay? All right, during treatment, it changes. So once you're over the hump, you start the treatment, you've had your surgery, that anticipation anxiety changes. Now it changes to more of that lower level anxiety, maybe a little bit distress. not quite panic, because you've now got an adjustment, you have the plan, you started whatever is going on. Now here comes the questions, right? Is this working? Oh my God, what am I doing? Am I doing everything I need to do? Is this worth it? You're managing the side effects of treatment. If side effects are heavy on you, your mind will fall in line. So anything that you do in this space, focusing on making sure your body is managed and your mind will fall in line too. Major changes in life, if you had to take off work or you're purely bored, right? If you've been working your whole life and engaged round the clock, you're a worker, and now you're just getting your treatment and going home, I don't recommend to people, if they don't have to take off work for doctor's advice, then don't, right? You can do intermittent leave if you can at your job. If your mind is still sharp, the mind has to be worked at that point, or it's going to worry because it's idle, okay? Financial issues and toxicity, right? Start to come up, reaching out to your resources wherever you are. And then second guessing, should I have done this? Should I have done that? Am I picking the right doctor? Is the team really for me? Are they hiding stuff from me? These are all the kind of internal conversations that you might have. So what you do is control what you can. Input, output. You very much so have control of what you're putting in your body and what you're doing with your physical body, right? So movement. If you're worried about treatment working, do everything you can to help it along, right? I want you to, at the end of the day, it wasn't by function of me and what I didn't do that caused whatever outcome to come. You can say, well, I did everything I could. I made sure I ate, I moved my body, I reached out to resources, I kept my mind occupied, and I managed the anxiety. Prioritizing basic needs. For some reason, human beings let the basic needs go first whenever stress is high. You stop showering, you stop eating. It's something about brushing your teeth when you're stressed out. I'm serious, this basic, anybody remember Maslow's hierarchy? At the bottom, that's the foundation. If those basic needs aren't met, the whole of you begins to crumble, right? So if nothing else that you can focus on is just making sure your basic needs are tended to, spending time outside as well as inside. If we're not in a hurricane, don't go in a hurricane, okay? All right, keep moving, keep physically moving, seek out resources, let others help. If you have questions about burdensomeness, that's a big one, right? Am I being a burden? Am I taking them away from loved ones and so on and so forth? People who care for you also want to be able to do something about cancer for you. So if the only way that they can help you is to give you a ride, give you a tuna casserole or a green bean casserole, or get you some toilet paper before it runs out because of what we got going on, let them do that. It makes them feel good. So it might not even be about you. It's this word called altruism, where when they do something for you, it fulfills them in some way. That is not burdensomeness, okay? And do things outside of cancer. Your life is way more than a cancer diagnosis and treatment. Sometimes you shouldn't even talk about it. If you go to lunch, catch lunch with your friends, this is a cancer-free conversation, right? You've had life before this. You have much to talk about. So sometimes we shouldn't even be talking about it all the time because it does nothing but provoke anxiety. Okay. Now, when it changes again, a period of transition, when we complete and beyond, it's that fear of recurrence. It's that readjustment back to or changing to something new, right? It's managing lingering side effects. It takes some time. A toxin has been in your body, so it takes some time to readjust. And then for those who may be on lifelong treatment, so if they're going, or longer treatment than a few months or so, for a year, what the questions are is set your goals for living, right? Similar to how you set goals for exercise and nutrition, you set SMART goals, which are specific, measurable, achievable, realistic, and time-bound. Values-based living. If everything you do every day are not important to you, the things that you do, why are we doing it? It should be balanced, right? With the things that give you fulfillment when we gotta go to work, right? So we balance these things. It should not all be tasks that you have to do for some reason, but balance with tasks that you wanna do. Another thing that I use is called meaning making. Yes, no one ever wanted you to have cancer, but what meaning will you bring out of this? I have a story for that, and then we're gonna zoom through this. I had a 24-year-old woman who had leukemia, and she needed a bone marrow transplant. I asked her the same question. I say, what meaning do you want to grab from this? And she said, well, I never knew my brother cared about me. I thought he was just 18 years old, living his life, and then he came and donated his cells to me. And now our relationship is great. Not saying we wanted you to have cancer to have that happen, but you can choose whatever you want to carry from this experience and not choose to be something helpful, right? So that's meaning making out of a tough situation. It's not positive thinking, it's just the truth, right? It's what you want to carry to keep you propelled and going forward. Okay, reintegrate with life. Get back into living. I don't think you should have stopped, but you carry on. Okay, so this is real quick about how to manage that worry. I don't know if you can even see it clearly. It's my cancer must be spreading because I am more fatigued. So we really balance that between a hierarchy and answering yourself questions. So you basically simply ask yourself two things. Is this true, and what else could it be? If this is 100% true that my cancer is spreading because I'm feeling fatigued, then tell your doctor. But if not, if it could be, well, I didn't eat today, then there's a conversation to have happen about changing goals and managing yourself, but not all thoughts are 100% true. Okay. Just another quick one. This is the one, and I'm gonna wrap up here, but this is the one about managing your body's chemistry. If you're in a state of panic, it's gonna seem weird. Stick your face in a cold bowl of water. Way before we had fancy defibrillators to bring your heart rate down, they stuck people's faces in ice buckets of water to bring their heart rate down, right? So that will trigger your body and brain's response to say chill out when it's cold. It will switch from the active fight and flight to the chill out part of your nervous system. So that's the one that I tell people stick their head in the freezer all the time. It's that age-old idea of splashing cold water on your face. Your body will call for that. You can hold ice cubes in your hand, put ice packs on your face, but that's dedicated for that panic phase, when the breathing strategies doesn't work, when the distracting your mind doesn't work, to bring the body's chemistry down, and then you do those skills and strategies. Okay, the goal is to manage anxiety. No such thing as anxiety, no anxiety. So it's all about balance. Solve what you can, manage everything else, and talk to someone for help. If you don't have any family, talk to me. All right, any questions? Oh, we saving questions, okay, cool. Thank you.
I will introduce the next speaker, Dr. Edward Chabito. He is the Dean of the LSU School of Public Health and Professor of Cancer Epidemiology. Sorry, I'm tripping over those words. He is also the Deputy Director for Population Science in the Stanley S. Scott Cancer Center. Much of Dr. Chabito's career has focused on cancer epidemiology and cancer control. Please come up on the stage so I can stop embarrassing myself with speaking words.
Well, thank you for that introduction. It's good to be here. Thank you for inviting me, and I've been impressed with the speakers that I've heard, and I'm happy to talk to you today. This is going to be a different subject than you've been hearing. I was asked to talk about environmental exposures and cancer, and in particular kidney cancer. There's not a lot of data on it, but I have some to share with you. So let me just start by showing you something from our Louisiana Cancer Registry, which records information on every case of cancer among a Louisiana resident, even if they're diagnosed at MD Anderson in Texas or St. Jude's. We have information on every resident of Louisiana who's been diagnosed with cancer. So this is incidence. These are the number of new cases and the rate of new cases. And so the map on the top left gives you an idea of the distribution of kidney cancer cases in Louisiana with, I'm sorry, I'm colorblind, but with a darker color being the higher rates. On the right, you see what's been happening over the course of time in terms of the incident rate for kidney cancer. And so, yes, there has been an increase. We'll wait and see whether there's really a decrease that's been kind of all the way on the right That could be due to the beginning of COVID, but we'll see. This is the next one on the bottom left is the age of diagnosis for kidney cancer. And although most of the people I've known personally who have or have had kidney cancer, most of them were younger. The highest incidence rate, the point at which more cases are being diagnosed, are in older ages. And then the bottom right compares men and women and blacks and whites in Louisiana. And the higher bars are for men, the lower bars are for women, and there are marginal differences between the two racial groups. Now this slide looks at mortality, at death rates. And the first thing to notice is that death rates are going down, although not that fast, but they are going down over time. And that's presumably due to earlier diagnosis and better treatments. And so it's, that's progress. It's not as much as we want to see, of course, but they are going down over time. And then there's a slightly different distribution of deaths across the state, and that may have to do with availability of treatment and availability of earlier awareness and detection. So let me just start with the risk factors for kidney cancer. And I'm sure you've heard this ad nauseum, but let me just go over it. You've heard about physical activity. You just heard someone talking about that. And you had alluded to, a couple of people alluded to nutrition and food and drink consumption. We're going to talk about environmental exposures, elevated blood pressure. So if blood pressure is not controlled, that can make it worse. Gender, we saw a difference between men and women. Older age, we talked about smoking. So I'm assuming nobody here smokes anymore, but if you lived with a smoker or live with a smoker or are exposed to environmental smoke, that increases the risk of kidney cancer, and it increases the risk for a second kidney cancer. And so that's really important. That's one of those things that's avoidable. Obesity, and I don't see any obese people in the room, which makes you very unique in this world and in this state. We do have a problem with obesity across the country, and in fact across the world. Diabetes is a risk indicator and a risk factor for kidney cancer. Hormones are involved in kidney cancer development, and some of the chemicals that I'll talk about actually can interfere with hormonal levels. And genetics, that's the one thing you can't choose. They say, what can you do to prevent cancer? Well, choose your parents. It's not quite that easy, but genetics are certainly an important risk factor, but there are lots of people who have bad genetics for a cancer and don't develop it, so it's not an automatic guarantee. It's not as simple as just who your parents were and what you've inherited. So this is a simplistic diagram of environment and what it does to the kidneys. And in the top you have air, water, and soil pollutants. And why is that important? Because we get these chemicals through inhalation, ingestion, and skin exposure. Then you get to the other part of the environment, the climate. And, whether it's excess heat days, which we've all experienced, extreme weather, which we've all experienced, or some combination of those, floods, fires, all of those fall into the category of climate and what those do. Now, we can't control the climate personally. I mean, yes, politically you may be able to do something, but the bottom line is we've always had hurricanes, we've always had heat, but the heat's getting stronger and hotter, and in some areas of the country colder, and it's coming more often. And I will talk to you about how that not only influences cancer occurrence, but how it interferes with treatment. On a very hot day, your likelihood of wanting to go in, a patient's likelihood for wanting to go in for a medical exam is going to go down. The likelihood that they're going to go out to the pharmacy and get their medication goes down. In storms, take Asheville, North Carolina right now. Asheville is not just, they've got flooding today, but by in a day or two it's going to be over and everything will get back to normal. Much like Katrina, when there's damage to an entire area, pharmacies are out, hospitals are out, roads are out, electricity is out, dialysis is out, and so these events do have an impact on getting access to treatment, and even the hospitals can't necessarily be very helpful because they're dealing with the same thing. They try ahead of time to transfer patients, but there are real problems here. And then had the port strike continued, there are also supply problems. So I just heard that one of the only plants that manufactures IV fluid was affected badly by the latest hurricane. And so they've started to have to ration what hospitals are going to be able to order for IV fluid. This slide talks about PM 2.5. PM 2.5 is air particulate matter. That those are not ultra fine, but they're fine. And we breathe those in all the time. And mostly they are associated with other cancers, particularly respiratory cancers. But it has been shown to, in a cohort of kidney transplant patients, it was associated, higher levels were associated with post-transplant graft failure and all-cause death. So high particulates are not good to inhale for anyone, much less somebody who's dealing with medications, immune issues, and concern about mental stress and concern about potential recurrence. Water. So drinking water is obviously critical to the functioning of the kidneys. Unfortunately, drinking water has problems, whether it's lead or arsenic or a variety of chemicals. For example, the runoff chemicals from agricultural waste, which we have in the state, is treated with strong disinfectants to prevent infectious disease transmission. And yet part of that process results in two classes of chemicals which are carcinogens. If that gets into the drinking water, we've got a problem there. And it does get into the drinking water. Arsenic. We have a lot of arsenic in the soil in Louisiana. We're not the only state that does it. And it actually gets into our rice. And rice is considered one of the healthier things to eat. But in fact, there's a fair amount of arsenic in the outer husk of rice. And so we're ingesting that, and arsenic is a known carcinogen. And we've seen studies that have looked at exposure levels of some of these chemicals, and they've been associated with kidney injury and chronic kidney disease. So this is you'll notice in this middle, the boxed areas, phthalates, BPA, and PFAs. You've all heard about these forever plastics that are in our oceans, in our water supply, in all of us. And those are from packaging materials. They're from water bottles. We get them in our water, we get them in our air. Unfortunately, several of them are carcinogens as well. Chronic kidney disease has been somewhat associated with ingestion of PFAs. It's still a little early. The research hasn't been done entirely. And unfortunately, it's pretty hard to avoid these. Using less, storing things in plastic containers, which I do, drinking water from plastic water bottles, which I do, only increases my likelihood of having PFAs in my body. The Go cups that they pass out at Mardi Gras, and I keep drinking out of those, not a great idea. Go for glass. That's why, glass is going to be much better for you in that sense. Continually drinking out of plastic containing containers, which doesn't sound right, it's just really, from what we know, that's not good for you, and it's certainly not good for the prevention of cancer. Endocrine disrupting chemicals. So these are chemicals that are produced or are byproducts of a number of industries and polluting aerosolized pollution, and they affect the endocrine functioning of the organs, which of course affects the hormones and the functioning of many of your organs. They affect glomeruli, renal tubules, lead to diabetes, and renal fibrosis. I don't mean to scare you, but there's a lot of stuff out there. And nobody can live no matter what lifestyle you live, it's not going to be perfect. So part of it is you can't worry about everything, and so you pick and choose what you want to worry about. This slide looks at environmental exposures and cancer in Louisiana. And so this one, the darker bluish, purplish colors are the higher cancer risk. And this one is for arsenic. And you can see that where cancer rates are high, which is in this industrial corridor area, and then going all the way down to the Gulf Coast, arsenic exposures are higher. This is chromium and cancer risk, and it's a little bit, it's not just over there, it's also here. So those are, again, higher rates of chromium exposure and higher rates of cancer. Nickel exposure is also higher in some areas, and you see a similar pattern. Cadmium is also produced as a byproduct in the state. Mercury, not so much. We're not really worried about mercury, fortunately. And this is particulate matter. So the darker areas, so this is PM 2.5 concentration, and the higher the particulate matter, the higher the rates of cancer. Now, we're not unique in Louisiana in terms of industry. We've got our issues, of course, but we're not unique. I realize you cannot see any of this, and that was not on purpose. The left column has all the chemicals, and the rightmost column has the effect on the kidneys. These slides are going to be available on the YouTube presentation, and so you can run it and stop it and freeze it, and you'll be able to see the chemicals. This is the impact of climate on health. I talked about climate for a few minutes, and so obviously, so on the left you have all the different climate pieces, and then on the outer circle on the right, you have medical and physical health, mental health, and community health, and all of those add to stress to relate back to the last speaker, and so it's not going to cause cancer in that sense, but we do know that these are going to interfere with treatment and diagnosis, treatment, follow-up, access to medications, access to clean water. People who work in excess heat occupationally have been, they've ended up having more kidney injury, and then combining that with sugar-sweetened beverages, we see more kidney injury. Extreme heat events has been associated with patients not being able to receive in-center hemodialysis. And so we're just learning more about these. These are early in the field. Let's see, that's okay. So prevention. I think I missed a slide here. There we go. All right, this slide shows the river, Mississippi River, and it shows factories along the Mississippi River. And, factories locate along the Mississippi because it's less expensive to get land, and because they can have a way of sending their products down the river to the port, and also because they can dispose of some of the waste. And if you were to look at the cancer rates in many of these, they are elevated, not uniformly, but depending upon what people are exposed to. It's actually very difficult to sort out all the exposures because there are so many of them. Oh, am I out of time? All right, I'm gonna have one more slide. Okay. So what can you do? Quit smoking, get away from people who are smoking, don't be in a confined room where there are smokers. That's probably one of the most important things you can do. If you've got family members who smoke, you gotta do more, they've gotta do more. It's just not gonna work out. More fruits and vegetables, and eating both of those, particularly those that are high in fiber, lowers the risk of kidney cancer. Control blood pressure, maintain a healthy weight, limit workplace exposure to chemicals. In your home, if you're working with chemicals, because we all do in terms of cleaning and stuff, make sure the room is well ventilated, because there are noxious, it's called indoor air pollution, there are noxious exposures there too, and those can have an impact. And that finishes my talk, and thank you for listening.
So, Ro Arcott, one of the neurologic oncologists at Ochsner. First, thanks for all the talks. I thought they were super interesting, each one of them uniquely interesting and important, I think, for all of our cancer care survivors and those still undergoing cancer treatment. But I guess my question is for Dr. Murray. With respect to anxiety, it's definitely not something as a surgeon, I think I don't say we don't think about it, but I think we pride ourselves on trying to provide the best counseling message we can so that patients don't have that anxiety. But I guess my question is, how long, or how when is it more devastating? Is it the pre-treatment, the anxiety level, or do you see that more people are really struggling with it after even treatment and being curative? Like, where's that tension point? I think it would be obvious before, but do you find afterward it's just as challenging?
I think it would depend on a few factors. One is pre-existing mental health concerns, and that can dictate, so those were there before, they'll be there after. But those periods of transition is where I find people are the most distressed, often panicked. So at the new diagnosis, immediately in the days leading up to a surgery is where they experience the anticipation anxiety. And that can only be solved once the thing that's causing that anticipation is over with. In the periods where people have adapted and gotten used to things post-surgery during the course of treatment, it's still there, but it's in terms of severity and in terms of acuity, not quite as high. So I would say the pre-existing conditions and periods of transition. And that includes transitioning from treatment to no treatment. I play around with this word survivorship because not everybody identifies with the term survivor. So I say post-treatment. But periods of transition is where I see it the most in terms of severity, that distress and panic. Think the night before surgery, they're, well, boy, right? But encouraging them to that it will change. So if you're noticing that with them, specifically with you, that it will change once the surgery is complete. You understand that it's that anticipation, but once they're over that hump of surgery, it won't be as severe as leading up to it. Does that answer? Yeah. Okay.
I have a question for our MC, Anna Maria. So I am an oncology dietitian. I'm on the front lines. I'm also a healthcare consumer, but my bread and butter is in medical oncology clinics, and I find I get increasingly frustrated that I'm the only one advocating for movement. How do we raise awareness? How do we promote more movement for our individuals that we're helping?
So I think the one thing I would say is stressing that, okay, how do I articulate this? I might have to do like a backstory or some back. So one thing I've noticed as a coach that tends to be a misconception, misperception is that movement is intense. Right? Exercise has to be intense. Like you have to be running or lifting weights or doing all these things because unfortunately social media and the inundation of all these different fitness coaches perceive that. And there's this idea that if you don't move, it's because you don't prioritize your health, you don't care about your health, when in fact it's like you have a life and you have a certain life that you're living and you have to find a way to make fitness fit for it. And I think that's where we need to start. We need to start by making people understand that movement does not have to be something that looks the same for every single person, and that we can find ways to make it fit for each person's life. And I think that even goes for saying it to doctors, saying it to healthcare professionals. It's like when you're promoting movement, it doesn't, the whole 30 minutes a day, 100, a lot of what we know about fitness and movement is outdated, and we need a lot of new research that shows what your body really needs. Because even 5 minutes a day does a lot for you. And so I think that's kind of where we can start. I don't know if it answers your question, but I think that's a place that we can start, is making people understand that it's not about having this certain regimen where you're lifting and you have a split, or you're always jogging, or you belong to a group, but that it could just be as simple as doing squats while you cook. When I was first diagnosed and afterwards, and I was getting back into it, I used my son as a weight. He was what was he? 5? How old was he? I don't even remember. He's 9 now. So yeah, he was 5, and he was a weight for me, and I was using him during my squats because I wanted a weight, and I was just taking care of him. So that's what I would say. Starting is just making people realize that movement is anything.
Dr. Matrana, would you say a word or two about what you and I discussed privately before this session about the poor bedside manner of most physicians and how they could minimize stress by being better educated about how to deal with patients?
Might be good for Dr. Matrana and Dr. Murray.
Sure. Yeah, we were discussing, and you mentioned that you thought about 5% of physicians that you encountered had a good bedside manner, and it's a pretty shocking statistic. I was very fortunate. I was very, very fortunate during my training as a fellow that I went through 2 years of communication training on how to give difficult news, how to deal with difficult patients, how to alter how you approach patients based on their cultures, and so on and so forth. I'm not saying I'm an expert at it. I think it's something we can always get better at. But I think the first thing for any healthcare provider is to recognize that it's important. It's important to be able to communicate with patients. And then to know that there are resources out there. There's training out there for people who want to get better at it. And it is something people can improve. It's definitely something people can improve on it. So it's a big piece of the puzzle for sure. One thing that can just help, a quick tip, is just asking patients to relay what they understand. Because the way a patient may see something and understand it may be very, very different than their healthcare provider. So often when I meet a new patient, that's a few of the first things I ask about who's with them in the room. 9 times out of 10, you can figure it out, right? It's an older man, older woman, they're probably married, but you don't know. It's the 10% of the time that's really interesting. But you'll ask, who's this with you? And then, who do you live with? Tell me about your family. Where are you from? I like to get to know my patients a little bit. And then I'll ask them, I'll tell them, I've looked over your chart. I understand what's going on. I've talked to my colleagues. But tell me what you understand about your condition. And that gives me great insight into where they are and where we need to plug holes. So I hope that helps.
Then there's me, right? So I will say healthcare is making better strides at that as we move along. There's someone like me integrated into the cancer center there, and I actually train the fellows and the residents on these specific topics. And last week we had a training on how to discuss difficult conversations with patients with our advanced practice providers, and I led that talk too. So we're working on it, okay? Part of the thing too is that a lot of physicians do go in with what their natural inclination to communicate is. And that's not bad or good, it's just, it may not fit for you. So what I often tell patients is to let a provider know how you receive communication and if their style and approach for you is working for you. For example, I do the pre-assessment evaluations for transplant, for stem cell transplant, CAR-T, and bone marrow transplants. So the doctor that they see in clinic might not be the doctor that they have in the hospital, which is often true, right? So I do this questionnaire to say, you best receive information with a thumbs up and thumbs down. You don't need anything beyond that. So the doctors coming in, they need to know that about you, right? Like, doc, I don't really want too much, because they're coming in middle of the ground, whatever approach that works for them. But if you're a person that needs more details, that needs less details, that needs it discussed in a certain way, tell them that. And give them a chance to accommodate. But if not, switch providers. We do that all the time, because sometimes this is a different thing. This is, you'll be with people for the long haul, and believing that your doctor is communicating well with you can impact your adherence out of your awareness. So that conversation, so tell them. If you're like, all right, doc, tell me a joke every time I come in here before. Let them know what you need so they can. So the onus is part on you and part on them too.
So there was a question earlier, Mark, actually from this gentleman here, about screening for kidney cancer, and we discussed that there is no routine screening for kidney cancer available, but it was brought up that we have a study at Osher related to cancer genetics called Pathfinder So I was wondering if you could speak a little bit about that and its relationship to signal and GU, if there is any.
No, thanks for that. So, there are only a handful of cancers that we screen for in this country. Largely, this is based on the United States Preventative Services Task Force recommendation. This is Congress's arm of screening recommendations. They actually meet, that organization, once every 2 years, and that's due to funding. And they make the recommendations of patients should have mammograms this often and colonoscopies this often. But it hasn't been found that routine screening for other cancers is useful or improves outcomes. And so we have a study at Ochsner of a technology called multi-cancer early detection, specifically with a company called Grail. The test is called Gallery, and the study, the study that just finished enrollment, is called the Pathfinder 2 study. And it's essentially a blood test that can tell a patient if they have one of 50 different active cancers. It doesn't tell you that your risk is increased. It doesn't tell you about your family's background or ancestry or hereditary information whatsoever, or it doesn't tell you anything about the genetics of the cancer itself. It just tells you if you have one of these 50 different cancers. The test is FDA approved. Excuse me, the test is commercially available, but is not FDA approved yet, which means it's not covered by insurance. The study paid for 2,000 patients at Ochsner to have the test. It's an $800 test, so it's not cheap. We've also had several hundred patients who have just come in off the street wanting to do the testing and paid for it out of pocket who didn't necessarily qualify for the study. We're opening a larger study of 65 plus, individuals 65 plus, who don't have active cancer and have not had cancer in the last 5 years for this study as well. So if people meet that criteria and want more information, we should be opening that in the coming months ahead. But more to follow on these tests because they are becoming more routine, and I have no doubt in my mind that one of these tests will be FDA approved. There was just one for colon cancer called the Garden Shield test, which is now a blood test that you can do for colon cancer. That is FDA approved, and payers will be paying for that. It was just approved, so it'll be next year when payers start picking that up. But essentially, a lot of patients won't necessarily need colonoscopies, so they can do this blood test instead of that one. But many companies are trying to get one of these tests out of the box. It is not great for picking up the Gallery test, the Grail Gallery test, is not great at picking up kidney cancer because it is best at picking up extremely aggressive cancers like pancreatic and these cancers that shed more DNA. But the jury's still out. Give it 5 or 10 years, ask me that question, and we'll all be getting a cancer blood test at our PCP's office each year.
I want to just tell people that one of the problems with these kinds of tests is they may find things for which there's no treatment available yet, and that somebody taking that test and finding out they have some condition that you can't do anything about, not everybody wants that answer. For a while, companies were doing whole body CT scans to find something, and they sure as hell did. The problem was a lot of things they found were not things to be worried about. And I asked some of my classes, if you could be told now that we have a test that absolutely says you're going to have Alzheimer's later on, would you want it? And I teach graduate students, so they're pretty young. Almost all of them said yes. Most of the faculty said no, not yet. So it's a little bit of a trade-off. Be careful what you wish for, because you want to make sure, I mean, just for me, just to be saddled with the knowledge that I have something that I can't do anything about, but I'm going to die of it, I'm not sure, and we're all going to die of something, I'm not sure that's what I want.
Yeah, and that's where our genetic counselors come in. We've hired an army of them, and we're actually starting a master's degree program with Xavier to make more of them because there's just not enough of them. But they can help people both from a psychosocial standpoint and a genetic standpoint try to put this together and make the right decisions because it is tough. It's really tough.
All about balance, right? So you're balancing out the need for this information with this information, if it's futile or not. So
that varies for each person.
So a statement and a question. Anna Maria, first of all, I'd love to be your friend on the Peloton. One of the things, though, that I found, and actually my internal medicine doctor advised me of, is I used to be in very good shape before my cancer diagnosis. I was very frustrated afterwards. A, because of fatigue, I just felt like I couldn't. B, because I had mets in my lungs, I felt like I shouldn't. All excuses. What my internal medicine doctor told me was that leaderboard, because I'm very competitive, that leaderboard, I was always in the top 10%. Also knows in 50% or lower. And he's like, do yourself a favor. Clear your leaderboard. Get rid of all those stats because you may never get there again, but that's okay. So, question though for Dr. Murray. I noticed, a lot of the markers that you put up on the board, I've gone through a lot of those. I also noticed, though, that my caregiver is still going through a lot of those. What can I do, what should I do to help give her the guidance? And she's very proud, very stubborn, but to help her, give her the guidance on, talking to somebody, getting some help for those.
Two things. First thing, the meaning making just for you. The fact that you were as healthy as you were going into cancer diagnosis did you great, right? So always reflect on that as well. You were if this was going to come down the pike for you, you were as healthy and managed as well as you could because you were in that position. Second thing, I would say, depending on your communication style, I would discuss with her how it's impacting you, okay? So if she's all about you, caring for you, making sure you're good, and she often denies herself, say, hey babe, what you're going through is now impacting me and I want to see you flourish, okay? So even if you can do this and work on yourself, and that will help me. You're saying the same thing, but it's a different spin on it. Because if this whole time she's done things to help you, she's denied herself. But now, you denying yourself is hurting me. It's worrying me, and I don't want us in that perpetual state of worry. And then she can maybe ease up to go seek that out. But that's a complicated question. Yes. But I would start with that. Just make it about you, right? If she's all about you, make her getting help about you too.
So though I'm not on the panel, this is kind of also to answer or to add to what you've asked, Rich. One of the things that we found with both caregivers and patients alike, especially spouses, I know we see it with parent-child dynamics, but particularly with spouses, you both are very protective of each other, so much so that you guard your true feelings in your own way of trying to then support the other person. So one of the things that we recommended in our group, in the group session, is have receptacles with little note cards. Ask each other questions or make comments. Put it in that person's receptacle. They get to look at that card and either answer that question or respond on the flip side of that card in their own timing. They put the card back in your box. Ever so often, you both can either have then a sit-down conversation based on what you put in on those cards and in those receptacles, but it gives you time to both process your feelings, but also to think about kind of what you would want the other person to know. And that gives you a less confrontational, I have to answer right now. It takes a little bit of that stress off, but we also know that writing gives you a chance to kind of process too, as opposed to always being ready to have a rebuttal or an answer to the question being asked. So that's one way of doing, having communication, or just giving simple, short answers or feedback to each other and being able to put that in the box. Okay? All right, we have time for one more question. That's Sam.
I'll let someone else go if they want to. Why? I'd say my question is more so for Dr. Trapido. I work in the environmental sciences. I've doing remediations at oil and gas sites, and And so the group I work with, we kind of pay attention to new laws coming out or new restrictions on, environmental, rather oil and gas releases into the environment, stuff like that. We heard murmurs about PFAS, phthalates, and others, possibly the EPA doing something about that, but then nothing ever came, at least from my understanding, nothing ever came about it. Are you aware of any efforts being made to push for some type of control on those chemicals or substances?
Yeah, there is stuff moving forward, but frankly, it's election season. And so nothing is going to happen during election season. And it's going to depend very much on not only who's in the White House, but who's in the Congress, and government agencies have been limited in their power due to the Chevron decision about what kinds of restrictions can be put across. So I wish I could say I'm optimistic from a health point of view, but I'm realistic that it's not going to come soon, and they're probably, the research will be challenged because it's still early in knowing what people's exposures are, and measuring people's their exposures, and because cancer is a disease of long latency, seeing the impact on cancers may take a while. So that's really, it's, cross my fingers, what can I say? I will say, it reminded me of one other thing. During hurricanes, the releases of exposures are much higher. And so basically all bets are off because people will release and don't have the electrical control to not release things. And so they're all linked in some way. But I'm not allowed to say very much. I'm a state employee.
All right, thank you to our panel.
I want to introduce our next speaker, Brandy Verdon. She is going to be sharing, she's a stage 4 kidney cancer patient, and she's going to be sharing her story with us.
Hi, my name is Brandy Verdon. First of all, I want to say I'm a woman of faith. I'm a wife, a mom, and a BB to my granddaughter Sawyer. I was born and raised on the bayou in Terrebonne Parish. Our rich Cajun cuisine is second to none. Over time, I found ways to prepare healthy versions of our Cajun dishes because I developed a passion for fitness and nutrition. That passion led me to become a certified personal trainer and fitness nutrition specialist. My desire to live a healthy lifestyle led me to a deep dive on how to eliminate toxins from my household. It was my belief that my lifestyle would ensure a disease-free life. Never did I imagine at 47 years old, I would be in a predicament that would require me to be fighting for my life. On April 25th, 2023, my granddaughter Sawyer was born. The next day, I had an appointment to see a urologist because I was at the gym one day and I went to the restroom and I noticed bloody tissue in my urine. I met with the urologist the next day and he told me he suspected I might have kidney or bladder cancer. He assured me that it was treatable and I had nothing at all to worry about. It is my belief that the urologist felt confident to say those things to me because I looked like the portrait of health. My physical appearance was deceiving. On May 1st, 2023, I had a CT scan, and later in the afternoon, those results were posted to my patient portal. It was well after 5 p.m. I had just returned home from a relaxing facial, and I could not believe what I saw. My left kidney had a 14-centimeter tumor, and there was metastasis to both my right and left lungs. I had an appointment with a urologist the next day to go over the results. He told me there was nothing he could do for me, but he would send me to a surgeon in New Orleans at Ochsner who could possibly help me, and that surgeon is here today, Dr. Orcott. Over the next several days, I met with Dr. Orcott and the medical oncologist. While the medical professionals were building a team of oncologists to treat me, I was busy establishing a group of people who would pray for me. I knew in my heart the dual attack of prayer and modern medicine would give me the best chance to overcome this disease. I had a biopsy which confirmed the diagnosis of stage 4 clear cell renal cell carcinoma. In the meantime, my case was presented before the tumor board, and it was deemed that my tumor was inoperable. The medical oncologist created a treatment plan for me which consisted of Keytruda and Inleta. Before the start of treatment, my health declined tremendously and I was hospitalized due to low hemoglobin. I was given 2 pints of blood and then released after a 2-day hospital stay. Once I was released from the hospital, I experienced debilitating pain. Most days I would lie down on the floor and I would just moan and pray. There was no way I could work out at the gym. I nearly crawled into the gym to put my contract on hold while I continued to fight for my life. My prayer life and faith has been the greatest lifeline through all I've been through. After 2 months of treatment, I began to feel better, so I returned to the gym. I felt very well on Keytruda and Inleta and had no side effects. For 4 months, I received treatment, and it was then later determined that I had new metastasis near my urethra. In October of 2023, I had surgery to remove the tumor that was metastatic near my urethra, and then began new treatment, which was Cabometyx 60 milligram. 10 days into that treatment, I had terrible burns on my tongue, so the treatment was reduced to Cabometyx 40 milligram. On November 7th, I met with Dr. Orcott, and he told me I would probably never have surgery because the cancer in my body was really, really bad, and I probably would never survive surgery. I heard what he said, but I decided to trust God and remain in faith that one day I would have surgery. I had already envisioned myself walking down the hallway after surgery, and I held on to that vision as though I knew it would come to pass. In December of 2023, I had radiation to the site where the metastasis occurred. On January of 2024, I had a CT scan that confirmed the Cabometyx was indeed working. And then again, in April, I had another CT scan that confirmed the treatment was working, so the oncologist referred me back to the surgeon. On May 15, 2024, I had the surgery that I prayed for. Dr. Orcott removed my left kidney. He removed my left adrenal gland, 8 lymph nodes, repaired my inferior vena cava, and I had a total hysterectomy. The next morning, I was up walking that hallway. 4 weeks after surgery, I resumed Cabometyx 20 milligram. 10 weeks after surgery, I returned to the gym. I felt like I was on top of the world. It's like I had a brand new body. Unfortunately, at week 14 post-op, it was determined there were tumors on my bladder and possible invasion to my urethra. Currently, I am taking Afinitor and Levima and trusting God daily for extension of my life. In closing, I can't go without expressing how blessed I am to have an oncology team who cares for me. The other day, I was having a really bad day, and my medical oncologist called me and she said, I'm gonna need you to take a page out of your own playbook. What you were doing 6 months ago and a year ago, I need you to do that, and that's what's gonna keep you going. I was reminded to lean in on my faith and continue to trust God. It is my hope that my story helps to encourage every other person in here to keep going, never surrender, and to trust God. Thank y'all.
Welcome back, everybody. So this session, I'm very excited for this session. We have Lori Bombaco. She's a board-certified specialist on oncology and nutrition, working passionately in the field for almost 20 years. Lori most recently joined the Cancer Nutrition Care Team, a startup company with a mission to provide trustworthy and meaningful nutrition services for those affected by cancer. So I'm going to put that up for you and welcome you onto the stage.
You're welcome. A lot of people mispronounce my last name, my married name, and they'll say Bumbaco, but I remind them everything's about food. So it's like a taco, Bumbaco, that's right. So I just want to start by thanking JNF and KCA for inviting me to present. I really feel honored to be a part of the program and to learn alongside all of you today. I noticed that the audience has dwindled, but have no fear. I think they saved the best for last. And that's just my personal assumption. So I have an alphabet soup after my name. The most important part is the CSO. And as Anna Maria suggested, what that means is that I'm board certified as a specialist in oncology nutrition. I take my boards in November, so say some prayers for me. But I recertify every 5 years. This will be my 3rd time taking my boards. And so I find that that uniquely qualifies me. So if you're gonna work with a dietitian, try to find a CSO, okay? Less than 1% of practicing dietitians are board certified like I am. So I'm really proud to carry that distinction. All right, I have to use this?
Yes.
I can't like hit the arrows?
I did not prepare you, I apologize.
That's cool. I'll remember that. It's gonna go in the survey. All right, so typically I present for like over an hour. So this 20-minute time limit is going to be a challenge. I'm gonna move through rather quickly. I'm gonna coast over some of my content because our last speaker is presenting about symptoms and side effects, and I have a little bit of that in my presentation, so I'm gonna coast through that. But also when I present, I'm super casual, informal, and I like to engage the audience. So I want a little audience participation today. Is that okay? There's enough of you that we can manage this, right? All right, so thank you. Okay, so before I begin, just a quick disclaimer. I'm here to give you general guidance. I'm not here to substitute any professional medical advice that you receive. I'm not trying to diagnose you. I'm not trying to give you different decisions about how to treat your cancer. I'm here to just give you information, right? And especially with nutrition counseling, it's really based on individual patient circumstances, right? So what I'm giving you is generalized. So please keep that in mind as we go through my presentation. All right, so on my menu, thank you, Dr. Arcott, for that, because I'm going to borrow that. So this is my agenda, but I like menu better. It's more appropriate. All right, so I'm going to start with the value of nutrition counseling and cancer care. Why am I even here? Like, why does my job exist, right? It matters. And then when you're diagnosed, the most common question I get, what do I eat? So let's take some time on that today. And then I'm going to coast through the nutrition priorities. Really, this is about symptom management. If you want me to speak more about that, just give me like a little head nod or a little shake, and I will spend time on it. I'm from New Jersey, so I use my hands a lot. Sorry. And then I'm going to go through a handful of the most commonly asked questions that I receive, and then share some additional resources along the way. All right, so nutrition counseling. Why should a dietitian be on your interdisciplinary team? Great question. When you work with a dietitian, we can help minimize the risk for significant weight loss, as well as malnutrition. And I'm going to talk about malnutrition next, as it turns out that's vital in oncology care. We can also help to promote optimal nutrient intake while managing some of the symptoms and side effects that you might be experiencing. My favorite aspect of my job, I help improve quality of life. Love that part. Because if you agree with me, food is more than just nutrition, right? Food is social connection. Food is pleasure. And very often when someone is diagnosed, they lose that. And so I help to partner with them and bring back the pleasure of eating. And now for the job security of what I do. There's a lot of misinformation about diet and cancer. Do you agree? It's overwhelming, right? So this gives me job security, and much of my job description is doing just that, addressing that, helping people clarify that for themselves, and then also address any distress that they're having over something as simple as deciding what to eat. And then I help to improve your confidence so that you feel empowered that the food that you put into your body is the best it can possibly be. All right, so let's talk about malnutrition. I promised I would. Malnutrition is independently associated, or independently predicts outcomes, sorry. So what that means is no matter what your age is, I know age has come up a lot today, no matter what your socioeconomic status is, no matter what the stage of your cancer is, if you are malnourished, you will not do as well. What percentage of those diagnosed with kidney cancer have malnutrition? Anyone want to guess? I told you, I try to engage you. 10? I'm just kidding. So this is taken from data out of Europe, an estimated 50 to 80%. Is anyone surprised by that? I am, right? So at any point in time during the cancer continuum, someone may be malnourished or undernourished. Here's the problem with malnutrition. It's associated with a reduced risk for, or increasing the risk of infection, worse tolerance to treatment, interrupting treatment, and complications from surgery. And ultimately, we've known this for a long time, 20% of anyone who's been diagnosed with any type of cancer will not die from the cancer. They'll die from cancer cachexia. And that's a progressive disease, and good news there is a dietitian can help delay that or even prevent that from happening. All right, so what happens when you meet with a dietitian? We're gonna provide a unique and comprehensive assessment. We're not cookie cutter. We're not Google, right? We're gonna really tailor our recommendations to meet your specific needs. The goal is early and ongoing assessment for appropriate intervention. A proactive intervention is much more effective than a reactive one, especially in the setting of nutrition. Now, what we recommend is gonna depend on a lot of variables, mostly your treatment modality, the intention of your treatment, the presence of high blood pressure, and or the presence of any impaired kidney function. And we're gonna tailor our advice accordingly. Sometimes too, what I'll do is layer in some additional strategies with diet and lifestyle to reduce inflammation and or optimize metabolic and cardiovascular health. All right, so one of the most common questions I get, I've been diagnosed, tell me what to eat. I'm gonna summarize that with an acronym. The WFPBD. What the heck is that, Lori? The WFPBD. It's a whole food, plant-based diet. Have you heard of this? Very trendy, very popular. So what it does is it emphasizes fruits, vegetables, whole grains, legumes, nuts, and seeds. I saw some of you eating an apple. Well done. You're eating plant-based. And there's a lot of different ways to enjoy something like an apple, like a dehydrated version or an apple chip. Love them, right? Delicious. At the same time, we're gonna minimize consumption of highly processed food like sugar-sweetened beverages, as well as processed meat. So those are two food groups that I try to take away from the people I'm working with. It's important to point out that no single food or ingredient contains all of the essential nutrients we require. So we wanna think about consistency, and we wanna think about variety and the overall pattern of what we're eating. Now, this next slide I'm proud of. So try to stay here with me and like don't be blown out of the water with this amazing graphical work that I did here. All right, so I'm so proud. All right, so if we want to conceptualize what a plant-based diet looks like, let's think of this as our plate. So that's my pretend plate up there, okay? So half of the plate, I did that. Whoa. We want to fill it up with non-starchy vegetables and fruit. Half of the plate, right? Does that help with proportion? So if we sit down, and you get to decide, I can give you ideas, but you decide what choices you're going to make. And then a quarter of the plate we're going to use for our intact and whole grains, as well as our starchy vegetables like sweet potato, delicious. And then the remaining quarter of our plate is going to be for our protein sources. So not only from animal sources, but also plant proteins that tend to be kidney protective. So there's lots of different iterations of a plant-based diet. I'm going to talk about one in a moment. But you see on the blue colored plate, that's like a Mediterranean plate. And that's an example of a whole food plant-based diet choice. There's some salmon there, right? But hopefully what you notice is there's a lot of color and a lot of whole plant foods, right? So really delicious, easy ways for you to pursue this. All right, so why? Why a whole food plant-based diet? Two things come to mind. The first is phytochemicals. Has anyone heard of phytochemicals? Atta girl. I might call on you in a minute. All right, so how many phytochemicals are we aware of? How many have been cataloged? More than one, well done. There's at least 10,000. There's probably more. It's like, I call it like the Amazon jungle. Like there's a lot of things left to be discovered in there. Really promising information coming out about phytochemicals. Well, we've known about them for a while. So here are all the anti-cancer mechanisms that phytochemicals possess. I don't have enough time to go through all of them, but hopefully you're just as impressed as I am by them. It's preclinical data, so not the best data, but super compelling and worth your while. So trust me on this, we want to consume these foods. So what are phytochemicals? They are bioactive compounds, and they're found only in plant foods, and they're identified through their color, flavor, as well as aroma. So if you think of the burnt orange color of turmeric, that's curcumin. That's a phytochemical. Wow. If you think about the bitter flavor of something like arugula, that's isothiocyanates, phytochemical. If you think about the aroma of garlic, yum, those are organosulfur compounds, phytochemicals. Anna Marie, I'm going to ask on you to repronounce these words for me, okay? They are part of the plant's immune system. Here's what's really fascinating. When we ingest them, they transfer over to benefit our immune system. Really, really cool stuff here. And what is important to point out is that there's so many of them and they all exert different anti-cancer mechanisms, so we want to think like broad spectrum and try to consume like the rainbow. You hear a lot of dietitians say that. That's what we're referring to, is that you're going to obtain a lot of these different phytochemicals regularly. The other thing, I promised two things. The other thing that's so great about a WFP-BD is the fiber. How many Americans are eating recommended amounts of fiber? 10%. You are good. So I'm in that 10%. Who wants to join me? You, right? You had an apple today? We're getting there, right? So there are anti-cancer mechanisms to fiber as well. It supports our gut health, which in turn supports our immune function. It aids in blood sugar control as well as metabolic health, regulates inflammation, and of course promotes bowel regularity. So things like flax seeds, I would of course recommend ground flax seeds, but raspberries, did you know they're very high in fiber? As well as the whole family of beans and lentils. So each of these, a serving of each of these would be an excellent source of fiber for you and very easy to accomplish, all right? Now, I want to introduce you to a version of the whole food plant-based diet. It's called the DASH diet. Has anyone heard of that? You have heard of it. Amazing, good. So the DASH diet stands for Dietary Approaches to Stop Hypertension. It was developed actually a couple decades ago, and a dietitian was on the team. And this is an image of basically the targets that we're looking to accomplish on this way of eating. It's from the National Heart and Lung National Heart, Lung, and Blood Institute, which is a division of the NIH. And as I shared, it's not a diet per se, but it's a set of targets for us to try to eat these foods daily. So it's plant-based, right? There's a lot of whole grains, fruits, veggies, nuts, seeds, beans, and peas, and smaller amounts of animal food, so things like low-fat dairy, as well as our meat, poultry, and fish. So if you're eating a lot of those plant foods, guess what automatically happens? We eat less sodium, which is also a good thing for the kidneys. So typically it's reducing sodium intake to less than 2,300 milligrams per day. The research has shown that it has been effective at lowering blood pressure. Good to know, right? So here's some inspiration if you're looking for ideas for a whole food plant-based diet. So let's put it all together. These are just ideas I come up with off the top of my head. So avocado toast, oatmeal, scrambled eggs, maybe even scrambled tofu. Let's get crazy, right? But what we're doing is we're infusing some more plants here. So not just avocado toast, but maybe some herbs or some sliced tomato on top. Not just oatmeal, but some pumpkin seeds and some berries in there, right? We're infusing more nutrition, more fiber, more phytonutrients, okay? And we can also accomplish this at lunch and dinner and snacks. If I had more time, I would get into it. But here's some examples as well. Okay, all really delicious, all accessible foods. You might also look towards ethnic cuisine for some of their traditional dishes. They tend to be plant-based and super delicious too. All right, so this is the part I'm going to coast over unless the audience wants me to talk about it. So a lot of my time in clinic, I spend on nutrition impact symptoms. I do work in infusion, so I don't see a lot of oral chemos. Does anyone want me to talk about these? Weight changes, diarrhea, constipation, it's like a Pepto-Bismol commercial. Taste changes, fatigue. Do we want to, any questions? I'll keep moving. All right. Yeah, because we have a presenter that's going to help, I think, with a lot of this. So, and during the panel, you certainly can ask. So I'm going to just work my way through them, just for the sake of time and minimizing redundancy as well. A lot of what I do in clinic is work on some of these nutrition impact symptoms. So it's the majority of my time is spent there, and I think it's really important. I do want to point out about fatigue is that there's a research group that's come up with this fatigue reduction diet. So aptly named, right? And they have 2 studies that are out now and published. The first was a feasibility study with breast cancer survivors, and the second showed some effectiveness with reducing complaints of fatigue in lymphoma survivors. So can we generalize that information? I don't know, but maybe it's a matter of time before we see that some of these components to this diet might be effective. This research group is theorizing that it's inflammation that's to blame for contributing to fatigue. And so the diet itself is a whole food plant-based diet, but there's very intentional addition of antioxidant foods as well as omega-3 fats, which most Americans do not eat enough of. All right, so here are the commonly asked questions that I receive. I'm going to start with the one most common question I get asked every day, sometimes more than once a day. And it's been 10 years that I've been getting this question every single day. Does anyone want to guess what it is? Bingo. All right, so sugar. Does sugar feed cancer? Okay, so over 100 years ago, we learned about this really unique metabolism of a cancer cell and that it loves glucose. So novel discovery at the time, really fascinating, and we learned a lot, and we thought maybe we can exploit that mechanism and then withhold sugar from a cancer cell. That way we could starve a cancer, right? Well, since that time, we've learned a lot. We've learned a lot, so we want to keep that in mind too. And it's complicated. It's too complicated for me to get into today. But the gist of what we've learned is that cancer cells demonstrate what we call a metabolic flexibility. So what's the hallmark of a cancer cell? It adapts, right? It pivots. And so it will use other fuel sources and not just sugar, right? And so the thought is if we're not eating sugars or carbs, we can starve the cancer, but not so fast. What happens is metabolically, it will shift and pivot, and it can use other fuel sources like amino acids from our muscle and some of the fatty acids from our body stores, And if that's happening, we might lose weight, we might become malnourished, and we already know that that's a problem, right? So we don't want to lose out on all the cancer protective qualities of these high quality carbohydrates, right? So we never want to omit those choices. Now here's what I want you to know. I want you to know what I know, all right? So cutting out sugar, fine, go for it if you want to do it, right? But you don't have to fear that if you do eat sugar, it's making your cancer worse, okay? And if you want to leverage the power of nutrition, there are a lot of other ways you can do that above and beyond just cutting out sugar. So what we would recommend is that you adopt a lifestyle, and that may help you control your blood sugar and maybe more importantly, your blood insulin levels, and that seems to be more of the relationship and connection with cancer, and also reduce inflammation. And this is going to create much more significant impact rather than just cutting out sugars, right? And how can we do that? So we're going to consume a high fiber diet, like a whole food plant-based diet, balance our diet with high quality fats, high quality proteins, including those anti-inflammatory fats like omega-3s from fatty fish, walnuts, and flax seeds. And then, I don't do this often enough, but use those herbs and spices. They are like a phytochemical punch, right, that you can layer on top of your choices. Next question I get, which supplements should I take? So what percentage of patients that are diagnosed take a supplement? 50, good guess. It's super high, 80, and those are the people that report it, right? Now, of those 80%, the majority are taking more than one. And sometimes at my desk, I get duffel bags full of bottles of dietary supplements that I have to review. And I'm like, phew, it's gonna be a long day. Right, so here's what we know. Experts recommend that nutrition needs be met through food first and supplements second. Always keep that in mind. So there is no evidence that suggests that supplements are gonna prevent cancer or cure or treat our cancer, right? So we don't wanna rely on them for that reason. Here's what I want you to know beyond that. Dietary supplements are not regulated like prescriptions are, right? They're regarded by the regulatory agencies like food, right? So that's a little worrisome in my mind because they exist and they're available to us until there's a problem with them. And that's when they're removed from the market. Yikes, right? So I want you to practice the precautionary principle. And if you're using any dietary supplements, just discuss it with your healthcare team, please, right? Don't assume that they're natural, they're safe, right? There could be contraindications, there could be interactions with your prescription. If you've been taking them and you haven't told your healthcare provider yet, go share that information, all right? It never hurts to ask. Sometimes there are exceptions and sometimes there are indications for dietary supplements, okay? But I want you to know that based on your own individual circumstances. All right, next question, second to last one. Should I eat vegan? A vegan diet's great, right? A little restrictive, in my opinion, but it's actually, even though there's some misconceptions about it, it can definitely supply all of our micronutrients and macronutrients that we require in the diet, but it's conditional. So we can do that as long as we're eating mostly whole plant foods, right? So there's a lot of imitation vegan versions of foods on the market, right? And they're sort of highly processed. It's sort of like junk food. And I think the original version of a lot of those products are better for us, right? Now the jury's still out about whether or not a vegan diet is superior to what I've just described to you, which is a plant-based diet. We don't know yet. So what I would want you to know is that making any steps towards eating more whole plant foods is a step in a great direction for you. You can empower yourself and you can make some significant improvements in what you're eating. I would consider my fun, fancy, healthy plate as a template or a way to conceptualize doing this. And then as it relates to plant proteins, do keep in mind, we have a biological need for amino acids, not protein. So there's 9 essential amino acids that we require in the diet, and not all plant foods have all of them or sufficient amounts of them. So when I work with someone who's pursuing a vegan diet, we get very strategic about making sure they're eating the right amounts of amino acids, okay? And getting variety as well. All right, last question. Are there any concerns to worry about? And I'm so grateful in the last segment we started to talk about this, and that's the PFAs. So this is like the dietitian's take on what I heard in the last segment. They're man-made. They were developed in the 1940s, and it's basically carbon atoms with like a fluoride atom. And what happens is it creates such a strong bond that this was really desirable to people manufacturing it, in that it can resist things like oil stains, water, heat. So it's in like Scotch Guard, it's in our raincoats, it's actually found its way into our food supply, like microwavable popcorn. And that bond is so strong that there's no known way of breaking it apart, not in the environment or in our body. So this is why they're called forever chemicals, because nothing breaks them down. Wild, right? So they stay in the environment since the 1940s, as well as in our body for a very long time. Now the concern, and I don't have the reference for this, but I pulled it off of the NCI website, is that there are some studies that suggest there's a risk for kidney cancer, and probably the dose is the poison, so high levels of exposure of these PFAs, so good to know. Now, because they are forever chemicals, they have found their way into our food, our drinking water supply. So that's a main source of them. So here's what I want you to know, and what I learned today, like really added to this information. So in just April of this year, the EPA finalized drinking water standards to set legally enforceable MCL. So I don't know if that helps answer your question. So that's the maximum contamination limits. Now, I guess unfortunately time will tell if those can be enforceable, right? So I guess we need to make sure we get out and vote, is what I heard from that, right? And also, I guess there is a lot of work in this area. So a few years prior, there have been some of our government agencies that have partnered to try to research, regulate, and remediate this issue. Does anyone eat canned clams? Check the label. If they come from China, they've been found to have high levels of PFAs. Okay, so just source them differently if you can. That's what I would recommend, all right? And our public water systems have test results for PFAs. Did you know that? So where I live, every year we get our water report from our health department, and I look at it, it's a booklet, but it discloses what they detect in our water supply, so good to know. There also are some water filters that are certified to remove or reduce the PFAs in our drinking water. Good to know. So there's 3 filters: charcoal reverse osmosis systems, or ion exchange resins. Sounds really expensive. The EPA has a really amazing fact sheet. If you just Google EPA water filter, it'll walk you through the process of looking for those filters that are certified. When we buy them, we also have to maintain them. So keep that in mind as well, okay? So hopefully that will be helpful to add to that conversation. So in summary, just want to share that nutrition counseling with a registered dietitian can improve outcomes. It certainly is tailored to the unique needs of an individual. Undernutrition and malnutrition independently predict outcomes. Keep that in mind. Eating a whole food plant-based diet provides nutrient-dense foods, as well as the compounds that seem to exert some cancer protection promise. And with that, I thank you. And I just want to share, this is kind of my philosophy: where food is shared, happiness is doubled. Let's have dinner tonight. All right, thank you.
Thank you so much. Did anyone answer yes to the question about canned clams?
No.
Okay, because I just, you said that, and I'm like, that's a choice. That's a choice. It's a choice. Well, thank you. I won't sit here and judge canned clams too much longer. So next, I'd like to welcome up Kaylee, right? Kaylee Vincent. She is a licensed acupuncturist with over 8 years of hospital-based experience. She is currently over cancer strategy program for the current acupuncture, physical therapy, and therapeutic yoga providers at Ochsner Health. Kaylee, come on up.
Hi. I'm not the greatest public speaker, so I'll try to go very slow. My name is Kaylee. I'm an acupuncturist by trade. I helped establish the integrative program over at Osher back in 2020. And since then, we've kind of expanded our available services quite immensely. So what is integrative oncology? So what we try to do is make sure that it is a program within the health system that is patient-centered, it's evidence-based, helps utilize everybody's practice of how they treat their body, how the products they use affect them, lifestyle modifications to help reduce chances of recurrence of cancer and treatment while they're in cancer, alongside with their normal routine for like if they're getting active treatment, if they're getting radiation, we're not going to replace that. So the aims is to optimize your quality of life through treatment. We want to make sure that your outcomes are as positive as possible. We want to make sure we are around before, during, and after your cancer treatment so that we can help recover as much as possible. Okay, I gotta slow down. I'm sorry, guys. Okay, so the goals. We want to have the multidisciplinary approach. So we want to approach you as a whole person. We don't want to just focus on one aspect of your treatment. We want to make sure that you are actively moving, which I know we talked about that a lot today. We want to make sure that you're eating properly. We want to go over your supplements. We want to make sure you're treating yourself well and having your anxiety taken care of. Because of that, your whole mind and body, if you have a positive outlook to the treatment, you're more likely to have an easier treatment. So, where can we help? So, newly diagnosed is usually the most whirlwind for most of our patients. We have a huge anxiety and stress reduction. We do that with acupuncture, we do that with movement, we do that with Dr. Murray. We make sure that we have that access so that you are feeling confident going into the treatment. We make sure we target insomnia, because if you're not sleeping, you're not going to recover where you need to. Pain, especially newly diagnosed, we want to make sure that your body is actually being able to recover. We can target that pain with PT, with our occupational therapeutic yoga. We can do it with acupuncture. We can do it with general movement meditation classes. So during chemo, we like to make sure that we're able to treat your neuropathy if you get symptoms of neuropathy, nausea, vomiting, fatigue, chemo brain, which I don't think is actually studied yet, is it? It's just they're not sure, but I've seen it, I know it's real. Bone and joint pain, anticipatory anxiety, which we touched on a lot. Pre-surgery, we want to make sure that you are moving, we know where your baseline is, so we can get you as close to that as possible after. And then the same with radiation therapy. A lot of things can happen post-radiation that patients aren't aware of. We try to discuss that as much as possible and help curb those symptoms. Fatigue is the biggest one that I see, but there is some for like xerostomia for our head and neck patients, which doesn't apply here. So I pulled this off of the SIO so we can kind of see what integrative medicine can do to help with symptom control. So pain is statistically shown that acupuncture can help a lot with pain. Massage, we actually started integrating massage, oncology massage into our program as well, and it's been a huge benefit for the patients because one, they miss it when they think they can't do it anymore. So it's able to kind of get them moving and get that stress muscles out. And meditation. Meditation is extremely beneficial to patients to help kind of get their stress levels reduced. It's shown very, very much to have great, great support in that aspect. Fatigue, we all know movement is the best for fatigue. Even though you don't want to, when you're tired, it really does help. There's some great protocols with acupuncture as well that help with this. Insomnia, Tai Chi, yoga. We don't do CBT much, but it's something everybody can explore. Anxiety, and then of course the symptoms that are very, very common within chemo care, which is nausea, vomiting, neuropathy, dry mouth, and hot flashes. We have options for a lot of mind-body programs, which really including like meditation, yoga, Tai Chi, Qigong, all those type of classes, I would highly suggest getting into when you are going through your treatment. Art therapy, music therapy, all great options that we have within the system. Survivorship. So while I'm not as versed in this, because Dr. LePere, our integrative medicine doctor, is the one who kind of runs that whole program, she has been a great resource to help with patients who, during and post-treatment, to go through what different type of supplements you can take, new medications on the market that will help post, like breast cancer, for example. There's new things that can help with hot flashes if you're on aromatase inhibitors. It's just been a really great access to have, because patients can see her all through cancer care. So having a survivorship MD is a great connection to have. The debunk myths is my favorite part. So I cannot tell you how many times I get messages from providers with a list of Chinese herbs that people just order off Amazon and are taking all these things and don't know the contraindications of those with the active chemos they're taking. So some of them will completely negate your chemo. High doses of certain things that will clear your liver too fast and you're not getting the treatment you need. So we're able to kind of work together to make sure that you're getting the best benefit out of your cancer treatment. Oh, look at me so fast. Okay.
Well, that just means we have more time for the panel. So next, well, thank you for that. Integrative care is just very fascinating and I think needs to be talked about more in oncology for sure. Well, I don't even, okay, there it is, all right. Go to the next one. So next I would like to, our last speaker, I believe, of the day, Erin Pierce is a nurse practitioner specializing in Cancer for Ochsner Health and is the manager of Ochsner Health Center for Innovative Cancer Therapies program. She currently serves as a sub-investigator for over 100 clinical trials.
Hey y'all, my name is Erin and I'm a nurse practitioner. I actually worked with Dr. Matrana, who spoke with y'all earlier, for almost 8.5 years. So up until this past Friday. So I have been doing this for quite some time, specializing in genitourinary cancers. So this is definitely kind of my bread and butter. I think for me as a nurse practitioner, I'm maybe helping decide some of these treatment plans, but what I really find that we're the most experts at is side effect management. So I think this is what I do the most, and the most, I should say, counseling that I do with the patients. All right, disclosures. So I kind of think about when we're talking about kidney cancer, there's two different types of symptom management. One, of course, related to disease itself. You know, sometimes those that present initially that get the concern, so to speak, and then the ones that are actually caused by the treatment. So I'm going to go between the difference between the two. All right, so talking up first, hematuria, blood in the urine. I think this one, everybody pretty much it knows what it is. It affects a ton of patients when they are initially diagnosed. They think, oh, I have a urinary tract infection, or I need to drink more fluids, and then they're saying, oh, it's still going on. So definitely common. Pink or light red urine is okay. I think Rose on the front can say that people get very concerned about having blood in the urine. We definitely expect to have some, especially when you haven't even started treatment. And honestly, even going into treatment, people will have this. What we don't want is that dark, deep maroon color. We don't like that one. Then if we have clots, we really don't like it. So those would be probably the two that I would say, hey, talk to your provider about it. You want something? You want to add something, Ro? You look, oh, okay. You look like you want to throw something in. So of course, like I said, we're gonna rule out a UTI or a kidney stones, drinking plenty of water. And again, if those clots do develop, immediately let them know, and especially depending on how big the size. It is definitely an emergency when you cannot urinate any longer because the clots have essentially obstructed that. Moving next, I would say lower back or flank pain. Often it will be say that people are like, I can't reproduce it, it's a dull ache. Sometimes just changing positions, stretching, heating pad versus cold packs. I think some people work for one and some people like the other. Try a combination of the two to see what helps. Soaking in the tub, medications of course, such as over-the-counter versus narcotics. I will say a lot of times narcotics, it don't take away the pain completely. If you have a good renal function, most of the time I would think ibuprofen is your best bet because it really does help with that inflammation, whereas the narcotics just kind of mask the pain overall. Moving on, so we talked earlier about anorexia and explained weight loss. I can't tell you how many people will come in and be like, oh yeah, I lost 40 pounds within a month and a half, and I'm like, oh, were you trying to lose weight? And they're like, no. And I'm like, that's alarming. So this is one of the things that people just will say, hey, this weight is just falling off. I'm eating normal. I'm even eating more than I typically do. It just doesn't stick to me. And I mean, essentially cancer is robbing you of those nutrients and utilizing it for its own benefit. So definitely if you see something that, we need to go ahead and get on top of it as quickly as possible. Getting our nutrition, our dietitian team on, like immediately on this is so important. I feel very comfortable starting appetite stimulants to make sure, hey, if you're struggling to eat because of nausea or taste changes, let's put it in there and make you hungry. I often recommend patients, do some of the ones that are over the counter, prescription drugs that we use, including Marinol, which is a synthetic version of marijuana. But I also have patients who will say, hey, I'm gonna make myself some THC butter. I had a lady who did it. And every time she cooked, she'd put a little bit of that butter in on the bread, put in the chicken, and that helped her. So I think there's a lot of stigma around using these products, but when it comes to nausea and anorexia, it really is super beneficial. Venous thromboembolism or a blood clot is definitely something that people will see. So for instance, somebody will all of a sudden have leg swelling for no reason. They're in their 50s, they're active, they go to the emergency room, they get an ultrasound, they're like, you have a blood clot. And so they're like, well, why should I have this? So the workup begins, and lo and behold, this is something that they can determine. One thing that we really do have to be very, very careful about is the blood thinners for the blood clots can definitely have drug-to-drug interactions. So that just goes back to the point that Lori talked about earlier, having that accurate med list and giving every single possible thing that you use, whether it is from Amazon, Walgreens, the truck stop down the road. Like, we want to know it all because these all make a big difference. Fatigue. I probably think this is the biggest one that I hear in cancer in general across the board. When I'm consenting patients about treatment regimens and I'm discussing, hey, this might be a possibility, they literally look at me and go, Erin, I'm already tired. Like, I got it. But sometimes there is something we can do about it. It is a toxicity of some of those potential drugs that we'll talk about soon enough. But things that we're looking at is, are you dehydrated? Are you not sleeping well? Because those things really just go into this big old circle of how you're going to function on a day-to-day basis. Doing exercise. I also have to put out there psychological interventions. Are you depressed? You've been recently diagnosed, and this is a lot to take on. It's something that's keeping you up at night. You're worried about worrying your family members. So sometimes depression or anxiety does come across just as fatigue. Renal insufficiency, last one, I can't forget that one. Especially a lot of patients who may have already had a radical nephrectomy, had part of the kidney removed. This is something that they may have as a result, and it may never go back to normal. And like I tell my patients, that's okay. I don't need the kidney function at 100%, with your GFR. We can have a little bit of decrease. But being careful not to overtax whatever kidney that you do have left is super important. So non-caffeinated fluids, I know no one ever likes it. They want their coffee, they want their tea, but it is going to further dehydrate you. Monitoring their labs, so in case, hey, we're doing something and the kidney function's getting worse, we want to know what we're doing. Blood pressure and diabetes control. So those comorbidities that you may already be dealing with, having those optimized will most definitely make the kidney function better. And then, of course, avoiding nephrotic medications like NSAIDs, certain antibiotics, and as most of my patients know, contrast for imaging, because they'll be like, they tried to give me the contrast. I'm like, stick up for yourself. You're your best advocate. And then, of course, you may need, depending, limit protein or sodium intake. If someone is, their insufficiency has become chronic, this is something that they're not rebounding from, I usually like to get patients in with a nephrologist pretty quickly, just because I like to have that person in my court. Having an extra team member, I specialize in cancer, I don't specialize in the function of the kidney. So when you need somebody, you want to be able to phone a friend quickly. All right, so we're going to move on to treatment-related symptom management. So earlier, y'all talked about a ton of different modalities in RCC, whether it be surgery, radiation, pills like TKIs, a combination of TKIs with immunotherapy. It's a lot, right? There's a lot of awesome treatment options, and with that comes side effects. So sometimes it's something that we know what's going to happen. So for instance, with like a TKI and your VEGF inhibitors, I know immediately I'm going to be counseling patients on, hey, diarrhea is a possible that I would say be prepared for. So go ahead, buy your Lamodal, have it at your house, so that way if you need it, it's ready to go. It's almost like you just bring your little goodie bag. Take your prescription for Zofran, put it in there as well, and that's your emergency kit. Because let's be real, if symptoms develop, it's going to develop at 3 a.m. on a Saturday when the office is closed and you can't get in touch with anybody. So at least you have something already prepared to get you through that time. Hypertension, definitely a big one that we're going to talk about as well later on. But immunotherapy, for instance, you may have inflammation of any single thing in your body, from the top of the head all the way down to the tip of the toes. We've seen it all. Anything is possible. Some of the things that are more common would be endocrine, liver dysfunctions, maybe some GI like colitis or inflammation of the colon, and then skin with rashes. The thing I will say to you is that nobody gets them all. We can't predict which ones you're going to get. But the biggest, most important, if you get anything from this, is communication is key. Making sure that you are talking with your provider and letting them know what changes you are having from your baseline. I'm typically do a really, really good front, session with the patient when I'm counseling. Like, I want to know what your baseline is. Do you have a chronic cough already? Will that all of a sudden get worse? Just so you can have an idea. All right, moving on to specific symptoms. Nausea and vomiting, super common. I think any cancer patient should have a prescription, no matter what treatment they are receiving, for an anti-nausea medicine on hand, because you just don't know when it will pop up. Other things can cause nausea as well. Anxiety, GERD. So, in the back of your head, looking at those things. And antiemetics has drastically changed. You hear so many people who are still so terrified because they watched their grandmother go through chemo in the 90s. And, they were on the floor, vomiting, We're not like that anymore. And what I tell my patients is, if you are, you should have already called me, because that is definitely something that we can help, maybe not completely take away, but we can make it bearable. There's so many different new drugs. And the most, I will say, one of the ones that I give quite a lot is something called olanzapine. And I have patients who go, of course, and I tell them what it is, but sometimes they're not listening, and I'm like, this is an antipsychotic, that is not why I'm giving it to you, but they'll come back and be like, did you know what you gave me? And I'm like, yep, you weren't listening, but that's okay, I get it. If you even get 20% out of the visit, we're doing good. But it really does help, especially for those really, really, really nauseating regimens. I have a lot of patients too on lorazepam for anticipatory nausea. Patients who, me working at Ochsner, as soon as they turn on River Road, they'll say, Erin, I start getting nauseated. I just feel it coming. It's just programmed. And so that can be really helpful. Constipation and diarrhea. I will say a lot of times patients may have either one or another, but most people cycle through. And it's very frustrating, because that's one of those things, those bodily functions that we want to work, and we want it to work right and regularly, right? Everybody's kind of looking at me like, but you kind of have to play around, because what one thing is going to work for one patient isn't going to necessarily work for another. So what I tell people is that it's usually a trial and error. To let me know what's going on. I can give you some different recommendations. We might one day take this, and then the next day take something, and then do like an every other day to try to kind of keep the pendulum in the middle, so to speak. But anytime not having a bowel movement, I would usually say for longer than 3 days, definitely need to be notifying the providers. And of course, making sure that you're drinking lots of fluids as well. So I promised we would talk about hypertension, and this is probably one of my soapboxes. Before starting any type of TKI or oral targeted therapy, and if your blood pressure is not controlled, do not start it. These drugs we know is an on-target side effect. These will raise the blood pressure. It's often a good sign that the drug will actually be working, but I also don't want to give you a stroke. So I would say, hey, making sure that you're monitoring your blood pressure before and when starting therapy. I'm super blessed to have been able to help start a program where it was our home blood pressure monitoring for our patients with cancer at Ochsner. And so this was the reason, was because I was so tired of not being able to get the data I needed from patients, because they thought, I forgot it, which I get, we all forget. Or no, I'm not doing it. And I'm like, I'm holding your cancer therapy because of your blood pressure, and you didn't want to check it at home. So this way I would get it. But of course, making sure you're checking it, letting somebody know. It doesn't, if you have a cardiologist who prescribed it, good for you, go with it. But I kind of feel that if it's within something that I may potentially be causing, I'm fully equipped to go ahead and let's titrate your blood pressure medicines. If worse comes to worse, which has happened a couple of times throughout the years, I'm not an expert in cardiology. We have a fantastic cardio-oncologist who I can get patients in with pretty quickly and really can help optimize that CV. And of course, take your blood pressure medicines. That always helps. All right, treatment-related symptom management. Next one, hand-foot syndrome. Some people may know it as PPE. It's super common with our orals, and I see some heads shaking. I try, this is another one besides the diarrhea, that to say, hey, this is a possibility. Let's be more preventative if possible with this, because I feel that it's easier to be preventative than once it starts. It's really hard to control. You usually need at least a break from the drug. The great thing about these orals is that they have been studied with people taking breaks, and so they're still getting good results. So I also like to reinforce that to patients in the beginning that, hey, we may need to take some breaks from your treatment, and that's okay. You will still get good results. You know, in that way, because some people don't want to tell you the truth about side effects because they don't want you to take away the medicine. So doing that up front is helpful. But redness, swelling, pain, oh, I don't want to ever see blistering and peeling. I've seen it a few times and it looks miserable. But I say limit the use of hot waters of hands and feet. You know, no soaking for long periods of time in really hot water. Maybe, you know, I always think of them as the mama gloves because my mama always wore them when she was washing dishes, but like the yellow gloves, like, you know, so your hands aren't. So something like that. Making sure that you're not having a lot of rubbing on hands or feet from friction. So making sure you're wearing shoes. That's definitely helpful. Skincare. Make sure lotion, more lotion, and before you go to sleep, lotion and then put socks on or hand gloves on, depending. But that will be the best friend, is just keeping that moisturized. And then of course, not walking barefoot, especially when we have people who have comorbidities, especially like diabetes. You may not feel that something is going on down there. We don't need this major infection developing. All right, low blood counts, I'll just kind of briefly go over. Of course, we know any type of cancer therapy can go ahead and mess with our counts. So our biggest concern is febrile neutropenia. Thank goodness this is not typically something we see very often related to our orals. It's more our high-dose chemo, but I still like to warn people. All right, decreased appetite and altered taste sensation. Laura mentioned that I was going to be talking about this. Food just doesn't taste the same anymore. It's salty. I hear that one all the time. Or something, you know, they used to might have loved, like Aaron, I love me some red beans on a Monday. And then all of a sudden, you know, they're gagging because they can't handle the taste anymore. What I try to tell people is, one, of course I get my nutritionist involved. Two, sometimes you need to go ahead and try different things. Something you would have previously sworn that you hated now might taste good. They've completely changed. Another thing that one of our nutritionists had told me many years ago, and I still tell patients, is different sauces. So something sweet or something salty, teriyaki, find what works for you and then put it on the food that you are eating. So if that's teriyaki shrimp, it's teriyaki chicken, it's teriyaki steak, you know, like it doesn't matter. Nutrition is so important, and it's how your body is healing and recovering from all the medicines that we're giving you and putting you through, that I look at patients and I'm like, it's not an option, it's your job to eat, because you have to continue to do that if you want to fight. Mouth sores, definitely. I think we've all probably had canker sores before in our mouth. What I usually try to tell people is you be proactive with warm salt water rinses before, but if you do get one, go ahead, use Magic Mouthwash or Dukes. Elevated LFTs, which is something that we do see. Of course, if we see those, we might tell you, hey, right now, don't take Tylenol, of course, don't drink alcohol, and we might need to hold your oral medication or your IV or immunotherapy during this time. Chemo brain, it's real. 100, that's why I was smiling at you when you were doing this. My mom had breast cancer, went through chemo, radiation. She still claims 5 years later that she has it. But it's definitely real. Short-term memory issues, problems with word finding, difficulty with attention. Some people, for instance, like an example would be like, Aaron, I can't continuously find my phone. Like, it's just somewhere in the house. I need to put a beeper on it so that I can find it. You know I just used it 2 minutes ago, but you know, those types of things. It is not the same as somebody who, for instance, if the patient is looking at his wife and no longer knows her name, that is completely different. So regular exercise, hey, is there some depression or some anxiety here? Sleep problems, cognitive treatments. I think y'all heard from Dr. Murray earlier, and she's hysterical, so I like to send a lot of patients to her. Talking about that anxiety and depression, always, always bring it up and let your provider know what you're going through. There is no reason why, one, you should be embarrassed to talk about this. I would probably say 80 to 5, maybe even higher, 90% of my patients will talk with me about having some sort of depression or anxiety. I would too. That is normal. Let's normalize it. Let's get you help. Let's try to make life better, improve that quality of life. So whether it be through counseling, antidepressants, anti-anxiety medications, yoga, Tai Chi, massage therapy, you know, a little bit of anything, it goes a long way. All right, so adverse events. I'm just going to touch briefly on this, but essentially we do have an understanding about when AEs may develop depending on when the drugs you are taking. So it really just depends on the drug. So again, the thing that I want to focus most on is just making sure you're having that open communication and dialogue with your provider, because they are going to know, especially if you're on multiple drug regimens, hey, based on this timing of when this is starting, it is likely X versus Y, and then we can do something about that accordingly. So we also know that some of the drugs are more common with side effects. So our CTLA-4 inhibitors are typically, for example, the Yervoy, typically has more issues with colitis, diarrhea, hypophysitis, and adrenal insufficiency. Whereas our PD-1 and PD-L1 inhibitors, we should be looking more for the thyroiditis, type 1 diabetes, or pneumonitis. I will say anything is impossible in any of the drugs. So just because this is the more common ones doesn't mean you're completely safe and free. Risk factors for getting type of AEs. So there's been studies and more literature is coming out to say that depending on your demographics and social history, you may be at increased risk for having these types of AEs associated with immunotherapy, for example. So being less than 60, having a higher body mass index, women on CTLA-4, men on PD-L1 or PD-L1, chronic smokers, sarcopenia, and low muscle mass. A lot of times it's the combination of multiple factors together. Maybe it's not just one. But this is more data that is coming out, and research is kind of showing us who should we be watching more carefully. And wouldn't we want to be able to catch something more quickly instead of like letting it go and it turn it into something really big where then we're hospitalizing somebody. All right, so looking at the risk factors for those, in your medical history, that alone might tell us something. So for instance, those people with a pre-existing autoimmune disease, it's one of my standard questions that I ask patients, especially when starting any type of IO therapy. You will be more prone, and I'm gonna be more cautious about watching you getting labs, etc. Those individuals who have allergies, food, drug, or contrast related, do have the possibility of having the increased risk of immune-related adverse events in solid tumors. So for instance, kidney cancer. Interstitial lung diseases. So COPD, previous smokers, history of radiation. Those would people I'd be more concerned with pneumonitis or inflammation of the lungs. We talked about hypertension, CAD, heart failure, MIs. Those individuals are more prone to having cardiac-related AEs. I will say it is very rare. So inflammation of the heart muscle is a possibility. It's called myocarditis. Rare, but it can happen, and so we need to keep our eyes open. All right, so of all the things that I said, I will put out here, these symptoms can occur at any time. It does not matter. And in fact, with immunotherapies, even after you've stopped the drug and you're a year down the road, you can have an AE that develops. Do not ignore the symptoms. It doesn't matter how small or trivial you may think it is. Don't say, I'm gonna wait 2 weeks till I see Erin, because she's gonna ask me all those questions anyway. Do not wait. Immediately let your provider know. Do not wait for your next doctor's appointment, which I just said. And if you see other healthcare professionals, for instance, you are out of town on a vacation and you're going to the emergency room or the urgent care because of something developing, please immediately tell them what you are taking. All of my patients get a card where they have the name of their drugs. It has my name and Dr. Matrana's name on it, and then our contact information. So that way, hey, if you don't know those drugs, ER physician, which, hey, you might not, you know, you're not in cancer, and you know, you graduated from med school and, you know, your own fellowship 25 years ago when these drugs weren't around. Call us. We'd rather know. And I will say we have fantastic support services. I think, you know, Kaylee did a fantastic job about talking of some of these things. Integrative, acupuncture, massage, music therapy, counseling, art therapy. It's the outlet to get this, because we do realize going through all of these symptoms, having this burden is a lot for people to deal with. And somebody needs something, whether it's reading a good book or just for a moment to quiet the brain. Last but not least, I felt like I needed to put palliative care out there. I think people get really scared when they hear the name palliative, and they are immediately thinking, are you sending me to hospice? And I'm saying absolutely not. This is something, as you can see from at the very bottom, ASCO, our national guidelines, say that patients diagnosed with advanced cancer, early palliative care should begin within 8 weeks of diagnosis. Why? Let's try to be preventative. We don't want things to get worse, and it takes a whole lot more effort to pull you out of that. Let's make sure we're on top of it. You know, I always say I'm expert at giving you these drugs and knowing what the side effects will be. Treating those side effects, palliative care are the experts. They're fantastic. So anytime you get a chance to see one, definitely. It's increased quality of life surrounding it in research, increased survival, increased coping skills. So getting referred early is definitely a bonus. So I think probably I went over, so I took Kaylee's minutes that she didn't use. I was looking for a timer, but I didn't see one. But if you have any questions, let me know. Remember, it's one day at a time, one step at a time. And you know what? Some days, it's one breath at a time. But we're all in this together, and just remember, your treatment team is there to support you and really uplift you.
Hi, I'm the guy that lost 40 pounds that you were talking about. So first of all, I credit my oncologist for saving my life. I was in pretty bad shape last November, but from what I can tell here, he was pretty conservative around my diet and instructions he gave me. No alcohol, no red meat, no sugar, no pre-processed food, which was 100% of my diet. But I followed his instructions to the T, and I'm doing much, much better now. But I can't put the 40 pounds back on. And each hospital visit, I seem to lose another 5 to 10 pounds. I've stabilized now, but it's concerning that I can't I'm eating, you know, what you recommended. Did I understand right that not eating the sugar could potentially be hurting me in putting the weight back on? So that's kind of my first question. The no red meat, I've shared that with some of the other people in the forum that I'm on, and they think that's crazy. They've never heard that. They've never heard the no desserts and no sugar. So they think that's overboard. So that's first question. Then I'm taking Cabometyx, and I have many of the side effects that were mentioned. I'm not getting the mouth sores, but I can't eat anything spicy at all. And it's impossible to eat down here in New Orleans with no spice. I can't find it. So any secrets about that one?
I think a couple of us might be able to share some great questions. Thank you for sharing that. Do you have a dietitian you can work with? Do you have a dietitian you can work with?
I do.
Yeah.
I've talked to him. I think I'm following.
So what I presented was a general overview. I would not apply what I presented to your situation based on what you shared. I could offer you more specific guidance if I knew more about you, like blood work, other medications. You're on active treatment, it sounds like. So you are hypermetabolic, and you also are looking to gain some weight. So we want to consume a high-calorie diet. And so sometimes sugary foods are a great example of getting a lot of calories in a small amount. They're also not spicy, so they sound like there's something that you could tolerate. And the experts...
I always tell people boost shakes and put ice cream in it, like Bluebell legit, full fat, you know, the whole shebang, and have that. And that really does help.
Yeah, so what I didn't get to share, because Erin did a great job covering this, but when someone's not eating a lot or is losing weight, we recommend bang for buck. So where we find so meaning every bite, every sip you put into your body, make it count for as much as it can. I see the water bottle there, which is important for hydration, but that's a waste of time, because you can hydrate with shakes or smoothies that are going to give you precious calories, right? And then also, like, say, for example, you're having toast, could we get some peanut butter on that toast so that every bite counts for more?
With one kidney, is that problematic if I'm eating too much protein?
It really all depends. What I would do is ask if you probably have a team that are helping you, but also the dietitian to interpret your blood work to suggest if you require any other dietary restrictions. But generally speaking, for someone in your circumstances, the less diet restriction, the better, because that's taking food away from you that might otherwise be really important for you to consume right now.
If I start working out, is that impacting weight, or does that hurt or help?
No, I think I'd have to know more, but I actually encourage movement and activity. It improves our appetite. And you'd be surprised, we don't burn a lot of calories, right? Right, so maybe not.
I don't want you to become a marathon runner, but to lift weights, I think it's great actually. It helps with the mental aspect of things as well. What I typically, and of course I'm not a dietitian, but I often tell my patients, everything in balance. I don't want you eliminating any one food group out, because let's be real, that never works. So do I want you to eat a pecan pie at every meal? Probably not. I don't think your primary care doctor would like me saying that. You might develop diabetes. But I think what we're saying is, you know, sugar does not feed cancer, so to speak. And it is sometimes easier to get in that bang for your buck. I will often give a description to patients, you know, fruit. Everybody loves it, it's healthy, we love it, but if you need to gain 20 pounds, I don't want you eating a bowl of fruit. I would rather you have a cup of potato soup with full cream, you know, bacon, cheese. It'll fill you up just the same, but you're getting a whole lot more calorie and fat in there. So it's like really being thoughtful about what you're putting in.
And those shakes, the shakes that Erin mentioned are so convenient. There's a guarantee in a bottle, and they're not spicy. So, and there's a lot of products on the market. but they are a guarantee in terms of the amount of calories that you can easily manage. And I find that most people fill up on solid foods and less full on liquids. So sometimes liquids give bang for buck too.
Are there any other questions?
The spicy.
Yeah, so fats are high calorie, avocado, oils, and any oils that you want, they also coat the mouth. So sometimes I recommend people use something like even honey, which is coating the mouth too. And it's going to give you some relief in terms of the spice, or adding some fats to kind of cover the spice so that you can eat them.
Cooking at home, don't go out to like don't eat at fast food restaurants, which I know sometimes you can't avoid. You need, but typically if you play around, kind of you were talking about with like the herbals and the different type of things that we can cook with, sometimes that can help mask that spicy irritation. Sometimes, honestly, when times are tough and you have a lot of mouth sores, we might need to swish and spit or swish and swallow some Duke solution 15 minutes before you're eating so that way we can get the calories in. Sometimes that's the job. So, depending on what's going on.
I actually wanted to touch on something about his first part of the question. I'm the home cook. I've been cooking since I was 13 years old. I try to have a meal on the table every night. Red meat. I mean, Americans have turned it into the devil, and we barely have any red meat at this point. It's going to be pork. It's going to be chicken. Is it bad to have red meat in moderation? She is I can't have red meat. I can't have red meat. I'm like, which doctor told you that? So I just wanted to ask.
Processed meats are a different story. So that's bacon, that's a hot dog. I mean, there's no real redeemable nutritional qualities to a hot dog. Let's face it just tastes good, right? So that we should eat it for that reason, right? But in maybe the minority of the time, red meat has nutrition. So hopefully I should clarify my presentation. I don't want you to avoid red meat, right? Especially if your doctors are giving you the go-ahead to have red meat. And especially if you consider all of the other food choices you're having, right? So sometimes the opposite happens. People are so proud they're drinking their green tea and they're doing a green smoothie, but what else are they eating or not eating, right? So we want to put that into context, and a little bit of red meat goes a long way. It's delicious, and it provides us with precious protein and some valuable B vitamins and some other minerals. So I generally advocate for consuming red meat in context with other food choices. Okay.
No, I definitely agree. I'm like, do you like steak?
Me, I'm not a big fan of it.
Okay.
I'd rather have fish.
But if someone tells me like, Aaron, a big juicy steak, oh, I'm just dreaming about it. I'm salivating right now thinking about it. And you eat it and it tastes good, go for it.
Something good was had there. Yeah, both mind and body. But I think, that's up to you, and here's the thing. I am someone, I always share, I probably went into oncology for a reason. As a dietitian, I'm not very restrictive in what I recommend. But at the same time, we're the only ones that decide what to put into our body. And I would never take that power away from anyone. So I respect someone's decision to put into their body what they want to, right? So it becomes challenging when someone is providing all the food and maybe who they're caring for doesn't want to have those foods. So that's a good conversation, and there's some psychology involved there too. And I certainly help people navigate that as well.
Are there any other questions? No? At all? Okay. Yeah.
Well, comment maybe. Just remembering too that meat portion sizes are usually the size of the palm of your hand. We're so used to exaggerated portions that even when we look at what true serving sizes are, the palm of your hand is a good guesstimate when you're looking at the plateful portions. And if you stick to that size for a meat.
Oh yeah, having one carne asada taco as opposed to a steak.
Yeah.
But just for me it's the variety. You eat the same things all the time. It becomes boring. It does. Just have a little variety here and there.
I feel personally attacked because I'm a meal prepper, so I have like the same thing. And my son looks at me, he's like, how do you have that? I'm like, it's my ADHD brain. If I don't eat. So chicken all the time. You're like, it's like, come on, kid. All right, if we don't have any other questions, then I guess I will wrap it up and thank the panelists for Thank you everyone for coming. You can please complete the survey, the evaluation, and let us know how you liked this. This would be great, and thank you for coming.